Okay, I think we've just got some housekeeping as well. First technical hitch for the day. Okay, the exit procedures there for you, fire and evacuation. And rallying points and exits there. If you have any problems, if there are any problems during the day, we'll direct you where to go and where to congregate. And usual precautions for COVID and other infections. Okay, thanks very much. And it's my pleasure to invite Dr. Jeremy Wellwood, who's Executive Director of Princess Alexandra Hospital, Metro South Health, to officially welcome and open today's symposium. Jeremy's been a big supporter of the Hopkins Centre since he's been at PA, and we thank him very much for his ongoing support. Over to you, Jeremy.
Thanks, Tim, and thanks for the invitation to come and speak this morning. It's my very great privilege to open today's proceedings. I have had a lot to do since I've been here at the PA with Tim and Professor Kendall and the team from the Hopkins Centre, and they never fail to impress me. It's a great privilege to be able to speak to a group of people, not about waiting lists, not about budgets, and not about ambulance ramping. So thank you for that opportunity. Look, it's actually great to see so many different people here from different professions and different institutions and walks of life coming together with a singular goal, because really, I guess what I would encourage today is that we forget about all of the commotion that clouds us during our usual working week, and we focus in on the things that we do best, and that is trying to find meaningful answers to the questions that we have that make an impact in people's lives. And as Tim said, I have had a lot to do, particularly with the spinal cord injuries unit here at PA, but also the brain injuries unit. And I can see Nick there in terms of persistent pain. And when I think about the human face of the questions that you're all asking and are seeking answers to, we are looking at the human beings in our society that are often at their most vulnerable. And you all know that, but I have come to understand that. And, on behalf of the people that you serve and the health services and institutions that you work in, I really thank you from the bottom of my heart, because it takes a very special person to try to find the answers to the questions that we need. And the people that are going to be the beneficiaries of the discussions you have through the day today need people like you to be advocating for them. So thank you very much. I would like to also take the opportunity to thank the really important collaborators for this work. Obviously, Mace and the work that you do. We're very grateful for that support. But NISQ and all of the teams that work together to bring this on. I was having a look through the work that the Hopkins Centre has done over the last couple of years, and it's an impressive track record that you have. As since about 2017, Metro South Health have been really, really proud, and certainly here at the PA, very proud to be at the centre of the work that the Hopkins Centre does. And, you know, when I look at, you know, over 100 clinician members, nearly 100, you know, research clinicians, $8 million in research funding, like nearly 400 publications. I mean, this is in the last 2 years. It's a really impressive piece of work. And I certainly, speaking on behalf of Metro South, that we're really committed to grow this research and to grow the impact that we're having in the community. And the philosophy of the Hopkins Centre, which you all know, is very much in lockstep with the feelings we have here at the PA, connecting human beings together. You know, whether it's people with lived experience, or whether it's clinicians working in the field, or whether it's experienced researchers. That connection is really very powerful. And I think the other key part of the philosophy, which is really, you know, working from the ground up, if you like, you know, what's actually meaningful in practice, and then bubbling that up to, you know, to develop, you know, programs of research that can be supported by health services and institutions and other funding bodies. But by doing that, it really ensures that it is something that will have impact, you know, at the coalface and for the people that we're serving. So look, I really hope you have a wonderful day today. Welcome here to the PA campus. I would like to, you know, give a shout out to the leadership of Professor Elizabeth Kendall and Professor Tim Garrity. I think, you know, we're very, very lucky to have that sort of leadership here. And I guess with no further ado, I would like to, you know, officially open today's proceedings. I wish you well, and I'm looking forward to hearing the outcomes and how we, you know, particularly here in Metro South and the PA, can support this even more and more into the future. So thank you and have a wonderful day. Thanks, Tim.
Thank you very much, Jeremy. And obviously, Metro South PA Hospital has been core to the Hopkins Centre since we first started. We are incredibly grateful for the support and the partnership that we've had with Metro South over those years, and we certainly hope and look forward to ongoing partnership in the future. Our other incredibly important supporter and funder over all of that time has been the Motor Accident Insurance Commission, and we would not have been able to do most of what we have done without the support of MACE. And it's my pleasure to ask Mr. Neil Singleton, the Insurance Commissioner, to come and say a few words as well. Thanks very much, Neil.
Good morning, everyone. I'd like to start acknowledging the traditional owners of the land on which we meet, pay respects to elders past, present and emerging. Sadly, First Peoples are overrepresented in the Queensland road toll and in road trauma statistics, and it is a big part of our commitment to helping reduce the effect of road trauma on First Peoples, and we've been particularly interested in doing research through the Hopkins Centre in that respect. So I thank Tim and Elizabeth for the work and your team have been doing in that regard. Thank you to Tim, Tamara and Louise for the invitation to come today. As Tim said, our funding started at pretty close to the commencement of Hopkins, but our relationship with Tim and with Elizabeth Kendall goes back well beyond that. So I think with Elizabeth, we go back to 1997, the relationship with MACE. And I think the strength of that relationship and the enduring relationship just adds to the importance of how MACE and Hopkins are working together. I think, as many of you may know, at the start of 2025, the funding for Hopkins will transition from MACE to the National Entry Insurance Scheme Queensland. MACE focuses on the Queensland road trauma coming out of the CTP scheme. NISQ is a lifetime care scheme for people who are seriously injured, either on the road or in the workplace. We fund or we support the claims on behalf of WorkCover and self-insurers. I think the disability focus that Hopkins bring is quite logical to partner with NISQ in terms of how we can help improve the lives of people who are unfortunately very seriously injured, whether it's through a spinal cord injury or traumatic brain injury or other serious injury. So we're looking forward to a very positive, constructive future between Hopkins and NISQ. I think the focus of today, collaborative research, is just so important. Not only are we proud of the work that happens within Hopkins and the amazing research and a lot of the presentations we're going to hear today, but I think from a Queensland perspective, encouraging collaboration across research centres, across the hospital systems, the more we can collaborate with a Queensland focus, the better outcomes we can deliver for Queensland road users. Hopkins is going to be an important part of the broader relationship we have with the Queensland Brain Injury Collaboration. NISQ is the core funder for the Cubic, and we want to see more of our funding channeled through Cubic so we get a more stronger focus on brain injury, rehabilitation and treatment. Likewise, in the spinal injury space, we have a significant number of partnerships with Griffith University, the James St John research that was got a lot of publicity the other day, Biospine with Dinesh Palapana, as well as the work that happens through Hopkins. Mace was the original funder for the ABI TRS for the first 5 years of its establishment here, and it's fantastic to see Arity and the team now continue that as an embedded service out of Metro South. So I think the opportunity space continues. I think we've got a track record of proving that we can fund initiatives, fund pilot programs, fund research that will lead to better outcomes. And I just encourage everyone, please stay focused. Please make a difference in terms of what we can do for the lives of seriously injured people. And thank you again, Tim, for this wonderful invitation, and best for the symposium and for the day ahead. Thank you.
Thanks very much, Neil, and we certainly look forward to working more closely with NISQ in the future, but I'm sure we will continue to have great contact and support and partnership with Mace as well. So moving on to our invited speaker this morning, our keynote speaker, Professor David Berlowitz. I've known David for a long time. We won't specify exactly how long, but and it's great to have David presenting today. Sleep is a relatively new sort of area of focus for Hopkins, and it actually came up originally through some feedback that we received from consumers and people with disability, that this was an area that was important to them, and the way that sleep impacted on the rest of their lives and on their rehabilitation. We had done some work in the past with David and his team on a clinical trial, and there's a renewal of that partnership happening at the moment, I would say. So it's great to have David here. One of our new seed grants is also on sleep. So there's a building reconnection, I think. So Professor David Berlowitz is a physiotherapist by training with the Victorian Respiratory Support Service, who holds the University of Melbourne Chair in Physiotherapy at Austin Health. David and his collaborators, students and staff examine the causes and treatments of sleep and breathing disorders in neuromuscular disease, especially spinal cord injury and motor neurone disease. But his research encompasses respiratory physiology, sleep, health systems research, implementation science, health data analysis, machine learning, and clinical trials and therapies and care models. I asked David to speak on the topic of, are we underestimating the importance of sleep disorders in rehabilitation and the lived experience of people with disability. Thank you, David.
Thank you very much, Tim, for the invite, and to the Hopkins Centre and Elizabeth Kendall and all of you for having me here. I would like to start by acknowledging that most of the work I'm talking about has been done on the lands of the Wurundjeri people from where I hail, and I'd like to acknowledge their elders and their continuous relationship with the land. I'd also like to start by acknowledging that most of this work is not mine. Marnie Greco, Dr. Marnie Greco, who works with me as an implementation scientist, who's really taken the lead in a lot of the data I'll present today. So what I'm going to do, I think it's always nice to know where we're going, is cover these areas. So let's just get straight into it. And I'm going to talk about sleep, what sleep is, a little bit of refresher for some people, so I apologise if you know this, sleep disruption and sleep loss and their impact. So we sleep for a quarter to a third of our lives, and sleep is an incredibly complex physiological and psychological process that is intrinsic to health. Back in the 50s, where you could do these experiments, they completely sleep deprived, and they shouldn't have, but completely sleep deprived multiple animals who all eventually died of overwhelming sepsis. We can't live without sleep. It's a fundamental human need. Sleep is divided into two kind of chunks. So I'm going to define those acronyms that I'll use. So there's REM sleep, rapid eye movement sleep. And then there's everything else, which is called non-REM sleep. So non-REM sleep includes stage 1 and 2, which is that going in and out of sleep that many of us experience, where you're more rousable, where you're dozing on the plane, those kind of things. Stage 3 sleep, N3, is slow wave sleep, restorative sleep. It's the stuff that makes you feel better the next day. During those periods, your basal metabolic rate drops, your carbon dioxide level goes up, your brain has a bit of a timeout, and it's rest and recovery, and as I say, it's restorative. Non-REM sleep, however, is entirely different. During non-REM sleep, every one of us is tetraplegic. The only two skeletal muscles we've got working are, well, only two sets of muscles we've got working are our diaphragm. All of our other accessory muscles of breathing drop out, and our eye movements, because our eyes twitch. And that's when you can look at your dog and see them twitching away. They're remming, they're chasing rabbits. That's when we dream. And sleep is organized so that most of the REM occurs at the end of your sleep period, which is why when you sleep in on Saturday morning, you're more likely to remember your dreams if you're one of those people that remember your dreams. The other thing about REM sleep is you get massive bursts in autonomic activity, particularly sympathetic activities, and your brain is actually more active in terms of glucose metabolism during sleep than it is during wakefulness. So an incredibly, incredibly important element. And the last thing in terms of background is that N3 sleep, that slow wave sleep. That's where we consolidate skills, and to a lesser extent, or not as clearly defined as when we consolidate and manipulate memory. So in the rehabilitation context, that restorative sleep is incredibly important to get. So I thought I'd start with some patient and staff experience of sleep in a rehabilitation context. That seemed like a good place to start for this talk. This is a nice little study from South Australia, qualitative study, in a subacute kind of rehab, slow stream sort of rehab context. Participants in this study were not those who had stroke, but all other kind of slow stream rehab sort of people. So, the clinicians in the audience will get a sense of this. Less than half of them slept like they did at home. It took them all longer to go to sleep, and particular, the environmental impacts on the quality of their sleep were large and persistent, and to some extent non-modifiable. And interestingly, particularly night staff reported good understanding of sleep hygiene, but really they had no power to modify it. The structural environment meant that all of these very well known and well described barriers were unable to be modified realistically. Occasionally there'd be a sleep zealot amongst the staff, and they'd do their best, and then it would grind them down. During sleep, the well-described disruptions are light, and we know about especially blue light in terms of being on your devices. And as we remove televisions and get everybody to look at an iPad instead, that's worse. It moves your circadian phase, delays circadian phase, blue light at the before sleep. So it's not only kind of arousing, but it also progressively shifts you, which is why after a week in hospital, nobody wants to start rehab before midday. Noise, social, procedural impacts. And then, of course, there's all the endogenous kind of reasons why you can't sleep. You may well be in hospital because you're in pain. And we know that pain and sleep are bidirectional, and I'm not really talking about it in great detail today, but emerging evidence, really quite nice evidence, is really strongly showing that the direction is more that bad sleep gives you worse pain rather than the other way around, which is, I think, many people's intuitive thoughts. And then, of course, there's all the sleep disorders that you come in with, and in many cases get worse once you land in hospital. So I'm going to talk about those in a minute. But first, in terms of how we measure it, so sleepiness can be thought of as both state and trait. So state sleepiness is how terrible, how a little bit more sleepy I am today than I was yesterday because Tim took me to a really nice restaurant for dinner last night. So it's that immediate fluctuation from day to day. And that's typically measured with something like the Karolinska Sleepiness Scale that asks you to rate on a Likert scale where you are at midday today. The Epworth Sleepiness Scale and scales like that are more about trait sleepiness. They're about your baseline, your chronic level of sleepiness, and they help us with thinking about things like accident risk in transport workers, those kind of things. And that gets into that tray. And so it's important to unpack those two elements because day-to-day variance is just that. I'm sure there are neuropsychologists and psychologists in the room, so I am not. But a lot of the research, in fact, the stuff we did with Tim had neuropsychological outcomes as our primary outcome measure for the studies. But sleep deprivation and loss particularly impairs executive function, attention and working memory. And so really it's not so surprising that it impacts learning during rehabilitation. And particularly it's very easy to demonstrate impairments in memory, decision-making, attention, especially vigilance, and processing speed and reaction time. And then of course there are the associated intellectual mood and personality changes associated with being sleep deprived, having sleep loss. Anybody who's had children knows what I'm talking about. So I'm now going to talk about sleep disorders, kind of the primary ones that are worth going over, I think. And so I'm a respiratory physio. I'm not a rehab physio. I have a short attention span. I can't do rehab. So this is kind of my bread and butter, which is upper airway physiological dysfunction and sleep disordered breathing. So just for clarity here, you lie on your back, you go to sleep, good air goes in, bad air goes out, it's all great. Simple snoring is exactly that. It's a vibration of the back of your tongue in particular that generates noise that you hear as snoring. And this is, worse worse as you get older. The prevalence is lower in premenopausal women, but then catches up, although women are massively underrepresented in the research because they present differently with sleepiness and don't present with it as a problem. And then there's obstructive sleep apnea, where usually the the back of your tongue, your genioglossus falls against the back of your throat and obstructs. And then you make deeper and deeper breaths until you mechanically force your airway open. When that occurs, you might transition from a deeper stage to sleep to a lighter stage of sleep. But in the battle between sleep and breathing, sleep always wins. So over time, you tend to downregulate your arousal responses. And so you don't wake consciously, but you fragment your sleep, which gives rise to daytime sleepiness. CPAP is an Australian invention. A respiratory physician and physiologist, Colin Sullivan, and his engineering mate, Mike Birkin-Jones, many years ago at the RPA in Sydney, invented CPAP when they were trying to do a physiology experiment. They were looking at very obese men who kept falling asleep and obstructing their upper airway, and they wanted to see what was going on with the tongue. So they blew a vacuum cleaner in reverse down their nose, which is all CPAP is. It's a dynamic internal splint that holds your throat open. And then with normal ventilatory drive, you just breathe over the top of that. So the pressure doesn't get transmitted beyond your upper airway. It does change your end expiratory lung volume. So you for the first like 10 breaths or so for most people, you can tell you're breathing at a slightly higher volume. When I try and swim, I sink. So I have to do this all the time. I have to keep air in my lungs to not sink. It's that same kind of sensation. And that's what it looks like, although it never looks that pretty when you're asleep on CPAP. Okay, the next thing I want to touch on is a thing called periodic leg movements of sleep, which are quite common and quite disruptive. So this is a sleep study. This is the EEG. These are the leg EMGs. This is ventilation, and this is heart rate. And this is what a PLM is. So this is an EEG sitting on, usually on tibialis anterior. So this is a very stereotypical, very rhythmic discharge. It's typically in your legs, but it can be in your arms. And it comes from your substantia nigra. So we treat this with dopaminergic agents. And that's probably how it progresses with time. You get a reduction in dopamine production with normal aging. And so PLMS becomes more common as people get older. Now, there's an associated disorder which is called restless leg syndrome. Restless leg syndrome is different in that it is a clinical diagnosis based on symptom, signs, and clinical characteristics. You can only diagnose PLMS on polysomnography. About 80% of those with restless legs do have PLMS, but it doesn't overlap completely. Now, again, I will defer to my neuropsychological colleagues, but I have gone for Roth, so, you know, kind of one of the three godfathers of sleep medicine, for the definition, working definition here of insomnia. It includes all of these things. So difficulty falling asleep is sleep onset insomnia. Staying asleep is sleep maintenance insomnia. And also this idea of simply non-restorative sleep. It's not there because you're sleep restricted by circumstance. It's there despite the opportunity. It makes you feel bad during the day. And it lasts for at least a month and happens at least 3 times a week. So it's not just a bad night. It is a persistent problem. All right. And I appreciate I'm going quickly, but I'm trying to kind of scoot us into the main business. So now we're talking about 3 neuro rehab kind of examples and how sleep impacts. So stroke is the best studied of all of this. And again, Bassetti was the first person really to well characterize increases in obstructive sleep apnea after stroke. This is from a European Respiratory Journal evidence synthesis. And stroke and sleep disorders are really difficult to unpack. Like many things with sleep, there's a bidirectional association. And so if we're talking about stroke, we have to make the distinction about stroke where sleep disordered breathing and other sleep disorders are a risk factor for incident stroke, and then also the consequence of stroke on subsequent sleep disorders. Because the chicken and the egg are both trying to cross the road at the same time. So we know that severe sleep disordered breathing doubles the risk of stroke, of incident stroke. But in fact, in some population cohorts, particularly in elderly people, a mild degree of obstructive sleep apnea, so exposure to chronic intermittent hypoxia is protective against all cardiovascular mortality. So there's a paradox there about dose. Treatment of sleep disordered breathing might reduce the risk of stroke in patients only if they're really adherent. So it's not the process of giving CPAP, it's the process of giving enough CPAP. And again, arguably, perhaps we need to restrict it every now and then to give them the beneficial effect of mild OSA. Insomnia, we don't know. But we do know that treatment of insomnia with benzodiazepines and other similar sedating agents is an independent risk factor for stroke. PLMs, RLMS doesn't seem to matter, and so we can't talk about treatment. So in terms of stroke outcomes, untreated OSA after a stroke increases the risk of recurrence and might increase long-term mortality. And CPAP is certainly feasible in stroke, but man, it's hard. And it might improve outcome. The outcome data is not clear. It doesn't do things like, make the penumbra resolve quicker or any of those kind of things. We have no evidence for that. Insomnia, we just don't know in terms of stroke outcomes. And restless leg syndrome might be associated with a worse outcome, perhaps because the restless legs are almost like a manifestation of the consequence of the stroke, rather than being truly independent. And if we look at Hassan's in 21, meta-analysed all of the kind of population prevalence estimates that we can get here for these four sleep disorders, going from the left on all of them of acute to subacute and chronic. And really, you can see for most of them, it doesn't matter much. It doesn't change over time in terms of the prevalence. This is mild sleep apnea, and it stays the same. And maybe with the eye of faith, you might think moderate to severe decreases over time, but it's not super compelling. And there are fewer studies down this end than there are up this end, which also confounds interpretation. So it probably doesn't change much, the prevalence of these sleep disorders after stroke. But having it before stroke, having any of them before stroke is probably important, particularly obstructive sleep apnea. If we skip now to TBI, what TBI seems to do is massively disrupt sleep architecture. So this is a really nice forest plot and meta-analysis, and I apologise, but I'm kind of going to assume that most people know how to read these forest plots. The things you've got to see are these big blobs here, these big quadrilaterals. If they're over this side, not having a TBI is favoured, whereas here TBI is not. Generally speaking, people with TBI have shorter and far less efficient sleep. They have well and truly delayed sleep onset. And once they are asleep, they have more WASO, wake after sleep onset. So their sleep is more fragmented. And specifically, sleep efficiency is massively impaired. Sleep latency is longer. REM sleep latency is maybe shorter. So maybe people, again, have this fundamental disruption, but as you can see, the confidence intervals cross zero. Total sleep time is shorter and wake is longer. In patients with a history of TBI, sleep disturbance is clearly associated with impairment of body functions, seems to be associated with a prolongation of post-traumatic amnesia and a slowing of recovery of consciousness. And there are specific impairments of cognition, affective disorders, fatigue, and pain. This is a nice comparative study between like a case controlled match study from a large group of a large sample of people with TBI, where they're matched for the degree of obstructive sleep apnea, whether they have sleep apnea, yes or no, at least of moderate severity. And you can see where it impacts. The Ray Adult Verbal Learning Task is a really nice non-motor task that picks up memory delay, both short and prolonged, retained, and the PVT, which is quite different between the groups, is the performance vigilance task. You have to press buttons in response to a dot on the screen. And the Ds down the right-hand side there, they're the Cohen effect sizes. So they're quite large, the differences between the two groups. So untreated OSA in TBI is almost certainly a problem for memory and thus for skill acquisition and retention. Now, this is my PhD, so I apologise that you have to look at my 5 years of my life in one slide, but this is some of the work that Tim and others from up here were associated with. So I did an incidence cohort as part of my PhD, and I looked at every new person with tetraplegia who came into the spinal cord injury service in Melbourne and followed them out for 1 year. Now, based on questionnaires, maybe 10% of them had sleep apnea before their injury. And in fact, one person in my cohort fell asleep at the wheel and had a single vehicle accident, so may well have acquired his spinal cord injury from untreated OSA in the first place. But as soon as I could really do sleep studies, I did some in ICU, but when we could really do sleep studies at 2 weeks, 2/3 of the sample had at least moderate sleep apnea. And that increased slightly at 1 month. It peaked at 83%. So 4 out of 5 people with acute tetraplegia had sleep apnea. And then it got slightly less bad. People tend to lose weight in the second of the first 6 months post-spinal cord injury before they then put it back on, sort of coming out and from 2 years onwards. This is some of Marnie's work, which of course I said I was going to draw heavily on. Marnie recently, that's chopped it off, but it's 2023, meta-analysed all of the population prevalence data for sleep disordered breathing in spinal cord injury, in tetraplegia rather. And so at least mild disease is present in about 84% of the community living population with tetraplegia. This is the range of the non-injured population estimates. So at the most, it's about 38% of the general population, which is clearly quite different. If we go to more severe disease, then the prevalence comes down, but it's still well over half of people living with tetraplegia who have at least moderate sleep disordered breathing. And you can see that the sample for the able body moves a long way to the left. And in fact, we don't know what the severity of, with any real certainty, what the severity of sleep disordered breathing is in the general population. But it's still over 1/3 of people with tetraplegia. So this is an AHI of greater than 30, which means you're having more than 30 events an hour. So every 2 minutes, your brain is being woken and your saturation is probably down in the 60s or 70s. It's probably not good for you. So sleep disordered breathing in tetraplegia is different to other neurotrauma and brain injury in that tetraplegia causes sleep apnea. It's actually the only model of incident sleep apnea we know in humans. Everybody else kind of gets it as we get a bit bigger and older. And other associated risk factors. It's actually obstructive sleep apnea. It's not central sleep apnea. It's well and truly the predominant type. It's not a disorder of ventilatory control. It's a failure of upper airway. We know from that study and work we did that it is associated with substantial daytime sleepiness, neurocognitive impairment, and quite profound reductions in quality of life. If you look at a health utility score for somebody with at least moderate sleep disordered breathing who has tetraplegia, it's at about 0.23. So that is a massive reduction in health utility. Major depression with suicidal ideation sits at about 0.42. So this is a scale from 0 to 1, where 1 is perfect health, 0 is death, and you can actually have a health state of where you perceive it as worse than death. So this is a very impactful health status disorder. We can improve sleepiness by treating sleep disordered breathing in acute tetraplegia. That was the study that we partnered with up here, but we showed no change in cognitive function, which was actually our primary outcome measure. What we did demonstrate is that cognitive function is massively impaired immediately after spinal cord injury, even when we excluded everybody with a Glasgow Coma scale of less than 8. So it's not just that they also hit their head. It's probably what emerged years later that isolated injury to the cord can give rise to generalized CNS inflammation. And that resolved spontaneously by the same amount in both groups. But over the 3 months of the trial, the change was the same amount in the PASAT, our primary outcome measure, the Paced Auditory Serial Addition Task, which tests attention and information processing. It's very sensitive to sleep disruption. It changes by the same amount that you see in somebody with multiple sclerosis, with or without frontal plaques. So the cognitive impairment that you get secondary to an isolated spinal cord injury is very large. But nobody gets diagnosed. In all of the population studies that are there, barely 15 to 20% of people living with tetraplegia in particular, and we suspect also with paraplegia, ever get asked about their sleep during their medical reviews or other reviews with any other health professional, and they don't go on to get treated. Periodic leg movements are also incredibly common after spinal cord injury lesions. There are 2 motor pools that drive PLMs. The primary one is in the substantia nigra, but there is one in the kind of motor bulb down the bottom of your cord. And the lack of descending inhibition associated with spinal cord injury seems to release this they essentially just function as pacemaker cells without any descending inhibition. So the prevalence is up around 60%. And in fact, it goes through REM, where we don't see it in the non-injured population, because as I said, our skeletal system is quiescent. And in fact, you can record it during wake. And it's not the only thing that goes wrong with your sleep. You get permanent jet lag if you have a lesion above T6. So the pathway for your pineal to produce melatonin is really dumb. Light hits the back of your eye and goes to your superior chiasmic nucleus, but it doesn't just scoot across here. It travels down with your sympathetics. So if people have sympathetic interruption at all, they lose their circadian phase. So normal circadian phase looks like this. You know, melatonin goes up at night. That's why we get sleepy and go and fall off to sleep. And then light suppresses melatonin production. As you age, it drops. And so this profile in people with thoracic lesions looks like, somebody in their 80s kind of thing, where the amplitude is small, but the phasic characteristics are there. It's dead flat in people with cervical lesions. So they are permanently out of phase. So when Tim asked me to do this talk and gave me that title, it's like, yeah, Fred. So I've given you a lot of background to come to a really, really obvious conclusion, and I apologize for that. But what I'm going to do now is try and lean in slightly to the theme of today, which is about, okay, so that's bad. Please don't engage in therapeutic nihilism. Think about what we can do differently. So the first thing that's really important, I think, is to understand this principle, but also to do your homework and to understand the data really well. He never said this. It's attributed to Einstein only after his death. It, in fact, comes from a feminist author called Rita Mae Brown, who had one of the characters in her book, Sudden Death, use the phrase, and somehow it's been misattributed. It's really important to go back to the source material before we decide what to do next. So this again is Marty's work, and an example of a way in which one might seek to challenge the status quo about it's all just too hard. There's no time in outpatients to ask anybody about their sleep. I'm worried about their pressure injury, their risk of a pressure injury. So this was a study that was run at Royal Rehab in New South Wales. After Marnie presented a couple of times some of her previous data showing these real barriers to access and uptake, Julie Pryor and oh my God, I forgot his name. It's fallen out of my head. Jared Webber. That's very embarrassing. And for some reason, he's not listed on the paper there. So I made a mistake as well. Came up and asked, can we do something about it? So you've seen this already. It's a big problem. But some of the work that had been done by our group previously had shown that this typical model of calling in respiratory or sleep as a consultant just pretty much doesn't work. Like I work in a sleep unit that houses the respiratory failure unit and the sleep lab, so and the spinal service. So we've got hoists in the roof of our sleep lab, and we still can't get people in there. It's too disruptive to their days. The sleep scientists are well exposed, but it's still a really difficult thing to do. The barriers to access and uptake are enormous, and they've been well characterized now. So Marnie went and got a fellowship to travel to 3 different spinal units that she'd identified around the world who were doing this differently, and synthesized the ways in which they were doing that work. So went to the source and then proposed a model based on that. So the idea, as you can see there, was to adapt, implement, and evaluate a similar model. Marnie's an implementation scientist, I think I mentioned. So we don't try and do any practice change without wrapping a really strong theoretical and evaluation framework around it first. It's very easy to get enthusiastic and that person leaves and it all falls away. So there was a model of care adaptation process, as you can imagine, to identify governance, find the right people, build flow charts that were for process that were well adapted to the local environment. Then implement it. So this is Jack Ross, one of our spinal physios, coming up and clearly during one of those times, providing education for the folk at Royal Rehab. And it was implemented in 2022 for 12 months with a quantitative and qualitative analysis. So this was done during inpatient rehabilitation, screened about 48 people, half of whom were assessed for OSA, 12 were diagnosed and recommended treatment, and 10 of those actually got treated. 4 of them, it didn't happen until after they left. Really importantly, there was specialist respiratory physician engagement. So David Joffe from Royal North Shore provided we had an algorithmic approach to screen out really the primary almost contraindication for CPAP, which is hypoventilation. If somebody underbreathes, you can theoretically make it worse by providing them with CPAP, where they will then underbreathe more because their upper airway is well controlled and they sleep through the arousals that were waking them up and protecting them from type 2 ventilatory failure. It's more of a theoretical concern. It appears in the literature, but when you drill into the literature, it's there because of case finding, really, of severe untreated for many years that turns up. You can see the enablers, but it didn't happen. That's the other important thing. But we had systems in place. You can see the enablers here, and then the barriers. Who knew that you couldn't get sterilisation of masks done at a standalone rehab service? So all of these kind of typical implementation barriers, and some related to the workload, but particularly to staff turnover. However, that was the evaluation of this process, but the project was by no means a failure. They subsequently tweaked the model and have continued to provide care. So I want to propose that I'm going to stop now, so there's time for questions, because everybody always likes to ask questions about sleep. Or at least I hope you do. I would like to propose that, we have an opportunity to think much more boldly about how we manage sleep disorders particularly during subacute and kind of chronic rehabilitation, and particularly for neuro rehabilitation. I do think there's place perhaps during acute for comprehensive screening and for consideration of ongoing management. And there's some real low-hanging fruit here, not flutes, around things like circadian management and the way in which we organise care. There are some very simple things that we could do that, if well evaluated, would be translatable and able to be implemented into clinical practice. But I do think that not all of the elements of screening and care and other things need to happen necessarily in the same temporal space. I think the impairments in neurocognitive performance may mean that there are other things that need to be worried about earlier, and that the sleep stuff can't be ignored, but also it's important, not urgent. It's that kind of consideration. I also think that there's a real role for much more co-design in particularly discrete choice experiments around various ways to skin the cat. So a mandibular advancement splint, for example, is a type of treatment for sleep apnea that kind of pulls your jaw forward. It's a bit like a mouthguard on steroids. And it tends to make obstructive sleep apnea less severe, but it's better able to be tolerated, as in used over time typically, than CPAP, which many people struggle with. So perhaps the area under the curve of the resolution of the chronic intermittent hypoxia might be just as important as complete resolution for 3 nights out of 7. And that's where I'm going to stop. Thank you very much.
Thank you very much, David. Very interesting and challenging presentation. We do have some time for questions, and we'll need to get a microphone to you so that the people online, let alone the people in the room, can hear properly. So any questions for David?
Thank you. Thank you for such a great presentation. While watching that and thinking about the patients that you're working with, I'm wondering if you encounter many issues with people misusing medications or using other substances to try to ineffectively manage their sleep problems.
Yeah, of course. If you've got a problem, you'll fix it. And if that involves sedating medications or, dope's the obvious one, marijuana use in to self-manage kind of fatigue, but also sort of ennui associated with your new life is very common. And it's not necessarily bad, dare I say, but we don't have any data about it. That's the important thing. What we do have data about is benzodiazepines. They're a disaster. They increase fall rates in older people. They do interrupt sleep architecture, and yeah, they're particularly bad in stroke.
Thank you very much for an incredibly interesting presentation. And I just wanted to ask one question, because you were mostly focusing on spinal cord injuries, and I was just interested in the ABRs in terms of those mostly obstructive or central sleep apneas.
Yeah, so it's not clear really where central versus obstructive sits in TBI. That's your question, isn't it? Yeah. I don't know that it's been unpacked in the same way, and it's complicated as well, because it's not like you only have one or the other. Unless you have chronic congestive heart failure and you have chain stokes, and even then, if you've got some impairments of ejection fraction during sleep, you will tend to have some obstructive events as well. You get caudal redistribution of fluid to your upper airway. When you're lying down, all that blood, all that fluid's got to go somewhere, and it tends to go up here. And so if you've already got a bit of a bigger neck, it can make the hole in the donut smaller and you collapse. But where you do definitely see central sleep apnea is during the acute phase. So when somebody's acutely injured, they will frequently have very disordered ventilatory control, which does seem to resolve. But whether it's a primary problem, whether it's an epiphenomenon associated with, with the brain injury per se, I'm not aware of any data that really unpacks that completely.
Yes.
Apologies, just to coordinate interpreters. Doctor, thank you for your presentation. It's very interesting. My name's Sean. Obviously, I'm deaf. I'm a community advocate. I wasn't aware that sleep disorders had such a bad effect on people, but I know that mental health is a massive sensory issue now, and that affects sleep as well. I'm just curious if the effects on people who are constantly tired from mental health affects this sleep disorder as well. Is it an actual sleep disorder, or is it just a side effect of, say, coming out of COVID, not having an active lifestyle? A lot of deaf people that I know have sleep apnea because they don't have physically active lives. And we can't use things like music to help us sleep and other parts of breathing techniques that people tend to use to help them sleep. So I'm wondering if there's any correlation with mental health and coming out of a non-active lifestyle to sleep disorders.
Thank you, Sean. Great question. I obviously couldn't deal with every one of the causes of sleep disorders, which is why I pruned them down to that. Certainly, depression and insomnia in particular are intimately associated. Other mental health disorders, there are sleep disorders associated with the treatment for those as well. Changes in arousal state from various medications, which can then manifest as changes in daytime sleepiness. And the environmental factors that you talked about, weight gain, having a sedentary, more sedentary lifestyle, a lack of exposure to exercise, particularly at the right time of day from a sleep point of view, right being in inverted commas. So I did leave mental health disorders out. The data are not as clear. They're associative data, and there's not a lot of kind of, I do this and then it goes away kind of treatment data, which means that it's not as clear what the impact would be, I think is fair to say. But thanks, great question.
Hello. I wanted to ask, I'm from NISQ and I work in a team that is working with participants that have just discharged from hospital and setting up their community supports. Do you find that GPs are sort of across this, or is it something that we should perhaps be pushing more for review of? Because I find a lot of participants are sort of just given melatonin, and there are a number of issues impacting on their sleep, and sometimes we're not sure of the best person to refer to, whether it could be a psychiatrist or a sleep clinic specialist, and sometimes that's not always feasible. And we need to somehow get data on how is their sleep being impacted, and sometimes they don't even know how to tell us. I was just wondering if you had any advice there.
So the Sleep Health Foundation understands the challenges with sleep knowledge in primary care. It's enormous. I was actually, I was at the Gold Coast last week. So I flew back to Melbourne on Saturday and came up yesterday, contributing substantially to my carbon footprint. But there was some data presented, in fact, about an audit of all of the medical schools, well, the medical schools that participated in the audit around Australia and New Zealand. At best, during medical training, people maybe get 4 to 6 hours worth of exposure to sleep and sleep disorders. So it's not a large part of the curriculum. The curriculum is massively squeezed. It requires this is the first stage of an active campaign to increase education, particularly in primary care. There are mechanisms by which primary care can partner with specialist care around sleep. So, and they can get money from Medicare for engaging through different mechanisms, I believe. But yeah, this is a really common problem. And melatonin in Australia is weird as well, because we can't. So when I go to the US, I just stock up on 3 milligrams from a drugstore, which I take to manage my sleep, my jet lag, because there's Cochrane level evidence about how to use melatonin to make jet lag last for less long, which I can explain when I've had some coffee. But it's in Australia, you can't get kind of 3 milligrams of melatonin apart from a compounding pharmacist. It's classified as a food by the FDA. So we tend to get people prescribed the long-acting M1, M2 agonist form of melatonin, which is much more potent. So many people get hangovers from it, essentially. And we did do a small randomized controlled crossover trial of 3 milligram in spinal cord injury. And one of the primary things we found was that even with what is quite a small dose, most of the participants had a hangover. So you only get a sedative effect from melatonin when you're circadian out of phase. So if I take melatonin now, when I'm trying to, climb in my arousal state, I get a sedative effect. I get sleepy about 20 to 40 minutes later. But if I take melatonin when I'm trying to go off to sleep, it's imperceptible. You can't feel it. So you have to have it when you're out of phase. Those graphs I showed you that were bumps, you have to take it during the nadir to get the major effect, which is why it's so good in spinal cord injury, because they were always flat. So they get a sedative effect. Yeah, the way in which we manage melatonin in Australia is a bit weird. It's a bit out of step with the rest of the world. But yes, the primary question, I think, around education is a known deficit, and people far cleverer than me are trying to address it.
So I'm just going to take chair's privilege and ask one final question, which kind of follows on from that. you've spoken about the way we might do things better in a rehabilitation inpatient setting. But what about all of the people in the community now who have undiagnosed sleep apnea or other sleep disorders, which are really impacting on their everyday life?
So that would be the grant that Tim and Marnie have in, which is to, think about, following on from that Royal Rehab, think about how we might do this in spinal review clinics. It's about an awareness raising process, but it's also, I think, about establishing and testing care pathways and providing people like, primary care, partnering with primary care to at least get it on the radar. That's the biggest problem we have at the moment, is it's just not on the radar. When we survey most spinal clinicians, it's just not something they ask about. They will respond. And so the other part of this is, of course, awareness raising within the community of people living with disorders, but it doesn't pop up. It really doesn't pop up as a first line problem.
Thank you very much, David. Can I ask everyone to thank David? Great. Now, we're coming up towards morning tea, but before we do that, we've got a very important session, and I'm going to ask Professor Elizabeth Kendall, who's the Executive Director of Griffith Inclusive Futures and Director of Partnerships and Innovation for the Hopkins Centre, to come and take us through this session. Thanks, Elizabeth.
Thanks, everyone. And thank you, David. It's always lovely to hear you and how well you know that topic. Such an important topic. As Tim said, I'm Elizabeth Kendall. I was the director of the Hopkins Centre. And what often happens when they put you out to pasture is that you get called back in to do the fun things. So it's really good. And they take over the things that aren't so much fun. So I get to do two really fun things before morning tea today. And first of all, I want to introduce to you a very good colleague of the Hopkins Centre, Belinda Adams, OAM. And Belinda has been on our Ambassadors Council for some time, but she's taken the extraordinary step of writing a book about her experience with her son, Dylan. And a little while ago, we started a book club, thanks to Moretta, who's sitting up there. And it's astounded me how important these books are. They're people who've taken the time to think deeply about their experience and then put that into words for other people to learn from and to reflect on themselves. And as a fellow carer of someone who went through the brain injury system here at the PA, I really enjoyed the book and it made me tear up multiple times. So it's a great event to be able to launch this book or pre-launch this book, because there is another launch which you'll see information about in your kit. So I'm going to hand over to Belinda to talk to you about her book, and I hope you all go out and buy a copy straight away. And then I'll be back to do my second fun thing. I think I did the wrong thing already. There's a chapter called I'm Awkward. How do I go back? Yeah, what do I click to learn? There we go. Okay, sorry about that. So my name is Belinda Adams and I'm a mother, a carer, a filmmaker and an ambassador for the Hopkins Centre. I Bought a Bus is the story of my family's journey through brain injury and beyond.
What is fear? March 14, 2012, my 19-year-old son Dylan dropped me at the airport. I was going on a holiday to visit my family in my hometown of Broken Hill. When I disembarked the plane, I was given the news that Dylan had been in a horrific accident and had been placed in an induced coma with a severe head injury. Sorry. I was stranded in Broken Hill. I couldn't get another flight out till the following morning. I've never felt so helpless or afraid in my entire life. When I finally made it to Dylan's bedside the following day, I knew I had two choices on how I could deal with this nightmare we had found ourselves in. I could descend into fear, or I could hold the vision of Dylan healing and try to be a beacon of hope when it seemed there was none. 2 weeks later, Dylan was finally brought out of his induced coma and transferred to the neuro ward, a very different young man to the one who had kissed me goodbye at the airport weeks earlier. The days were long, so I tried to create adventures for us in the hospital grounds to keep him entertained. Starbucks was a favourite. We'd usually start down there and we would create a world for ourselves every single day. We would pretend we were flying somewhere and we were overseas, and we would create different personas, and I'm not sure if that was probably the right thing to do when he was trying to remember who he was, but it kept him occupied and entertained for the day. Always a fan of superheroes, Dylan took on the persona of Iron Man at this time. I later asked him why Iron Man. He said, Tony Stark built the Iron Man suit to protect himself when he was being held captive and used it to escape. He tried to escape here many, many times. He had to be fitted with an alarmed bracelet in the neuro ward. When Dylan was ready to go to rehab, there were no beds available. He was stuck in limbo at a critical time of his recovery. He would eventually go to Biru. After 6 weeks working with amazing clinicians and therapists, he finally came home, but he felt like his old life no longer fit. My old life no longer fit either. Oh, sorry, went back to front. My trauma caught up with me. I had been running on adrenaline so long in fight or flight that my body shut down. I couldn't read, I couldn't remember things, and I could no longer do my job. A psychologist finally put into words what I was feeling: ambiguous grief. I was grieving the loss of who my son was before his life was irrevocably changed. I also grieved for the time I lost with my other 2 kids at pivotal times in their lives, as I felt like I ceased to exist to them, and for the loss of their childhood innocence. I needed to help Dylan find his path forward. He had tried numerous jobs post-brain injury, but none had worked out. We fought to gain access to disability services, which was no easy feat, as he did not tick the boxes on the forms. He eventually gained access and started a new career, right here at the PA hospital. He'd come full circle. First, he received life-saving care here, and second, he found a new purpose in a supportive environment, and he moved forward in leaps and bounds. Can I go back? Where's this one? Oh, yeah. Sorry. Thank you. I woke up one morning and I had had a very vivid dream of this magic bus. It looked like the magic school bus. So I went out and bought a bus. But in order to bring this vision to life, I needed to earn more money. I was still working casual. I'd gone back to working casual at a law firm. And I had to find a way to earn money quick. So I took a job working on a seismic exploration crew in remote locations all over Australia, a complete fish out of water. There were a lot of challenging aspects to this job, but it also gave me an overwhelming sense of freedom travelling the country with a mobile crew. I realised it was the first time in my adult life that I didn't have to care for anyone. That did make me feel slightly guilty, but it was a great time of healing for me. I returned with enough money saved to fulfil my vision, and in July 2017, I hit the road on Belinda's big bus tour for brain injury awareness. As I drove around the country, people came out to meet me or contacted me asking me to come to their community so they could share their stories with someone who understood their journey. The trip highlighted the need for programs and resources, so I began researching the connection between the arts and health. In 2019, after 2 years working in seismic, I finally got the break I'd been dreaming of when I was offered a job on a feature film, ironically called Buckley's Chance, a childhood dream come true for me. At the same time, Dylan's dream of becoming a father came true. He is now a loving father of 2. Also at this time, I was asked to join the Hopkins Centre Ambassador Council. This synchronistic timing enabled me to bring together my 2 greatest passions, arts and health. I was able to undertake more formal research when my new company, Citrine Sun Entertainment, partnered with Griffith University, the Hopkins Centre and Queensland Ballet to collaboratively bring ballet for brain injury to life. Being an emerging filmmaker, I captured the program on film. Our short film made the finals for the World Health Organization's Health Film Festival in 2022. And last month, it screened at the United Nations General Assembly Arts Festival at Carnegie Hall. Film is such a powerful tool. It enables real people to share their stories with the world. And stories have the power to shape who we are and impact society. When we connect emotionally with a character on screen, it can shift viewpoints. So who is telling the stories is really important. In March 2012, I was told this is going to be a long journey. I have come to understand that it is a lifelong journey. So we need to change the narrative around brain injury. The daily impacts often depend on stressors in the individual's life and environment. Equity in access to support and connection is needed for all brain injury survivors, so we can alleviate some of the stressors that brain injury survivors and so they can live with dignity and thrive. This will also lessen some of the burden placed on unpaid carers who often won't ask for help because they are protecting the dignity of the one they care for. The need for research and rehabilitation is vital. That's why I will be donating $1 from every book sold to brain injury research. I want to thank the Hopkins Centre for offering me the opportunity to speak today and for their ongoing support. And thank you all for listening.
Thank you everyone for listening, and thank you, Belinda, for that amazing effort that you put into writing that book. It's not a small thing to write a book, and to write an emotional book is even harder and more important for those who are reading it. So thank you very much for doing it. Belinda is no shrinking violet, as you probably noticed, and it really brings home to us how important our families are in the research that we're doing, but also in the rehabilitation that we're providing. And they're a resource that we need to draw on much more effectively. So thank you. I get to do my second thing quickly before morning tea. Then you have about 30 minutes and you have to be back in here by 11. So the next thing that I want to achieve is to launch our Inclusive Futures research writing competition. And I just want to first of all acknowledge Delina Amsters, who's the continual champion, there she is up there, continual champion of easy English. If there's, and also I'd like to acknowledge Joe Keck Parmenter, who does a lot of our easy language translations of our work and makes things available to everyone. One of the things that we are really proud of at the Hopkins Centre is that we're trying as hard as we can to engage people with disability in our work as heavily as possible from the beginning. So we have people with disability operating at all levels of the Hopkins Centre, governance through to specific projects. And one of the things that stops people participating fully is jargon. Now today, October the 23rd, ironically, and I don't think Makala knew this when she set this date, it's Drop the Jargon Day. How appropriate is that? So it's a really important day. It's to recognise the fact that in the health system particularly, but also in legal systems and other systems, jargon prevents people from being fully active in that engagement. So we're launching a competition where all you have to do is write about your research by the 22nd of November in about 800 or so words of very plain English that tells us about your research, and it's going to be accessible to everyone. Now, this is really important. We have also been asked by the Disabilities Department in Queensland to do something similar, to make research more available. And I think this applies not just to consumers. It's really important for everyone. I recall writing an article, a series of articles called Rehab Review a little while ago, and there were 6,000 clinicians would read that. And all it did was made research accessible. So I think we as researchers have to stop and think about how inaccessible our work is and how can we make that difference so that it's used more effectively. So by the 22nd of November, 800 words on your research and you could take home $500. Thank you, everyone. Thanks. Morning tea now. So if I could just remind you to be back by 11 o'clock. Thanks, everyone. Should I turn that off, Tim? Oh, okay.
Well, good morning, everyone. I'm hoping you've had your upshot of coffee or caffeine or whatever your vice is and something lovely to eat. And I'd like to welcome you back to the next session of the BIBS Symposium today. My name is Louise Gustafsson and I'm Program Lead of the Enabling Technologies and Environment stream, also affectionately known as Program 2 at the Hopkins Centre. I have the great honour of guiding us through the session just before lunch and the session just after lunch. We kind of were able to very neatly distribute the presentations into our main two streams. So the first one today is going to be the Enabling Technologies stream that we're going to talk about today. So I think in the interest of time and to keep us moving, I would like to invite our first speakers to make their way across. And I would like to introduce Mr. Matthew McShane and Dr. Camilla Shirota, who are going to co-present on their, I did not move along, on their topic that we affectionately call the BIBS ADLs project.
Thanks, Louise, for the introduction, and I'll let Matt get started.
Cool. Thank you. So this is our Visualizing ADLs program. It's about finding ways we can enhance the home modification program using 3D visualization technologies. It's a proof of concept study to develop a prototyping tool. And our main goal is to enhance collaboration between all parties and stakeholders in this process, from the users to builders and contractors, therapists and their family and supports. Cool. So we're lucky enough to have a large project team. So we've got a wide variety of people from different backgrounds. We've got engineers, designers, clinicians with experience in home modification process. We've got people with lived experience of home modification process. And also a unique aspect was our design team of gamers and a different language for us. So that was really cool to bring in. We also had a few different reference groups. So end users, people with lived experience of the home modification process, as well as therapists and clinicians that have years and years of experience in that field of home modification. So we decided with our reference groups to capture 3 different personas of spinal cord injury. So the next one.
Oh. Yep.
Yeah, so persona 1 is a power chair user that might require to support people for their ADLs of transfers, that might require different spatial requirements within the home. Persona 2 was another power chair user that might just require, say, 1 support person and potentially less spatial requirements within the home. And then persona 3 was a manual chair user, potentially independent transfers that might not require as much space within the home. So the ADLs we decided to capture were bed transfers, so to and from the bed, toilet and showering sequences, navigating hallways and tight corridors and doors, and then just circulation space. So we thought these 4 ADLs would capture most of the important activities within the home, as well as things that would require more work and investigation in terms of spatial requirements for modifications.
Thanks, Matt. So just talking a little bit about our trajectory and experience getting to where we are now, it was really important to us to do authentic movement capture. So rather than having able-bodied people kind of acting as people with a disability, to actually have the people, the wheelchair users, do the acting themselves. So we tried a few different types of technologies to do that capture. We started with the one that was maybe the easiest one to set up, which is based on video. So it's essentially we have a video camera that's going on, the computer is looking for a body, and then it kind of tracks that movement in space and over time. It's, despite being very easy to use, it's one of the newest kids on the block, so it has lots of issues and not many workarounds. And so one of the problems that we had with it is that it is expecting the person's feet to be in contact with the ground a lot of the time, which means that sometimes it worked really well. So as you can see there on the left, Matt is in the chair and there's a little avatar, but sometimes it can go catastrophically wrong. And that's most of the time. And so that would take way too much of our time to fix it. So we kind of skipped that one. Our next best trial is called an IMU suit. So IMU stands for Inertial Measurement Unit. Those are little sensors that capture movement. And the way it works is you put them in specific parts of your body. You can see there a time lapse of Danny, one of our researchers, putting it on. And based on knowing where the different sensors are in the movement it tracks, we can rebuild that movement in the computer. We also have different sensors like the one there at the bottom. So little pucks that we borrowed from a VR system that we can put in objects to track them. For example, we put them on wheelchairs so we could track where the wheelchair was moving. Another problem with this, it's the second newest kid on the block. So the IMU suit requires people to be standing to calibrate the system, which of course is not possible in our case for our actors who are wheelchair users. So the way we went around that is finding somebody that has a body shape that's similar to our actor to put it on, calibrate, and then we transfer it to the person in the wheelchair. And I don't know if you saw very briefly, we can watch what the avatar is doing in real time so we can adjust the sensors and put them in the right places. So we went into people's homes, 3 different actors, and we had them do those activities of daily living. And these are samples of what we've been able to reconstruct so far. So the first one that you see on the left is our manual wheelchair persona who's doing a going down a corridor and turning through a door. And some of the things that we can do is we can change the walls. So first you saw a see-through wall. This is what a real setting would look like. And then you can also see that we can take the wall away. We can also do different camera angles. So from the top, at the top video, you can see close-up, so we can get close to locations where we think there might be issues, or it might be very narrow, or as Matt calls them, danger zones. And at the bottom, you can see that we can play around with room layout. So we have a carer with a person in a wheelchair, and you'll see that sorry, that should have been running, that the wall moves in and out, so we can see how much space people need next to their bed to be able to transfer in and out of their bed. So obviously, we would like to advocate for more authentic movement capture, meaning technology can catch up and allow us to do that better and easier. So looking at technologies and algorithms to accommodate for that, which means just making different assumptions. And in a bigger picture, we see this being part of our home to hospital project, which we've been working on for a few years. This is the immerse and modify bit, but as you can see, there are lots of different bits and pieces that we still need to work on that we hope to do in the near future. And that's us. Thank you.
Well, that set a very good standard for keeping to time. No pressure for anyone that follows. Don't go quick, don't go too far. Are there any questions for our presenters? If not, you know where they are afterwards. We will keep moving, but thank you very much for that. Okay, our next presenter is Dr. Mike Norwood, who's going to talk about nature-based virtual reality in brain injury rehabilitation.
Okay, thank you, Louise. So yeah, my name's Mike. I'm a research fellow at the Hopkins Centre, and I'll talk to you about our project which asks the question, what effect does immersive virtual reality-based nature exposure have on anxiety, stress, depression in people with brain injury in a hospital rehabilitation ward? So the briefest background you'll hear today, hopefully, everyone kind of knows there's decades of evidence that exposure or different types of interaction with natural environments is really good for lots of things, but for mood, so things such as stress, anxiety, and depression. So the problem is not everyone can access natural environments, and so what we're going to do is explore how we could bring a nature experience or interaction so that people who couldn't access it could get the associated benefits. So we were looking for people who couldn't access nature. Sadly, astronauts, I couldn't find any astronauts. So we decided to look at hospital clinical environments, because it's also difficult to access nature in many of these environments as well. So one way of delivering nature to people who can't access real nature is to bring virtual nature. So virtual nature could be delivered on a headset similar to this. So the headset completely occludes the real world. So the person can only see what is being presented to them in the lenses. So it presents a completely immersive alternative world. And virtual nature is a way that's been used to provide safe access to natural environments when they're not available in the real world. So patients in inpatient settings are often one of those groups that can't access real nature. So essentially, we aimed to first establish the feasibility of using virtual reality nature in this setting, and explore the effects, the potential benefits of immersive virtual nature exposure on mood of people in hospital-based rehabilitation following a brain injury. So feasibility, we were looking at motion sickness, which is a risk factor of virtual reality. Briefly looking at their experience and enjoyment through a quick survey or some brief qualitative questions. We were looking at the immediate impacts on mood, so before the watching and complete directly after watching the virtual nature, and then more longer term effects over the whole 2 weeks on depression, stress, and anxiety. So essentially, we aim to get 26 inpatients at the Gold Coast University Hospital in the Neurosciences Rehabilitation Unit. And all they did was 3 sessions of virtual reality nature per week for 2 weeks. And then the 2 weeks of standard care as a sort of control. And the videos were only 4 minutes each time, so short exposure to the videos. And we tried to make sort of the nature, the locations local national parks. So that was Springbrook, Burley Heads National Park, and Telledry Creek isn't a national park, but it's still very lovely. And what we found, so in terms of acceptability, motion sickness was really low. So no sickness was reported, 82.5% of exposures. So stimulator sickness was negligible, and motion sickness, the one below, 91.2% had no sickness. And when it was reported, it was very low level sickness, sort of stomach awareness. In terms of experience, there was a sort of high level of sensory immersion and positive affect. Scenes were rated highly. They were enjoyed from most participants. And we didn't find any difference between the scene locations in terms of enjoyment. And we didn't find any real difference in sort of if the scenes were rated by the user as meaningful or familiar. So the immediate effects of the virtual nature on mood, we had just if they were feeling so sad and anxious, the green bar is better. So after the 4 minutes, the majority, something like 50, up to as close to 60% were feeling better after the 4 minutes exposure, with the yellow one being sort of the same, and only one person on one occasion feeling worse. This is like no context bar chart, sorry. But this is the depression, stress, anxiety scale. So over the 2 weeks, so the longer term sort of mood. The green is the before and after for the 2 weeks experimental watching virtual nature. So in terms of overall depression and stress and anxiety, they're all decreased in their symptoms after the 2 weeks, and they all decreased. They were statistically significantly reduced compared to the control, apart from the anxiety one in this corner here, where it decreased, it just wasn't significant compared to the control. And then we had some very brief sort of interviews afterwards. We found that it was very acceptable. The top bar there is general appeal. People, when we asked if they enjoyed it or what they enjoyed about it, they just sort of said a general liking. The biggest impact on the user themselves was calmness. That's the second yellow bar there. Patients mentioned blue space as well, the most overall. So all those blue bars are in the top half there, but one of the most frequent answers, they enjoyed the ocean or the river or the waterfall. Green space less so, that's just the couple at the bottom. They appreciated auditory stimuli as well. So all the purple bars near the top, that's sort of the sound of birds and the sound of water was something that people really noticed. And activity, it was mentioned a couple of times, and the colors, people enjoyed the colors. When we asked what they didn't like, essentially the two green bars are like nothing. Most people said there was nothing that they disliked about it. And there were a few comments on sort of length of video, which was where they were saying it was too short. And there was a couple of comments on like video quality and things they didn't like in the background. There was one person commenting about wanting more surfing or better surf, which I thought was a really great Australian/Gold Coast response. So essentially, yeah, we set out to test the feasibility of the virtual nature, and we found that it was feasible, it was enjoyable, and there was low levels of motion sickness. The immediate impacts were positive. There was less feelings of feeling depressed or anxious or sad, and there was also indicated that maybe in the long run as well, it would have positive effects on mood. So the findings essentially support that this might be a way forward. It was a pilot study, so need to do sort of more work in the future. And there's also more questions we can ask on like interactivity or if we involve more senses. So that's it. This is obviously the whole team. There's more people than just me doing this, lots of very clever people. So thank you to them.
Thank you, Mike. Are there any immediate questions for Mike? I'm so delighted that people talked about surf and water because I love my blue spaces. Moretta has a question up there. Thank you.
Hi, Mike. I was just thinking that if people are enjoying watching surfing and things that maybe aren't classified as nature, whether it's really about nature or, you know, if you'd given them a tennis match to watch or something, they would have had a similar effect.
Yeah, I mean, that's a good question. I think, so the comments on surfing they weren't the main comment that came through. It's true that, I mean, like a lot of the stuff we're trying to explore in our research is on like enriched environments in general and sort of recreational activities. So yeah, it's true that just watching, if they just had a surfing tournament on, that person would probably have enjoyed that. And I think that goes to, if we can continue this work, we want to do some sort of co-designing of what the videos might be or what they'd like to do. And there'd obviously be some individuals who would prefer to watch nature. There was a couple of comments on it wanting more activity. That was only a couple of comments, but for that person, they wanted people in the background. They wanted dogs and they wanted surfing. Most of the research would suggest that for improvements in mood, there'd be sort of less people involved and less activity and just sort of that restorative experience. So it depends on the outcome you want as well, I suppose. But yeah, they'd be exploring sort of different content for different outcomes would be sort of a future step. And that would include, yeah, activity versus no activity. It's also interesting because people don't want people in the videos necessarily. They want just nature. But when we asked them the questions about what they liked about it, or was it familiar? A lot of the responses were like, well, it was, this is where I used to go for a walk, or this is where I spent time with my family. So they want to get that restorative impact. You want know people, but part of the benefit for the people is the memories of people. I didn't know what to make of that, but I found it interesting.
Lovely. Thank you. Okay, our next presentation is a collaboration between engineering and physiotherapy, looking at the introduction of tech into rehabilitation. So I'd like to welcome Jackie Donovan and Dr. Camilla Schroeder back up.
Thanks, Louise. Alrighty, so now I'm going to talk about Epic Tech. So, sorry, this was a study that we started here at the PA. We started in January at the brain injury and geriatric and rehab units. And today we're going to share a little bit of our experience and some of our preliminary findings. So the project came out of like a challenge identified during clinical delivery of gait therapy. So some patients require a lot of support. And even though we know that there are devices available on the market that could help support the delivery of this therapy, we don't really see them being used in practice as much as we would want to, or it could be done. So what we were trying to do as part of this project is to look at a different interdisciplinary approach where engineers and physiotherapists work together to introduce new pieces of technology. And in this case specifically, we were looking at the Endago, which is the machine that you see there. It's a robotic partial body weight support. And so the participants in our study were people that their therapists deemed they would benefit from gait therapy or walking therapy. And that might benefit also from partial body weight support or some harnessing so they could be safe during upright activities. So our aim of the study was to look at clinical impact, acceptabilities, and barriers and facilitators of technology implementation with this interdisciplinary team approach. And we divided our study into 3 phases. So the first one was just a baseline phase, looking at what physiotherapy looks like and usual care. Then we did 3 months of trial, which we just finished now in October with the new device and the team. And then we're currently in evaluation. So today we're going to talk about phase 1, which is the usual therapy. So this is just an outline of what the study looked like. We had, patients enter the study. They did a batch of functional assessment and standardized measures of balance, walking, and function. Then during their therapy, the physiotherapist wrote down every single session, what they did, the amount of staffing and the equipment required. Some patients got some activity trackers and some of the sessions were videoed. And then at study exit, so either when patients were discharged from rehab or at the end of our 3-month study phase, we repeated the same measures from the beginning, and then we interviewed the clinicians and patients. And so now Jackie's going to present some of our quantitative results.
Okay, so in usual therapy, we managed to recruit 13 participants. 70% of these patients came from the geriatric and rehab unit, 30% from the brain injury. Most of these patients, or more than 50%, had a stroke. And the next highest conditions were acquired brain injury or a autoimmune neuropathy. And the median age for the cohort was 57 years old. So in phase 1, patients were enrolled in the study for 52 days, a median of 52 days. Across the course of the trial, all participants improved on their measures of balance and walking, and all except one improved in the clinical outcome variables scale, which is a composite physical function tool, which is rated from 13 to 91, 91 being the highest physical function. And we demonstrated a median improvement of 22 points. Now, unfortunately, there's no minimal clinically important difference available for this scale, but it is likely that this amount of physical improvement is quite meaningful for the participants and their carers. So what happened in the physio sessions? So patients or participants received an average of 49 minutes of therapy by 1.4 staff every day. And the intervention and estimates provided by the therapist show that on average, patients are spending more than half of their sessions on completing standing, stepping, and walking tasks. And that the interventions are mostly being completed by more junior or HP3 level staff and physiotherapy assistants. So in approximately 50% of the sessions, no equipment was used. When equipment was used, the most prevalent were forward walkers, plinths, and walk belts. And it was interesting that the light gate, which is our current assistive device for gait therapy, was only used for 4 out of 13 patients. and 15 out of a possible 400 plus sessions over the 12-week period. So of the potential sessions that could happen across the course of the trial, 14% were not delivered. And the top rated reasons were staffing, uncovered leave, other therapies having some requirements that took priority, and or patient willingness to attend. And so what did we learn in this baseline phase? Well, we saw there was significant staffing required to complete the interventions for these patients with that average of 1.4 per session. But in reality, this could range from 1 to 4 staff, depending on the intervention that was applied. Eligible patients for this study were rated by their physio as benefiting from gait therapy device use, but the current device that we had was rarely used. And for those sessions where the light gait was put into action, it was usually led by a senior staff member, and it required 2 to 4 staff to implement. So it seems possible that our intervention phase may be of benefit if the Epic Tech team can increase the assistive device use, support more junior staff, and increase standing, stepping, or walking dosage. But you'll have to wait. So just where we are now, we just finished the intervention phase a couple of weeks ago. So we're currently going through completing the data entry, and we'll start analysis of that soon. And we're currently in the evaluation phase, meaning we're interviewing therapists that participated or not in the trial to see their impressions of it. And so we're looking forward to sharing our final results with you guys soon. So that's the team. Thank you.
That is very creative photoshopping. I do like that a lot. Any early questions for the team? Yes.
Yeah.
Yep. So the question was that originally you were requiring 2 to 4 staff, and why was that so?
Yeah, so when some of the patients had bilateral limb weaknesses or trunk instabilities, so getting them into the harness device and requires quite a bit of manual handling. And then also once the person is up in the device and then you want to start walking, we weren't using treadmills, we're just using the gym space. So you might need one therapist on the leg, each leg, one person pulling the device, and then maybe someone else behind at the trunk to help control what's going on and give the patient cues. Yeah.
Lovely. Thank you. Thank you very much. We are going to keep moving along. Our next speaker is Jake Bennett, who is a Senior Research Assistant at the Hopkins Centre, and he is going to talk about his project that's looking at using AI.
Hello. Oh, can everyone? Oh, maybe this needs to come up a touch. Hello, can everyone hear me okay? Yeah, relatively? Cool. Oh, hello, my name is Jake Bennett and I'm a Senior Research Assistant here at the Hopkins Centre, currently working on a project looking at using an artificial intelligence-based algorithm to assist the early identification and staging of pressure ulcers for people with spinal cord injury. So the principal investigators on the team are myself alongside Professor Louise Gustafsson and Professor Tim Garrity. And we're working with clinicians from the Queensland Spinal Cord Injury Service and the Spinal Outreach team also. Sorry. Okay, so a pressure ulcer can be defined as a localized injury to the skin and/or underlying tissue, usually over a bony prominence caused by pressure and by shear. And following a spinal cord injury, around 30% of people will develop a pressure ulcer within the first month, while around 85% will develop a pressure ulcer throughout their lifetime. For people with a spinal cord injury who've also developed a pressure ulcer, this can lead to quite significant reductions in their physical, psychological, and their social well-being, and have impacts also on their quality of life. From an organizational perspective, this can also lead to things like recurrent hospitalizations, medical complications, and increased patient care cost. Okay, so the purpose of this research really is to understand both the feasibility and the clinical scope of developing a technology to help with the early identification and staging of a pressure ulcer through an image of the wound site, and also begin working with clinicians and outreach teams to identify where this type of technology could be applied within our contemporary healthcare context. Beautiful. So to do this, we're going to be collecting a series of pressure images through our clinical partners and or through historical data, and images will then be used to train a machine learning model. The particular type of model that we'll be working with is called a convoluted neural network, but what it does is it segments images into features, and it uses those features for pattern recognition, and in this case for image identification. So it does this first through similarities between images within the same class. So of all of the images of the stage 2 pressure ulcer, what's similar of those images, or what discerning features are there? And also, how does that then compare to what a stage 4 looks like, or a stage 3, or a stage 1, or a deep pressure tissue injury, for example? And it does this mathematically through something called kernels, which are number matrices to extract features. Within practice, what we'll do after we've collected all of our individual images is we create a series of composite images. And what that is you do a series of image manipulations to them to create different versions to highlight different things. So first, for example, you can flip an image. So you can do a horizontal flip, or you could flip it vertically, or you can also translate an image. And what that is you'll show the model a specific part of the image, and you can blur, so occlude all of the parts of the image that you don't necessarily want it to learn from, because we're trying to get it to learn some of those patterns. Or you can do a series of image manipulations, such as increasing the sharpness or the contrast, and you can perform these manipulations individually or in combination. The purpose is to both increase the sample size of the images that are being used for training, also increase the training variability, so the types of patterns that the model itself can learn, and also begin to train model to overcome deficits. So once you get to the evaluation phase, if we find that, for example, we're not particularly good at picking up on a stage 2, we can introduce new variations of images so it can begin to learn some of those patterns that maybe it missed on the first iterations of the model training. Cool, so we actually put this little theory to the test, and we collected 350 images of carcinoma, of keratosis, and of acne, and then we performed 3 composite image manipulations. So we had a version that had been horizontally flipped, another version that had been vertically flipped, and another version which had received a process called dilation. And what that is you're adding in pixels to areas of the image where you want the model to actually learn from. What we then found is that after our 4th epoch, and an epoch is once you run through the model from the start to finish, that's 1 epoch. So if you do it 3 times, it's 3. And by the 4th, we got an accuracy of above 80% for the first time, with a validation accuracy of above 80% as well. And that validation accuracy is on a subset of images that were not used as part of training, and that was 10% in our case. What we found is that with our continued epochs, we then got a higher levels of accuracy and less data loss, which means that as we begin to get some of those atypical image presentations that maybe it didn't necessarily know what to do with at the start of training, it's learned enough to then be able to integrate some of those patterns into the model. So that's really important once we then get to our area of generalizability. So once we've trained it, we exported it. I then got another 1,200 images that were not included in original training. And we got over 92% prediction accuracy on those images, with greater than 90% accuracy in statistical sensitivity and specificity, with a balanced accuracy of greater than 90% over each of our classes. Cool. So some of the expected outcomes of this research project is the start of a clinical tool to assist a visual identification of pressure ulcers using images, and also begin working on a potential mobile application to be modified for community use. We've gone through and made a bit of a mock-up for that as well. Okay, so As part of the progress at the moment, we're currently assembling our applications for our ethics and governance, conducting our literature review, and I'm currently optimizing and building a code repository. So once we begin to get our pressure ulcer images, if we notice anything particularly about them, I already have some code that we can refer to and begin to work on those manipulations in real time. We currently have some manuscript work ongoing. We're really looking forward to the next part of the project. So our next steps are to meet with our clinicians and to begin work on the model development. And if you have any interest or any questions about the research, I more than encourage you to get in touch. My email is up there, so jake.bennett@griffith.edu.au for those who are listening from home. Beautiful. Thank you very much.
I am going to go and throw to questions, but I'd like to be very clear that when Jake uses the term "we," he is not referring to Tim or I in terms of doing this work. This is Jake who's leading this. David.
We do a lot of natural language processing, training to find things like delirium, electronic medical records. We have to do a lot of work around negation. So do you present red bits that are not a pressure injury to the training model? So how do you deal with consequences?
Yeah, good question. So sorry, my mind has gone blank on that one.
So,
yeah.
You know, I assume you've got some screening, some clinical smarts that say, you know, this is likely to be an early pressure injury. But I'm thinking about, you know, dissemination, particularly in the hands of less skilled practitioners in the context of an app. How do you, have you thought about, or does the model incorporate the ability to say, no, it's just red, it's not a stage, like it's not a minor pressure injury?
Really good question. So those are the types of discussions that we're going to have once we're beginning to work a lot more closely with our clinical teams as well, even in terms of some of the information that might be brought in prior to, you know, the image interpretation from the model itself. So I think that that's what Louise, Tim and I at the moment are really starting to focus on and go from. But thank you, that's a great question.
Yeah, it's a great thing to think about. Thank you.
Awesome.
Thank you,
Beautiful.
Jake.
Thank you.
Lovely. Our next speaker is Rhonda Biggs from the Spinal Outreach team. Welcome.
Thank you. Thank you. I don't think I'll risk the clicker. It seems to be quite dodgy. My name's Rhonda Biggs. I am presenting here today as part of the Spinal Outreach team on the project that I'm about to talk about. And we're looking at how we're piloting the use of a low technology communication aid called Talking Mats to help us undertake qualitative healthcare research with people with an intellectual disability or a cognitive disability. So the context for this research is, of course, set on the backdrop of the Disability Royal Commission. We know that we have some difficulties in healthcare for this group of people. We know that there are numerous recommendations that have been made to improve the poor patient journeys that have been described. We know that those poor patient journeys include difficulties with accessibility, it includes difficulties with communication, and it includes a myriad of other problems. Metro South is proactive. It wants to improve those patient journeys. We know that we have the disability strategy plan. We know that we're working towards more inclusive futures. And we know that we are looking towards research that improves the dignity of people with disabilities. And Griffith University, who's also a partner in this, is also being proactive in breaking down those stereotypes that people with disabilities, and particularly intellectual disabilities and cognitive disabilities, face when they come into contact with healthcare systems. The backdrop of this research also considers the way in which we currently collect qualitative data that patients report about their healthcare experiences. Currently, when we look at PREMS, patient-reported experience monitoring, we're thinking about how people give that information, and it's usually through wordy, difficult to manage, difficult to understand questions. If you have a cognitive or an intellectual disability, those concepts really need to be broken down. And currently what probably happens in most cases is those prems are reported by proxies. So we're not actually getting the voices of people with intellectual and cognitive disabilities that tell us something about their healthcare. So in our research, we're looking at using something called Talking Maths. Talking Maths is a low technology, picture-based and plain language word system. It's intuitive. Somebody can see what they're talking about. They have a visual reminder, and it helps them to think about their decision making. It's definitely backed by research. There's numerous papers about this for use with people with dementia, with intellectual disabilities, with aphasia, for example, and many others. You have to undertake accredited training, and that keeps the training consistent. That keeps you, hopefully, from avoiding some pitfalls, which we'll talk about. And Talking Maths is well known to a lot of speech pathologists, but its use is broadening. We found a number of people that were undertaking this training, came from different walks of life, and they were trying to use it so that they could improve their communication system. So Talking Maths. This is a picture of a talking mat. On the top here, you have the top scale. And the top scale represents the data, the subjective data, the feelings or the opinions of the person. So you have a thumbs up, a shrug, and a thumbs down. The thumbs up, of course, represents what the person is talking about in a positive phase in the usual sense. It's really important that the top scale actually has a describing word that is the same, but maybe with a prefix or a suffix that helps to describe that. So for example, you could have clean or unclean, helpful or unhelpful. And that just keeps the meaning consistent for those people who have an intellectual or cognitive disability. If you're using different words, they start to mean different things. At the bottom, you have the topic. The topic is really important. It helps people understand and stay on track with what you're talking about, and it helps as a visual reminder. And in between, we have all the areas that people report on. The important thing about Talking Maths is that there is thinker-led. The person that you're seeking the data from is the thinker. So with help from our advisory group, and from the literature, we're using our Talking Maths to ask about the healthcare experience of people with intellectual and cognitive disabilities. And we're thinking about what's good and not good. And in between is unsure. We're asking about the temporal aspects of before, during, and after their healthcare. And at the bottom, you can see our topics: communication, getting there, my needs, and my feelings. You'll recognise those are very similar to the prems, but these are also what our advisory group told us were the important things for them. So what have we learned so far? The value of our advisory group has been phenomenal. They helped us to translate some of the research. They've echoed the research, but also added their own slant. They have been really helpful in us doing a trial and error. Although Talking Maths is feasible and it is generally acceptable, we had to go through a number of iterations, trial and error, to get it right. It's quite difficult to break down really difficult concepts into something that's very simple. On a talking mat, you really don't want any more than 15 pictures at any one time. So we had to be really clear about what we were asking. It does provide that framework for us to be able to ask any questions, really, any opinion. And the great thing about it is if you don't use it prescriptively, you use it as a framework, you can actually have a really good conversation that's thinker-led. And so that's really important, isn't it? We're actually getting the opinions from the people we want to hear from. So what next? Well, the Dignity Project Improving the Patient Journey continues. We're still using Talking Maths. And we want to use this data to create patient journeys. We want to understand the tensions and the strengths within our Metro South Health Service. We hope it's going to help us identify action points. And we're also wondering whether this is a way forward thinking about use for PREMS. Thank you very much. This is the research team, and a special thank you to QDN for helping us with our advisory group.
Wonderful, thank you. Thank you, Rhonda. Thank you. Your point about the importance of the advisory group, I think, was a really pertinent one. I think that's something that we find always very important with all the work we do in the program. Any quick questions for Rhonda? Yes.
Hi, Rhonda. Your presentation was very interesting. I'm just curious about the talking mats, if they're available through the NDIS, if participants outside the healthcare system could access this app on, say, an iPad.
It's a really good question, thank you. There is an e-version available. And when we were doing our training, there were actually numerous NDIS support coordinators who were undertaking the training so that they could use it with their consumers to gain an understanding of their opinions about their NDIS care or services they wanted. So I wouldn't be surprised if it doesn't start to roll out, but I don't know whether NDIS funds it.
Thank you. Thank you. Thank you, Rhonda.
Oh,
that's mine.
Not mine.
Yes, that's mine. Thank you. All right, we have our last presentation for this session just before lunch now, and I'd like to invite Camilla and Matt to come back up to, I guess, really wrap up this enabling technology session and talking about something that's really important to us in program 2, which is around collaborative co-design, but also learning from each other and working across disciplines.
Thanks again, Louise. All right.
Cool.
Let Matt get started.
So our presentation is titled Collaborative Rehab Innovation in a Pursuit for Co-Design Across Disciplines. So co-design is a flashy word that gets thrown around a lot. So we're going to talk about how different methods and ways we've tried to incorporate different disciplines to work together. There's an idea, everyone has a different ideal or idea of what co-design is, and often in reality it's very different, with different disciplines having different languages and different way of talking and different ways of designing and thinking and of co-design. So we're going to discuss a few ways that we've incorporated co-design in terms of within teaching and students, and there's a really good opportunity for us to impact this young generation of people coming through, so that when they get to the workforce, they're practiced and they've learnt it, and they've done a little bit of co-design of some sort within their degree.
Sure. Thanks, Matt. So yeah, there are obviously multiple ways that we can work with students. Some examples here are inserting ourselves in undergraduate courses, major studio or kind of graduating projects that students have, placement as research assistants, and then obviously honors, work integrated learning, and higher degree research. We work across all of these, but today Matt and I wanted to talk a little bit about the upfront part of it, so the undergraduate courses, but also the work that we've been doing with non-health students, because I think that's probably the more different for the crowd here today, who are mostly probably in health, and then how also some of our work in undergraduate courses feeds into the other modalities. So I'll just start with some of the courses that I've participated in. So we've been working multiple years with UQ and Griffith. So at UQ, we are within the medical device engineering course. So these are engineering students across many different engineering degrees, about 45 to 50 students for one semester. And they're learning about medical devices. So how do you create a medical device? What are the requirements, TGA certification, documentation, all that kind of stuff. So we come in, Hobbytech or Hopkins, we have a presentation on co-design and rehab for these students who don't necessarily know what rehabilitation is or co-design at that point. So we come in with a person with lived experience of disability and an occupational therapist here from the spinal unit. And then as Hobbytech, we also present a few issues to be addressed in a project. So these students do team projects, 5 students per group, and we work on a whole bunch of different issues. For example, that one up top that you see was a program that can track movement and count the number of activities that the person is doing in the scene. Another course that we work with is Future Product Studio. So these are design students. So in the School of Arts and Design, Product and Industrial Design, there are about 20 students at South Bank and 20 students at the Gold Coast. They work during one trimester on individual projects. And again, we bring a few different topics that they call design briefs. So for example, this year we brought in a person with a spinal injury who uses crutches, and he talked about some of the issues he has in his daily life. For example, being able to put his crutch inside of his car because he doesn't have very good hand function. So one of the students came up with a little clip thing so he can contract his crutch. So these projects specifically also became part of other research projects or their major graduating projects.
Yeah, and another example was this industrial design studio too. So this was a first time we've run this course this year. We had 15 students, and how we ran it was we got 2 people with lived experience coming in with 3 challenges that they would like the students to sort of brainstorm and sort of work with them to achieve an outcome. So it was a really productive course. There was a lot of work we did early in the course about disability in general. A lot of these students have never met someone with a disability, so we put some work in early to sort of get them kind and nice and not studentish. But so we did a lot of work early, and we gave them a few little smaller assessments that sort of got them thinking about someone else as well. And then we had our participants come in and give their challenges, and yeah, it was really successful. We've already been given the green light to make it bigger next year. And some of the outcomes we got were really exciting. We had a makeup brush or paintbrush attachment for someone's hand. One of our participants was struggling to pick up cans out of his fridge, so the students designed up a can picker-upper, and turns out he just drinks out of them now. And then on the left is an odd one, but it's really cool. It's a new clothes peg for someone that was having issues with fine motor skills. So these are some of the really cool outcomes that the students came up with.
Yeah, so some of the challenges and benefits, starting with the benefits, advertising rehab as a field, like Matt mentioned, a lot of these people maybe, or a lot of these students haven't ever met anybody with a disability. So advertising that rehab is a field, and we are here, and we would love for people to use their interest and talent to help us with some of the problems that we have. And then, as Matt mentioned earlier, also upskilling. So really teaching these students what it is to do co-design and interface with people with different backgrounds. Some of the challenges that especially we've had at Hobbytech is ensuring commitment from people with lived experience, for example, or clinicians. You know, it's very easy for me to go in and meet with the students 4 times throughout a semester, but that's not always possible for clinicians or people that don't do that as part of their jobs. So we need to be able to accommodate for that. And then a student deed for non-health students. So right now, students with clinical on a clinical course can come in and work with the students, but when you're trying to design something and you can't see the person or interact with them, it makes it really hard for us to come up with solutions. So our future plans is to make these courses more regular. We'd hope that we can get more disciplines, not just engineering and design, fix the student deed, and then hopefully also do something similar, but for health, introducing design and technologies for our health students instead.
Tell them I just come and gently stand next to them.
I'm done.
Well done, thank you. Thank you very much. Any questions? We have a question up the back here.
Just hang on till we get a microphone to you.
Just so our online audience can hear us as well.
Those were some really nice, elegant solutions to challenging issues. Where do they live? Like, they look like they're all 3D printed, and there are currently people out there who may need them. So it looks like it's just an STL file.
Yep.
Is that freely available anywhere? Is there a website? You know, like, because that would actually be, for a lot of people, game changers. And I'm guessing the university owns the IP technically, but I suppose you could try and commercialize it, but it seems like it'd be something that'd be easy to do. Just put an STL file on Yegi or Thingiverse or something, and then advertise to the health community that, hey, there's something that you can 3D print and see how it goes.
Yeah, that's our big goal, is to have a design library. Everything's going to be free and up there for people to download the files, or and in a perfect world, have a network of people that have access to 3D printers and stuff that's pretty affordable and accessible these days. So we want to provide a network as well, so that people that don't have that technology can we can link them with schools and universities that might be able to get them printed for them wherever they might be. So yeah, that's our end goal, is to have it all free, and we've got it all ready to go. We've just got to tick a couple legal boxes and then all good.
That's a great question, though. There are repositories already existing where people do put things. A lot of prosthetics related stuff is readily available. But yes, you also raise a great question around who owns the IP. So we always work with the students and sign all the documentation prior to them being engaged in the course, so that everything is in the clear. But we haven't had any issues so far.
Lovely, thank you. I think there was one question online, but I don't have access to it. Sorry, Mikala. That I'm just aware, Mike, there was one question online for you. If people don't mind, if we just take a minute or two just to answer that. Sorry, my apologies, Mikala. So Mike, for you, if you wouldn't mind popping up, the question was, I'm assuming that the video preferences prefer blue space because of the Southeast Queensland Gold Coast connection. And so their connection to the ocean water. Has this been trialled in different spaces, for example, inland or in more rural areas where perhaps fields or different types of countryside might be preferred?
So in general, in the literature on preferences for natural environments, blue space and green space is as like a combination is what comes out as preferred. And then there's stuff on like, well, what type of blue space? Like marshes and swamps aren't really preferred. So, I mean, the answer to the question is kind of like that it's not really been done in terms of virtual reality, but when it is, it still points to blue space it's been done in, some of our partners there in the States, they're not by the ocean and it still prefers blue space. So there does seem to be, there's not enough out there to draw firm conclusions, but it does seem to be based on non-virtual research and what exists that blue space is generally preferred. There is a line of research starting on deserts, which I think would be really interesting. And in terms of especially what we have in Australia in terms of the interior, and I'm not familiar with it, but I know that they still have restorative potential, that there's still benefits that people don't view these landscapes and then feel worse or don't get the benefits. But the answer in general is that no, I can't specifically answer that question, but from the research, it would suggest that most people would prefer the blue and the green space, but that those interiors are still restorative.
Great.
Not a very good answer, sorry. I don't think the answer fully exists yet.
No, we have learnt swamps and marsh, definitely not. Wonderful. Thank you very much. I would like to, if we can please, oh, sorry, we do, is it quick? Sorry. Please ask your question. We do have a few moments. Mike, sorry, Mike, you're back again.
I was just wondering, people before were asking about watching certain activities, but what about if the person is as if they're doing the activity? Do you know much about that? Like if they're mountain bike riding or hang gliding or something like that?
So I think, so when it comes to, there's obviously different types of interaction in that with natural environments. So if you're purely sitting sort of incidentally in a natural environment, then you'll get these restorative benefits on your mood and other benefits, but so the mood outcomes. Then if you're being sort of active in nature, you'll, depending on the activity, you're likely to sort of get those benefits and plus some more. Because a lot of, I mean, there's a lot of this nature prescribing is about social prescribing. So people go to natural environments, and this came out of our reference sort of groups as well, to be social, to like do an activity. So they get they want to be in those environments and they want to get the social benefits from it as well. And then they also feel better because they're doing them because they're getting those mood benefits. So that, and there's also some work mostly in the UK, and it should be done here, maybe it is, but on surfing. And surfing, there's a couple of projects, papers on people who are using surfing as a rehab tool. And sort of they had qualitative data, and it's sort of suggesting that they were getting all these different benefits from surfing because they're getting you're immersed in nature. So they're getting those mood benefits. They're also getting some sort of mobility and physical benefits. And they're getting a social benefit, and they're getting sort of a community benefit because they're with other people who are experiencing rehab. So different types of interaction do have different outcomes. And if it's a really active, like, if you're doing something really adventurous, then you're not really going to get those restorative outcomes because you're too busy focusing on, staying alive or doing your activity. And the idea with the restorative outcomes is that there's not all these, you remove the built environment and the people, then it's sort of, the idea is it's an attention thing. So your brain doesn't need to inhibit all these distractions. And like they call it sort of a soft fascination. So in nature, your brain isn't like trying to inhibit the natural environment. It can sort of relax. And so when you bring in those activities or those other people, gradually, the more you bring it in, the less it can do that. So then you get less of those restorative benefits and you get more of whatever other, benefits from those activities.
You can talk about
Makes
it
sense.
for
Thank
hours,
you.
so feel free
And
to stop with
I
me.
still won't make sense. So
I would like to take a moment to thank all of our speakers again for this first session for their presentations, if I could. It is now time, I'm going to wrap up this session and invite everybody to go to the outdoor space for the lunch break and just ask if we could all be back in here at around 12:45, please. Thank you, everyone. you. Welcome back, everybody. I'm here just to lead us through the next hour or so, which is the second round of presentations from Program 2 with the focus on enabling environments. We have a very potentially different view. We've got quite a few speaker changes this afternoon due to illness and different things. So you will notice that I'm introducing probably some different people to what are in the program. Our first presentation today is going to be presented to us by Mandy Nielsen on behalf of Stacey James. Stacey was one of the first recipients of the Bright Sparks initiatives from Hopkins that enabled her to take some time offline to conduct this work. So I'd like to welcome Mandy Nielsen up to present this. Thank you, Mandy.
Thank you very much. Shame that Stacey can't be here, and I'm sure she'd rather be here because she's dealing with vomiting children. So, okay. So as Louise said, Stacey's done this work under a Bright Sparks Clinician Capacity Building Grant, which is a short-term grant, and it's for new researchers. This is her team, so it includes Louise, Dr. Karen Watter, me, and Louise B, as we call her. So, driving disruption interventions for ABI. So, a brief introduction into driving disruption is that after ABI, there is often an unknown length of time where individuals are waiting for medical clearance to drive. Disruption to driving has a significant impact on clients and their support networks. It limits access to the community and increases dependence on others. So due to this, return to drive is a very common goal in community rehabilitation. Despite being prevalent though, addressing this goal after ABI can be difficult as individuals may not recall, have difficulty understanding or accepting education on this topic. It may also lead to individuals delaying other therapy such as return to work. So how often as clinicians have you heard that I'll do that when I'm driving again? For both clinicians and individuals with ABI, there's no clear path for an active approach to therapy that adequately prepares individuals to obtain clearance to drive or prepare them for driving cessation should they be unable to achieve this. So Stacey's research question was to identify the currently used interventions implemented during driving disruption to support the goal of return to driving after ABI and to identify the evidence base for these. An additional aim was to discuss intervention details, including intervention intensity, accessibility, and clinician training. Stacey used the Arksey and O'Malley methodology, which many people will be familiar with, for a scoping study. The method, so hang on, probably better if I read the notes. In identifying the research question, the population, concept and context were considered. The inclusion criteria were persons with moderate to severe ABI, licensed driver at the onset of ABI, and have goals to return to driving. Literature focusing on OT driving assessments or predictors of driving performance were not considered. All other interventions to address return to driving goals implemented by any profession were included, and limitations were placed on the clinical setting with only literature relating to community-based services included. 4 databases were searched, as well as hand searching of references. And this Prisma table shows the process of screening. In the end, Stacey had 31 articles which met the eligibility criteria. So going on to the results of the scoping review, 7 driver rehabilitation interventions were identified. And there was a wide range of study methods used from RCTs to newsletter articles. There have been consistent publications over the past 20 years. And so there's 7 of the most commonly talked about interventions identified here. So the first one is on-road lessons. And for on-road lessons, evidence appears promising, but there remains a lack of conclusive evidence through definitive RCTs. Evidence for simulated training indicates it may be suitable in the stroke population, but there appears to be a lack of translation to practice with these results. And considerations such as access to resources, clinician training and funding issues likely limit accessibility of these 2 interventions. Oops, hang on. No, that's all right. I've gone a bit wonky with my notes here. I think I'm on. No, I'm all right. Okay. Assistive technology and modifications include advanced driving systems designed at a manufacturer level, such as lane control sensors in your car, or using a piece of technology to support development of a specific driving skill. Evidence for this in improving driving performance remains unclear, with no definitive literature. There may be promising evidence for use of AT to target self-awareness of driving skills and support adjustment to driving cessation. So moving on to skill component training. These are off-road interventions aimed at retraining the underlying skills related to driving. They're provided in a range of clinically feasible platforms, including iPad games, pen and paper puzzles, or strength training. These were often used as the control group in studies representing usual care practices. Evidence was not conclusive, with varying reports on effectiveness when compared to other interventions. So community-based functional training, and these are activities aimed to remediate driving skill deficits during community outings, such as navigating public transport. And these appeared in the grey literature, such as news service descriptions, indicating a practice to evidence gap. These interventions often highlight that driving the vehicle is only one component of being an independent driver. And examples are practice of getting in and out of the car while holding an umbrella, or filling up the car with petrol. Emotional adjustment was explored in 2 qualitative studies, and they highlighted that driving interventions should also address ways to maintain community engagement and manage frustrations while not driving. This may include training an individual to use alternate modes of transport while not driving, such as trains, which we'll be talking about later. And finally, driver rehabilitation education. There were 4 themes identified. These were timing post-injury, delivery method, purpose of education. For example, is it informing about returning to driving processes or helping the client manage frustrations from not driving? And last, health professionals and services needing necessary skills and knowledge when delivering education. Okay, going on. Driving behaviour models were also frequently referenced within the literature. Michon's, I think, hierarchical mode of behind the wheel behaviour being the most used. As you can see, that's in the diagram there. Models such as this one highlight the complex demands of driving. So starting at the bottom with basic operational skills such as pushing the pedals, then building on this in the tactical level of integrating these skills into a dynamic environment, then most importantly, the strategic skills which allow us to make necessary judgment and anticipate risks, often utilised before driving such as altering our travel plans based on weather conditions. Based on the findings, this area of research of driving disruption in interventions for ABI appears to be a long existing and relevant topic of research, though there continues to be a lack of clear evidence for therapies. Those interventions with supportive or promising evidence, such as driver remediation or simulator training, are often not available to all, and there is a need for guidance on alternate approaches that may exist. It appears that support for driving resumption should be continuously provided by a multidisciplinary team. It is a complex topic, so interventions will need to be personalised, reiterated or revised as the person's needs change. We will need to learn more about how to apply this into practice, such as strategies for embedding this into existing services. Just gonna... Oh, there's a bit on that slide which I missed, but anyway. So here's the references, funding partnership details, and contact. Thank you very much.
Thank you, Mandy. And I think we'll let Mandy off from answering any questions, if that's okay. And if we have time at the end of the session, we'll certainly lead to questions if there's anything that any of us on the team can answer. Because I'm moving along to the next presentation, which was to be presented by Annabelle Johnston, but I'm presenting on her behalf this afternoon. It is a changing feast, this session. Annabelle is a final year advanced research occupational therapy student at Griffith University, and she's conducted this as part of her project with the Hopkins Centre and the Metro South Pain Rehabilitation Centre. She's actually at a job interview, so I don't think we can, this is the risks of inviting final year students to do something at this time of year. Hence I'm here. Oh, I better start my 7 minutes, time keep myself. Okay. The focus of this project was looking at home and the dimensions of home for people living with pain. And we certainly know that people with pain tend to spend increased time at home, but there's not a lot about their experience of home in the literature. There's quite a lot about the physical kind of aspects of home, but not really exploring it much beyond that. There's some incidental findings within qualitative studies that talk about where people might talk about some of the other aspects of home, but really there is a gap around this. And certainly this came up in a conversation with people from Hopkins and the Pain Rehabilitation Centre staff when the COVID opened up a window into people's homes through telehealth, and questions started to be asked about how this may or may not be supporting the practices within the clinic. So the purpose of this study was very exploratory. It's really asking, how do people experience their home environment, and are there any associations between the dimensions of home and reported pain experience? And when I use the term dimensions of home, we're really talking about the attributed meaning or the experiences that people have within their home. This was developed by Applin in around 2013, 2014, and this schematic diagram came about in 2019. And you can see at the top there, there's the physical dimension, which is one that we're all very familiar with, but recognises that for all of us, home is a space that is a personal space, a temporal space, a social space, occupational, and there's societal elements that also impact on that. And that all of this happens within our own kind of cultural background or way of being. So that's what I'm referring to in this presentation when I talk about dimensions, those 6 dimensions there. Because this was exploratory, we developed an online survey, and we've had 2 arms of recruitment. One was a social media blast and working with a lot of the national and big pain organisations around Australia, and the other is working specifically through and recruiting through the Metro South Pain Rehab Centre. And the survey gathered the information that's there, and most of that would be familiar to you. The last one is the Dimensions of Home measure, is a measure that's been developed by Applin and colleagues that ask people to respond to questions that sit under those dimensions, and you'll see them soon in the results. So I'm presenting data from the first 97 participants. We certainly have more now, but we're just going to give you a taste of where we're heading. So respondents were on average 51 years old, mostly women, and have been living in their homes for on average 10.4 years. The time that they spent in home on the left here, this is that 12-hour period between 6 a.m. and 6 p.m. How long are you in your home? So you can see that people on both the weekday and weekend are spending vast periods of their time within their home on those days. And in terms of the respondents, 60–90% are reporting musculoskeletal type pain, 36% oral, facial or head related pain, and there are other pain categories there, but they're the most prominent. And in terms of pain characteristics, a little bit hidden there, but people on average had been experiencing pain for 18.2 years. And then the pain severity and pain interference mean scores are listed under there for you. So I'm going to present just a snapshot and I'm going to talk you through this. So this is the safety subscale of the personal dimension. On the right are the types of questions that people were responding strongly agree through to strongly disagree on. Essentially, red is bad, blue is good, unless it's got an asterisk next to it, like PSF9, where blue is good because it's an inverse question. But I'm going to talk us through that as we go. But that's just a quick orientation to there. So we found that really, if we look at PSF9 there, 37% of people are agreeing and saying that they feel vulnerable to crime living within their home of all the population of people who are living with pain. And when we look at some of those pain variables, we can see they are weak but significant relationships with all of these. So people with higher pain are reporting that they're less likely to feel safe moving around and doing activities in their home, outside of their home, and entering and exiting their home. So we're starting to see some associations there. Social dimension really starts to build that picture even more for this. This S7 on the end there is inverse. So that is showing us that around 70% of people with pain said they'd like to do more social activities within their home than what they are currently doing. I'm really regretting these animations. Can I just apologise as well? So yes, we'd like to do more within their home, and I don't understand why that other slide keeps coming up. All right, the other big finding here is that people with longer duration of pain were let me get my orientation right. Longer duration of pain are less likely to agree that they can easily have friends and family around to visit, and people with higher pain severity and interference were less likely to agree that it's easy to do social activities at home. So home as a social place is definitely being impacted. Moving on to the occupational dimension, or thinking about the activities that people that do around home, nearly 60% of people do not find their home easy to clean. 65%, so AC2, the second one there is inverse. So a high proportion of people are saying that they would like to do more tasks within the home than what they're actually doing. And if we're looking at AC9, so the inverse one there, the second one in, we've got nearly 80% of people saying that they would like to do more of the activities that they enjoy at home. So there's a real gap for people there. And certainly in terms of relationships, there's a weak relationship with pain interference. Again, the higher the pain, the more they want to be able to do more activities within their home. And in terms of I can easily move around my home, people with a longer duration of pain were less likely to agree with that statement. And some of this makes sense with the existing literature. Finally, in terms of the temporal dimension, this is the one that I find the most interesting. This is really showing to us here that quite a significant enough of people, if you look on the left hand, are not happy with their routine within their home. And that's really something that's quite important for many of us for our health and well-being. Equally, if you look over to the far right, we've got a really high number of people with pain who are saying we are not well set up for the future in this home. So there's some real issues for people now, and looking into the future around home is supporting or not supporting them. T5, which is an inverse, saying changes to my home would make it safer and more comfortable. So we've got 60% of people saying that that would make a difference for me. within my home. So again, and I'm just going to ignore all of the animations that I've put in here, are really starting to highlight some of these issues for people with pain. And we do again see some weak associations with duration of pain and the pain reports. So really overall, in terms of the discussion, people with persistent pain feel less safe and able to do activities at home. They want to be able to do more within their home. They're really quite dissatisfied with their weekly, daily routine. They really don't feel like home's set up for the future, and they're not able to socialise easily in their home, and they'd like to be able to do so. So I think this is early work, and like I say, we've got more numbers coming in, but really the implications are that consideration of the home and the dimensions of home and all of these aspects may, if we can incorporate those into practice, may make a difference in terms of not just people's health and well-being, but also how well they're able to implement strategies and approaches that they're learning within pain rehabilitation services. And that's the end from me. Are there any quick questions, or shall we move on? I think I'd like to move on. We'll ask at the end and see if there's any. Our next speaker, who I'd like to welcome up, is Alice Ashley, who is going to talk to us about maximising the therapeutic value of mealtimes. Thanks.
Hi everyone, so I'm presenting to you one of my PhD studies, which is the co-designed framework for maximising the therapeutic value of rehabilitation mealtimes. So first, I'd just like to acknowledge the traditional owners and their custodianship of the lands on which we are meeting today. I pay my respects to their ancestors and their descendants who continue cultural and spiritual connections to country. So rehabilitation aims to maximise individuals' function and independence following illness or injury, enhancing their ability to engage in meaningful activities. Higher therapy intensity correlates with improved outcomes such as increased functionality, independence, self-care skills, and quality of life, as well as shorter hospital stays. And opportunities for this should be facilitated across all care activities. Mealtimes may be an underutilised opportunity for patients to practice therapeutic activities, which include optimising nutritional intake, having a break from the clinical environment, and providing a key opportunity for meaningful social interactions with patients, staff, and visitors, as well as contributing towards their patients' rehabilitation goals and experiences. However, the systems and processes around delivery of mealtimes have not been optimised to support attainment of the complete range of therapeutic benefits of the mealtime. Therefore, the aim of this study was to co-design a framework for maximising the therapeutic value of mealtimes for rehabilitation in patients. We utilise the values-focused thinking technique, which identifies fundamental objectives, which are those that are important in and of themselves, and means objectives, which are those that are important for achieving the fundamental objectives to support prioritising values over constraints in decision-making. 2 workshops were conducted, which involved synthesising data from the literature, my previous PhD studies, as well as the lived experiences of participants to develop the framework. Participants included rehabilitation staff from various disciplines, and consumers were patients and carers with rehabilitation and long-stay experience. Workshop 1 aimed to develop fundamental and means objectives that were important for maximising the therapeutic value of mealtimes, and Workshop 2 aimed to develop a suite of strategies to operationalise the means objectives. The development of the framework was conducted in an iterative process with continuous refinement through feedback from workshop participants. So in Workshop 1, the definition of a therapeutic mealtime experience was co-designed, which was to have a holistic, practical, caring and safe mealtime experience where everyone helps to maximise the nutritional and health outcomes for all. From this definition, 4 fundamental objectives were developed to address each concept. These include provide holistic, practical, caring and safe experiences, share ownership of mealtime imperatives, maximise all possible outcomes and enhance rehabilitation. 23 means objectives were identified and linked to the fundamental objectives they supported. And for each fundamental objective, a concept map of means objectives was created to describe the interrelationships between these means objectives. Workshop 2 identified 29 strategies to support operationalising the means objectives, focusing on general definitions and potential implementation barriers and enablers. These strategies primarily supported objectives of enabling access and provide information. Common barriers included resource availability, staff knowledge and capability, and workflow challenges. Participants assessed each strategy for implementation difficulty and impact, resulting in a prioritization tool to maximize the therapeutic value of mealtimes, with most strategies rated as having high impact and varying levels of implementation difficulty. For the remainder of this presentation, I will focus on two of the means objectives interrelationships describing specific subconcepts within the framework, and some of the strategies to support applying these in practice. So the first concept is foundations of rehabilitation mealtimes, with means objectives of enable access, identify needs, obtain feedback and monitor, plan the mealtime, and provide information supporting all 4 fundamental objectives. These 5 means objectives were linked, doubling up. Comprehensive planning involves understanding patient needs, available services, and collaboration with patients to ensure they are informed and involved in their care plan, which must be continually monitored and adapted as patients progress. Some of the strategies identified to support this concept were identifying mealtime goals, food service and mealtime orientation, and feedback processes built into standard practice. So goal setting is a core component of quality rehabilitation. So the strategy identifying mealtime goals is about having all clinicians who conduct goal setting to know that all activities related to mealtime should be explored, which could be used as goals themselves or therapeutic activities to support goal attainment. Food service and mealtime orientation informs patients about meal ordering, timing, dining locations, available supports, and how mealtimes support their rehabilitation. Feedback processes involve routine monitoring of nutritional intake to address issues with food service, supports, or patient conditions to address them promptly. These strategies aim to optimize mealtime experiences to be aligned with rehabilitation objectives, enhancing patient engagement and outcomes. The second subconcept I'll discuss is around enhancing the functional aspect of mealtimes. So participants emphasized that mealtimes in rehabilitation offer more than just nutritional benefits and felt it was important for the framework to support all possible mealtime outcomes. They valued incorporating functional rehabilitation into mealtime systems, such as making mealtimes resemble home environments and providing opportunities for practicing tasks like meal preparation. Additionally, they highlighted the importance of linking nutrition and rehabilitation, believing that appropriate support for nutrition and functioning can enhance each other, creating a positive snowball effect. 2 strategies that can support functional mealtimes are first accessible menus, which can involve a physical copy of menus for patients to access at all times, picture menus to support understanding of what menu items are, particularly for patients with aphasia, and menu with nutrition information embedded to support meal selections that align with their nutritional goals. And secondly, meal preparation with the mealtime. So this could be something like a breakfast club or a DIY sandwich station where patients have the opportunity to practice making their own food at the actual mealtime. So this is the first study to provide a framework to maximize the therapeutic value of mealtimes in rehabilitation, based on the priorities determined by consumers and staff. It can be applied in practice to identify mealtime initiatives to support connecting mealtimes to rehabilitation care and principles. While efforts were made to enhance the generalizability of this framework, the study was conducted with consumers and staff whose experience with rehab services were from a newly built digital hospital located in a metropolitan area, as well as the strategies being only a starting point and not a comprehensive list of all possible ways to enhance the therapeutic value of mealtimes. Future research should focus on validation and expansion of the framework, developing guidance for its use, and implementation of the strategies identified in the framework. Thank you.
Thank you, Alice. Do we have any questions for Alice? It's a quiet crowd. They're in the post-lunch lull. Lovely. Thank you very much. Our next speaker that you have on your program was unable to attend this afternoon, unable to join us. So we are moving on to Alison McDonald, who's an adjunct research fellow with us and a very valuable member of our advisory group in program 2. So I'd like to invite Alison to come up and to present her work on the Eco Village SDA. Thank you, Alison.
Right, haven't done this for a long time. So I'm Alison McDonald, and today I have with me Cleo, my guide, hearing and assistance dog. I'm an architect and I've worked in the industry since 1992. I was a university lecturer until disability from a cycling accident shared the gift of lived experience with me. There are many different types of architects. I was fortunate to focus on international infrastructure projects. In layman's terms, I worked on public projects funded and delivered in countries who embrace co-design, on significant projects whose mandate was public usability, public accessibility, where universal design was a standard inclusion. And to this day, projects like public art galleries, libraries, embassies are acknowledged as some of the most accessible. Projects such as GOMA and one of the last projects I delivered in industry, the Caboolture Hub. The UK's Building Research Establishment published the world's first environmental assessment method for buildings in 1990 called BREEAM. This sustainable building certification became the world's first leading science-based suite of validation and certification systems for the built environment. US followed with LEED in 1998, and Australia launched Green Star in 2002, with versions of Green Star then adapted for use in New Zealand and South Africa. And in 2008, 2009, I contributed to the creation of Estia Dharma, Abu Dhabi's Pearl building rating system. Today, developed countries employ environmental assessment systems for delivering leading sustainable buildings, providing a framework for healthy, highly efficient, livable buildings, which other environmental, social and governance benefits. These tools support solutions to reduce emissions, improve whole life performance, manage health and social impacts, boost circulatory resilience, biodiversity, and support disclosures and reporting. And since the late 1990s, I've had the privilege to work predominantly on BREEAM, LEED, and Green Star projects. These projects are internationally recognised as the world's best practice in sustainability. With the voluntary system is challenging to achieve, assessment is stringent, and only a small percentage of projects achieve these exacting standards. Since acquiring my disability, I've observed a bold and abrupt awareness of how hostile our built environment can be. The correlations between design for the world's best practice sustainability and design for cognitive accessibility, with these sustainable building tools incorporating cognitive accessibility in recent years. And for many years, their credits and categories, whilst addressing energy and the environment, have strong parallels with cognitive accessible design principles. I've also observed exposure of the low overall standards for design and execution of residential buildings and the lack of suitable dwellings for people living with disability in our real estate, within our real estate market. Our building codes and standards by building class separate residential and non-residential buildings, resulting in less requirements for residential buildings. And the lack of interdisciplinary awareness for Architects International Sustainability Building Certification and historical international applications of co-design and universal design, both within the building design industry and allied industries. With all of this accumulating, this led to the creation of Australia's first sustainable specialised disability accommodation. process of delivering this, in addition to the legislative necessary guidelines, the National Construction Code for Accessibility, long-standing Australian standards for access and mobility, and NDIS's SDA design standard. I focus the design on fully accessible and improved livability with some high physical support features. Despite the National Construction Code's increasing its mandatory whole building energy assessment for dwellings, LHA and SDA design standards lack sustainability, which feels negligent when it's the user group is one who needs these benefits the most. In addition to the Eco-Village's covenants for architectural and landscape codes and the Village Design Panel application superseding building certification, Sustainable Design Principles targeted net positive and the project using Starfish tool to deliver an affordable assessment for individual small project. One of the attractive features of this tool is its integration, is it integrates various sustainable building certification and environmental assessment methods like Green Star and the Living Building Challenge. The project's design also focuses on design for cognitive accessibility, sourcing information from several academic books, literature, relevant academic articles, and international standard for cognitive accessibility. This project is located in the Currumbin Eco Village, an area of natural beauty surrounded by national and state parks, minutes from pristine beaches where you can watch passing humpback whales and walk to Australia's largest eco park. The Eco Village sits on 270 acres, developed on 20% of the site, retaining 80% for community protection of native flora and fauna. The international community is centred on sustainability, the intentional community is centred on sustainability principles and is the recipient of accolades including the world's best environmental development, with 140 homes supporting a community of over 450 residents. Personally, I've always lived with the land. My family were graziers before founding members in the world's largest permaculture community from 1982. Home was off-grid, self-sufficient of natural materials, and the healing benefits of being in nature and active in intentional community were obvious. I struggled to understand why majority of SDAs are built in dense urban areas which are predominantly noisy, polluted, void of nature, health, and community, particularly post-COVID when online home delivery opportunities increased. Personally, I'd rather live where I want to spend most of my time and not where a normal person might occasionally shop near mass transport. Eco Village SDA is setting new benchmarks in sustainable specialised disability accommodation and cognitive accessibility in modern housing. It is reported to be Australia's first sustainable SDA. It is also one of the few built exemplars of cognitive accessible design. This is a complex project, so within the remaining time of this presentation, I'm going to focus on the element correlations with leading sustainable design and SDA, not covering either approach in entirety. I also add that as a result of 3 natural disasters to 3 consecutive homes in 12 months, flood, then toxic mold, then tornado, this project was fast-tracked. Within the categories of the sustainable building certification and environmental assessment methods, one of those relates to flexibility, adaptability in materials category. Excuse me. Okay. You're not going to touch the keyboard. Reports adjustable, adjustable flexible design is reportedly more sustainable, particularly in accommodating multi-uses. And single-purpose built-ins are known to have shorter life cycle due to their rigidity. In Eco-Village SDA, a significant portion of the kitchen was reused. The kitchen island is actually a piece of furniture on wheels, locked either end. Actually has 10 wheels underneath, but just the ends are locked. Power is connected via a flush floor box, and the unit can pivot around this connection or move to an entire new location. Careful design incorporated the existing heights to reuse drawer units, heights of the mobile mechanism, and adjustable elements to achieve the SDA height requirements. The unit is over 3.2 metres long. The island's cantilever provides more than the required 400 by 900 adjustable height bench space, running the full length of the island. The adjustable height control box has 3 preset settings, 1 flush, the low required height by SDA and the high required height, and it's easy to manually adjust heights between and beyond these settings. In its current spatial arrangement, it's designed to pivot to allow 1550 1.55 metres wheelchair turning circle in front of kitchen appliances, whilst remaining 1100 on the opposite side of the island. Lighting is another category within their energy credit, and there are various lighting credits. Overall low-level room lighting is credited under Green Star. This also reduces shadow contrast and improves consistency of lighting for visual impairments. With additional of task lighting in select location, such as an LED strip within joinery to light workspaces or up and down standard standing or table lamps, this reduces energy further. Indirect lighting, no naked bulbs is prescribed. Interestingly, this is mandatory in areas of wildlife protection due to the harmful effects on animals. The same can be true for people. Warm light is preferred for health, energy, and reduction of visual comfort. Whilst white light is most similar to daylight, we rarely look directly at the sun. People who live closer to the equator do prefer a whiter light, but in order to make white light, manufacturers add blue light to warm light, creating management of effects of blue light. Reflective surfaces and light shelves are important in spreading light internally. It's important to carefully consider the sheen of finishes, what surfaces you need to be reflective versus low or matte finishes. Filtered daylight is achievable via sheer curtains or Venetians. I'm a great advocate for Venetian blinds for cognitive accessibility. They retain external views out whilst allowing flexibility to manage light. Wider blades can act as light shelves reflecting light onto ceilings, then softly bounce light into internal spaces. Glare management is effective using fixed shading. This can eliminate direct sun penetration and aid design for visual light transmissions less than 10%. Visual contrast. It's beneficial to use material luminance contrast, i.e. 30% for the 50 mil strip, to improve building legibility, and using luminance contrast is an affordable tool for visual flow between spaces, particularly transitioning dark to bright and reverse. Humanising disability wet rooms. Rails typically wrapping around PWD toilets have been replaced with armrest rails. We worked closely with the manufacturer Caroma and supplier Reese to
devise an 800 care pan with armrests and a bidet seat combination. Previously not possible, and now this is available on their website as a result of this project. The armrests allow safer toilet use for ambient users, and the wheelchair transition. Rails can be easily moved into required location. They are incredibly strong and closer reach than wall-mounted rails, and they do not prevent traditional rail additions at later date if preferred. Whilst the shower bench and the toilet armrests are the only obvious disability fittings, we are yet to add planned mural on the opposite wall to fittings, providing further visual contrast on the door, on inside the door and light switch. Typically personalising disability toilets to selecting the colour of your typically personalising disability toilets is limited to just selecting the colour of your grab rails. For me, that's not really a good choice. I believe our personal forms visually disconnect from bathrooms disability fittings and correlates with the Living Building Challenges Sustainable Building Certification credit for valuing art within buildings. And there are actually a number of subtle art elements yet to be completed in this project throughout the house and inside. And I'm out of time. Then there's a whole lot on performance, and performance is so important because good thermal performance, post-brain injury, as many with cognitive disability, it's difficult to regulate your body temperature and not suffer the extreme heats and colds.
So sorry, I'm just mindful of.
That one's obvious. Oh, we did a landscape for dementia and all of the research things I'm going to procrastinate about.
Or talk to us about.
Thank
Wonderful.
you.
Thank you so much, Alison. With a cameo performance from Cleo. All righty, we have our final presenter for this section today. I would like to welcome Alex Grigich up to the lectern. Alex is also an undergraduate research student in occupational therapy. Hello, Michelle. Yes, Michaela will follow up with everybody around copy for slides that will be available for everyone. Yep, great question. Thank you. So I'm going to hand over to Alex, who's going to present the findings of a work around fatigue management.
Thanks, Louise. Hi guys, my name's Alex, as Louise just said, and I'll be presenting on co-design and traumatic brain injury, a participatory action study for fatigue management. So a very brief background. Fatigue following a TBI is a symptom that's chronic, multifaceted, and extremely complex. It has significant issues with impacts on occupations and overall quality of life. There's a lot of literature that talks about the diversity of experiences with physical, cognitive, and emotional components and how this manifests differently throughout individuals. But currently, this is an area of practice where there's very little to guide the clinical practice. Research does identify a variety of interventions. However, these often adopt siloed approaches or are conducted by singular disciplines. And this is proving to be ineffective in a concern that is multimodal. So the purpose of this study was to involve individuals with TBI, their key support people, and health professionals in a participatory action research study so that we could understand and co-design approaches for the management of fatigue. Like I said, we chose to use participatory action research, and we had 3 action cycles that were guided by co-design principles: need exploration, idea development, and idea refinement. We had 11 participants in total, 4 individuals with traumatic brain injury, 2 caregivers of children with traumatic brain injury, and 5 health professionals. And we used both individual interviews and group workshops as well. Like I said before, one of the key features of co-design is that it's participatory nature, and the participants really drive the input and the development of the interventions and solutions. So for the sake of time, I'm just going to run through the findings that were the principles that were co-designed throughout the process. The first principle was you need a team who are all on the same page. Throughout all of the cycles, there was a really consistent calls for a unified and a team approach. It was established that it takes a team to explore the possible causes of fatigue and manage fatigue. This was consistent with like using the same approaches, languages, and they all need to be on the same page with their respect to the understanding of fatigue and the individual nature of it. It was also identified that it's the role of the team to help the individual develop their own awareness through experiential learning. And this was really encouraging them to confidently explore the different options and identify what works best for their specific needs. The second principle was adjusting to life after brain injury and understanding fatigue. Participants highlighted that it was felt that the adjustment to the new them after traumatic brain injury was essential before they could start to work to mitigate fatigue. It was identified that this process takes time and it's often not a linear process. And the link between not having goals and a clear direction in life and the impact of uncertainty on fatigue was really portrayed throughout all of the cycles and highlighted by the participants. The concept of control was identified as an important mediator of the fatigue experience, with uncertainty and unpredictability described to exacerbate fatigue significantly. The third principle is the evolving nature of fatigue, and this was described by participants as fatigue as they adapt throughout life, and the priorities and demands they need to adapt with it as well. So like I said before, it's not a linear process, and fatigue evolves over time. There was identified that there's a constant process of managing change or uncertainty to become aware of the impacts of that on fatigue and the need to accept and adjust each time that this happens. Unpredictability that was attributed to environmental and sensory influences was something that came through really strongly as well. Participants said that this is something that they can't necessarily control, the sensory influences, but this is having significant impacts on their life and their fatigue as well. And the interplay between sleep, mood and stress and sleep medication and stress was something as well identified as having major impacts on health and wellbeing overall. The fourth principle was what's needed to manage our fatigue. And broadly, people identified that they need clear pathways for seeking advice. They need to know where to go for help, the need for personalised approaches and goals, remaining active and engaged with fatigue, and understanding helpful and unhelpful responses to fatigue. Implications of this study suggest that adoption and implementation of these principles may improve the experiences and outcomes of people with TBI, and its recommendation for the next steps going forward for guidelines, consensus statements, potentially, and a resource development of a lot of resources and educational context that are underpinned by these key principles. Thank you.
Brilliant, thank you. I joked with Alex that there's like 3 PhDs to come out of this work if she's interested, or if anyone else is interested. Any questions from any of our speakers before I wrap up my session and relax? Nick.
Oh, Nick, do you mind for the online audience? Sorry, I'm not going to get there fast.
So I predominantly work in pain, but recently I've been thinking about the similarities between fatigue and pain. And we often in chronic pain, we model pain that is problematic as a an unuseful hyperprotection mechanism. And fatigue is there as a protection mechanism to stop us kind of going overboard in similar ways, I think. And problematic fatigue can be similar. And when we push through pain too hard, we get into more pain. And I think when we push through fatigue too hard, we get into more fatigue. But also there's the opportunity for occupying a sweet zone, which drives bioplasticity, where we can push into that a little bit, but not so far that we cause problems. Did you have a think about that sort of approach when you were looking at the management of fatigue and brain injury?
You're going to be able to answer, aren't you? Sure. There certainly was a lot of discussion around where is that sweet spot. When people were talking about, yeah, how far can we push into it? When do we need to know to stop? When can we continue? And how do we manage that? And there's probably a lot of work to do there. I conceptualize, the more and more I look at this, I conceptualize fatigue in exactly the same way as I conceptualize pain. I think there is very much this multimodal condition that we need almost a similar setup of specialist services where people can go to, because there's a lot of misunderstanding around the health professionals around, but particularly in a range of different settings if they're not specialists and they're giving quite unhelpful advice to people.
I think the danger is if you rest too much, you become deconditioned and experience more fatigue or more pain. And they very often coexist, as we heard from Prof. Berlitz earlier on.
And sleep fits into it
yeah,
as well.
and sleep gets involved. Yeah.
Brilliant. Thank you. Thank you, Alex. All right, I would like to thank the speakers for that session, and I am going to sit down and have a rest and hand over and welcome Tamara Onsworth up to lead the next session.
Thanks so much, Louise, and for all the speakers. We're now shifting focus a little bit from technology and environment to evidence-based practice and community support. I think fatigue is a wonderful conduit between our two programs. So my name is Tamara Onsworth and I'm the Research Director here at the Hopkins Centre. I'm also co-lead of Program 1 with Tim Geraghty, and this afternoon we're showcasing some of the diverse projects that we have in Program 1. So we're going to be telling you about people's experience of hospital discharge and reintegration back into the community. We're going to touch on pain management, mental health, return to work and sustaining employment, community support, social support, and so much more. So I just want to do a quick shout out to say to the captioning people and the Auslan translators, I think you're doing a fantastic job, and we really, really enjoy having you here to support our diverse audience. So thank you so much, everyone. So we're going to start with a research presentation by Dr. Emily Bray. So Emily can't be here with us. She's just had a little bub, but she's pre-recorded a talk. And Emily is a research fellow and a citizen researcher here at the Hopkins Centre. She's also one of the lead investigators on the TRACE project. And she's actually led the first study, which focuses on the perspectives of people with spinal cord injury on their rehabilitation support at the time of discharge through to 3 months post-discharge. So I'm just going to hopefully get the video working, and we'll hear from Emily, and we'll be turning up the volume because she has, like me, quite a soft voice.
One moment.
with the video. Sorry for your ears. We actually have Rachel Bruff here in case we have any questions. I know it might have been difficult to understand Emily just because of the audio, and for the online audience, we will be providing a link to that video. But if anyone has questions about the first study coming from the TRACE data, we have Rachel Bruff, our wonderful TRACE project coordinator here. So any questions? No? Okay, we might keep moving. So I'd now like to welcome Samantha Borg to the stage. Samantha is going to share the results of a Hopkins Seed grant on opioid dispensing in the first 12 months post-discharge following spinal cord injury. Thank you very much, Sam. I'm very keen to hear the outcome of this project.
Thanks, Tamara. This was a study that was designed to look at opioid dispensing in acute spinal cord injury. So we know that opioids in the last several decades have increased significantly in terms of use and also associated harms and side effects. But in the context of spinal cord injury, far less is known. So a recent systematic review identified several limitations within the context of spinal cord injury and opioids. So limitations include highly variable opioid use between varying locations and subgroups of spinal cord injury, in some cases ranging from as low as 6% to so as high as 87%. The studies often include quite poor details of opioid use with little or no context of changes over time. And a lot of the evidence we have is mainly from that North American region. And to date, we only have one study in Australia. But it's not just opioids. So we also know that after a spinal cord injury, rates of polypharmacy or concurrent medications is quite high. So over half of people with a spinal cord injury on multiple concurrent medications. And specifically when opioids are used in conjunction with medications like anticonvulsants or benzodiazepines, we know that there's increasing evidence that there's specific side effects from those combinations, including risk of respiratory depression and opioid-related death. And we heard David talk about benzodiazepines and sleep in spinal cord injury this morning as well. So this study had two aims in trying to address some of those gaps in the literature. The first was to describe medication dispensing in the 12 months after discharge from inpatient rehabilitation, focusing both on opioids, but opioids in the context of antidepressants, anticonvulsant, and benzodiazepine medications. And the second aim was really more exploratory to see if there were demographic or medical variables associated with opioid use in that 12-month period. So data for this was from a broader observational study, TRACE, which Emily spoke about in the recording beforehand. This data is from a previous iteration of TRACE. So for people recruited between March 2017 and 2018. And we used a subset of patients for this with spinal cord injury. The data points that were used were admission to the spinal injuries unit and discharge from the spinal injuries unit. And both of these were obtained from hospital records. But the main area where we focused our data was from linked data from the Pharmaceutical Benefit Schedule, or PBS, and Medicare in the 12 months after discharge. So what does the cohort look like? So I said we had 68 people with spinal cord injury. They were predominantly male. The median age was 52 years. There was a similar mix between onset of spinal cord injury. And in terms of injury characteristics, paraplegia and incomplete injuries were the most common. We also, from the hospital records, identified that while people were in the spinal injuries unit, 16% had reported chronic pain during their stay there as a problem. So what does the medication dispensing look like?
At admission to the spinal injuries unit, and this is typically when we see patients transferred from other areas of acute hospital or other areas to the statewide services, 22% of people were on opioids at that point. This increased to half of patients on opioids at discharge. And of that half of those, so a quarter of patients had 2 or more types of opioids at discharge. This increased slightly in the 12 months after discharge. So we saw 56% with at least 1 or more opioid dispensed in that period. And we see similar increases, as you can see in the right-hand column, of the anticonvulsant, antidepressant, and benzodiazepine medications in that post-discharge period. But we weren't just interested, obviously 12 months is a long time. We're also interested not just in a single point, but what that looked like over time. So we did see whether there was any change in the mean number of medications dispensed over the 12-month period. There wasn't any evidence of an effect for that for any of the 4 medication classes of interest. And our second part of the understanding the prevalence was looking at concurrent dispensing. So nearly 1 in 2 were dispensed opioids and at least 1 other medication class of interest. So specifically, we saw people who were dispensed opioids and 1 class of medication, but 22% were dispensed opioids and 2 of the other 3 medication classes of interest, and 6% were dispensed all 4 medication classes. We were also interested in variables that were associated, as I said, with opioid use. So opioids at the point of discharge from the spinal injuries unit were important. So people who were listed as having opioids at discharge were nearly 7 times more likely to be dispensed opioids in that 12-month period after they were discharged. I said we also had Medicare data, and for this we were interested in having a look at, in particular, GP visits. We know most opioids are prescribed in the community. For this, we saw that people who were dispensed opioids in the 12 months after discharge, that they visited a GP at a much higher rate than those who weren't dispensed opioids. So 19 times compared to 12 times for those who weren't dispensed opioids. But what does this all mean? So we saw that opioid dispensing in that post-discharge period was quite common, as was the concurrent dispensing of opioids with some of those other medication classes. Compared to a recent Canadian study that also looked at concurrent prescribing of opioids with these similar medication classes, the participants from this study had a much higher rate of concurrent dispensing. So there is quite high potential for drug-drug interactions, which is, I guess, concerning. And a lot of that opioid at discharge is obviously an important area to look into. And while this is the first study that does use PBS and Medicare data to look at opioids in the context of spinal cord injury in Australia, we acknowledge that it is a small sample size. 68 people is not a lot, so the findings aren't necessarily overly generalizable. And while we did have that small context of pain for participants while they were in the spinal injuries unit, we were obviously lacking a lot of context for pain when we saw most of our data, which is in the 12 months after discharge. Based on some of the limitations, there's obviously more work to be done in this space. So studies that focus on larger sample sizes and longer observational periods. So we didn't see any fluctuations over a 12-month period, but if we looked over a longer period and with larger sample sizes, there might be more evidence to suggest changes in dispensing over time. And also studies that address some of the other limitations for opioids in the spinal cord injury context. And so some of those studies are currently in progress at the moment. So I guess watch this space. And finally, just like to thank the funding partners, Hopkins and Mace, And this paper was accepted literally yesterday, but if you're interested in reading more, the QR code will link you to the pre-printed version of the paper. Thank you.
Thank you, Sam. I think most people know that data linkage studies are incredibly difficult to conduct. So, yeah, very ambitious project. Do we have any questions for Sam before we move on? Nick.
I knew it would be Nick.
I knew it would be Nick.
Hi, Sam. Thanks very much. I found it interesting that a lower proportion, was it about half of the people on the unit reported chronic pain, but then so I think around a quarter reported chronic pain, but then half were discharged on opioids, which I think usually in a spinal injuries cohort, those would be given for pain that was experienced in a chronic nature rather than episodic nature. So I feel like there's a sort of discrepancy in that. Do you have any comments on that?
Yeah, so again, that data around chronic pain was extracted from, I think, AROC data at discharge reporting on various problems. So chronic pain is one of those. It was 16%, which again, we wouldn't expect to see maybe half of people discharged on pain medication, and especially, 2 or more types of pain medication if that's the case. But we don't, I guess, without really understanding the context of the prescribing, that might also change some of why the rates of dispensing are so high. I think recommendations in this paper came out around some more information in discharge summaries and stronger communication with general practitioners in being able to look at this. But in terms of, that context, I don't know, I acknowledge that I'm not a clinician in this space, but it might be prescribed as a, in case you need it, as opposed to a, you're actually going to use this because you have chronic pain. And that's always a limitation with dispensing data and charted medications, as we don't know what that actually looks like in terms of usage. He's coming back for more.
I was just going to say, I think if you repeated the study now, you might find less of an escalation in the 12 months post-discharge with modern regulatory changes around opioid prescription especially.
Yeah. And so I sort of briefly touched on future research in some data linkage space on spinal cord injury, which has follows people for 2 years after injury. Again, that data is quite old because obviously data linkage takes a very long time to get and you have to wait for that time to have elapsed first. But definitely think that there'll be some more interesting things to come. But this data is, very much a starting point of where we'd be looking at, and very likely a benchmark of where we might be looking at, future things to sort of compare, because obviously there've been regulatory changes in the last couple of years.
Thank you very much, Sam, and congratulations on that data being accepted for publication. It's tremendous. I'd now like to welcome Dr. Christy Hogan to the stand. So Christy's also going to present some data, some early data from the TRACE-3 program.
Thank you, Tamara. So today I'll be discussing the influence of resilience and hope on stress and quality of life during the early community reintegration period after significant injury. So this research forms part of the larger TRACE-3 project, which surveys and interviews people with brain and spinal cord injury up to 2 years post-discharge. And surveys are conducted at 3 time points, so that's at discharge and 3, 12 and 18 months post-discharge. This interim analysis focuses on the data collected at discharge from hospital and 3 months post, providing us with a snapshot of people's experience of well-being during the early community reintegration period. So participants were recruited from the brain injury and spinal injury units at the PA hospital between June 2023 and July 2024. We have a total pooled sample of 86 people, so that's 45 people with ABI and 41 with spinal cord injury. People with ABI and SCI were similar on age, but people with SCI were more likely to be male, and the length of stay was also longer, as you would expect with spinal injury. Additionally, motor function was lower for SCI, and cognitive function was lower for ABI. For our cohort, levels of depression and anxiety did not significantly change over time for either sample, and this is pleasing to see given other literature showing an increase in mental health problems post-discharge. Stress, on the other hand, significantly increased for both samples, accompanied by moderate effect sizes, and this finding is unsurprising during this key transition period. People with spinal cord injury had significantly higher anxiety at discharge and higher overall mood symptoms at 3 months post compared to people with ABI. And we were keen to understand what factors might contribute to these changes in stress, particularly people's own personal resources for coping. One such well-recognised personal resource is resilience, which refers to the ability to adapt or bounce back following adversity and challenge. One real-life example of the importance of resilience during the early reintegration period comes from a family caregiver of a person with ABI who in a 2011 study stated that there's very little that actually knocks him down. He's the most resilient person I know, very resilient, and so I think it's that bounceability that he can see the positive side in everything. There are differing views on whether resilience is a stable, enduring trait like personality, or whether it's fluid and changeable, increasing or decreasing in response to adversity. Whoops. In the brain and spinal literature, higher resilience is associated with better mental health, community integration, and quality of life. However, it's not well understood how resilience contributes to better outcomes. One possibility is through people's mindsets in times of stress and uncertainty, or their ability to see beyond the current challenge. In other words, hope. Hope is commonly defined as a multidimensional, dynamic life force characterized by a confident yet uncertain expectation of achieving a future good, which to the hoping person is realistically possible and personally significant. In other words, having confidence in a positive outcome in an uncertain situation. TRACE-3 measured resilience and hope at both discharge and 3 months post using the Resilience Scale 14 and the Hearth Hope Index. Levels of resilience did not differ between the ABI and SCI groups or change over time, suggesting relative stability. However, we found that hope was significantly lower at 3 months for both people with ABI and SCI compared to discharge, suggesting that confidence in the future had significantly diminished after several months in the community. So the question then becomes, how are resilience and hope related, and can they potentially account for the increase in stress during this period? To explore this, we ran a hierarchical regression to see if resilience and hope at 3 months could predict levels of stress at 3 months after controlling for discharge stress and injury type. In the first step, 13% of the difference in stress level was explained by the injury type and stress at discharge. In step 2, resilience and hope explained a further 21% of the difference in stress at 3 months, with injury type and resilience both acting as significant predictors. Irrespective of injury type, graded resilience was protective during community reintegration, whereby people with more resilience were less likely to experience an increase in stress. We were also interested in people's quality of life or their broader satisfaction with life. And given the finding that resilience was stable between discharge and 3 months post, we tested the following mediation model and identified that hope at 3 months fully mediated the relationship between resilience at 3 months and quality of life after controlling for levels of resilience, hope, and depression at discharge. This means that individuals with enduring resilience throughout the hospital to home transition were more likely to retain a sense of positive hope or positive expectation for the future, which in turn contributed to better quality of life 3 months after discharge. So what does this mean overall? Overall, personal resources such as enduring resilience characteristics can represent either a protective or a risk factor for adjustment difficulties after brain and spinal cord injury. Clinically, our findings highlight the importance of understanding people's long-standing ways of coping with stress to identify those at greater risk of heightened stress during the hospital to home transition process. Moving forward, the TRACE project will continue to build on the current data by examining longer-term stability and fluidity of resilience and hope at 12 and 18 months post-discharge and in relation to various life events such as returning to work, as well as their relationship to mental health and wellbeing outcomes. Such understanding will help guide the focus and optimal timing of psychological support interventions. And in the literature, there is preliminary support for resilience-based approaches, such as increasing people's sense of control over their care decisions, training or problem-solving and self-advocacy skills, as well as creating opportunities for mastering and building a positive self-identity. So I'd like to thank the TRACE research team and all the participants who have volunteered their time to share their personal experiences with us, because without them, this research would not be possible, as well as our funding partners. Thank you.
Thank you very much, Christy. Lovely to have some research on mental health. Do we have any questions for Christy? Ben Turner, did you notice where that quote came from? I don't know if Ben's in the audience. See, things come back to haunt you, Ben, your PhD findings. Okay, well, we might keep moving. Thanks very much, Christy. So I'd now like to welcome Emily Allen. So Emily is one of the clinical fellows at the Hopkins Centre, and she's about halfway through her clinical fellowship. So Emily's going to talk about aggregate healthcare data dashboards for visualising healthcare data. Welcome, Emily.
Hi everyone, thank you. My name's Emily Allen and I am a clinical fellow of the Hopkins Centre in 2024. And today I would like to introduce my clinical fellowship research topic, which has the formal title, Investigating the Factors Influencing Usability, Usefulness and Continued Utilisation of Aggregate Healthcare Data Dashboards for Rehabilitation Clinicians. We refer to it in short as the Rehab Data Dashboard Design Project. Firstly, what is a dashboard? A simple explanation by Wexler et al. Is that a dashboard is a visual display of data used to monitor conditions and/or facilitate understanding. We are all familiar with data dashboards in our cars, on our smartwatches. We track sleep, exercise, food delivery, screen time, the weather, water bills, fuel prices, or our sporting team. The thing that highly utilised dashboards have in common is that they are easy to use and useful. My research question surrounds the use of data dashboards by frontline clinicians and clinical managers in healthcare, where their use is relatively new and presents opportunities. Specifically, what characteristics make them useful, easy to use and utilised? The idea for this research stems from 2 years ago when the Quick Start service, a new arm of the Queensland Spinal Cord Injury Service, was launched with temporary funding, offering a statewide in-reach model of support. Along with some clever colleagues, in particular, Dr. Chow Do, I was involved in rapidly building a tool to collect and analyse data about patients referred to this service, which is now essentially the main entry point to QSIS. This means it houses a rich registry of all new spinal cord injuries in Queensland, and using Power BI, we found we could now translate this raw data into insights about our cohort, live and in real time. When building the early iteration of the dashboard, we needed to incorporate some best practices in graph design, particularly for reducing cognitive load, of which there are many. One example is the concept of the data to ink ratio explained in this short video. Remove borders, reduce colours, remove special effects, remove bolding, lighten labels, lighten lines, remove lines, direct label, less is more. There's the before and after, if you missed it. So we know that data visualization helps us to see the data. A step further is to explain the data with story. This is where it's most powerful. Charles Menard's 200-year-old graph showing Napoleon's army's advance into Russia is regarded by many as the best graph ever made. It shows 6 different sets of data at once. First, longitude and latitude, then the army's direction of movement into Moscow and their retreat. We see the size of the army shown by the width of the bar. We see that size significantly reducing as they progress due to fighting, desertion, and the weather. With the time and temperature shown at the bottom, we can see the cold Russian winter claimed thousands of lives. We know the human brain thinks and remembers in stories. The question is, do you prefer the full report or the executive summary? From this idea, the Hopkins Centre Clinical Fellowship is currently affording me the opportunity to conduct 4 main research activities. Firstly, conducting a national benchmarking survey on dashboard use in spinal cord injury services. Secondly, conducting a scoping review of the academic literature, investigating factors that impact dashboard usefulness, usability, and continued utilisation in healthcare. The scoping review protocol has been published. We have completed title and abstract screening and are about to start full text screening before moving on to data extraction. Thirdly, we're planning to conduct a focus group study in QSIS. The focus group study seeks to understand clinicians' experiences, beliefs, and preferences regarding dashboards, including the metrics that would be most useful to have displayed. We're looking at recruiting approximately 20 participants from across teams and disciplines who are working at the entry points to QSIS. We've received ethics feedback and hope to have approval soon after some minor amendments. Fourth and finally, we're leveraging the findings of the benchmarking, scoping review, and focus groups to continue to build a prototype dashboard for QSIS clinicians. I'll focus today on sharing some results of the first activity, the benchmarking survey conducted this year. We surveyed spinal cord injury services to find out how and why dashboards are being used, and I'll display some of the benchmarking results on a dashboard. We received 81 responses from across Australia and New Zealand, most identifying as clinicians and or clinical managers. We found that not many spinal cord injury clinicians are using a dashboard. 27 respondents, 33%, are aware of a dashboard available to their service. 19 respondents, 23%, have used a dashboard, and 10% report their service was consulted about the design of the dashboard. In addition, the most common software reported to be used, if known, was Power BI. Amongst the 19 people who use the dashboard, we found usefulness is low. Only 8 users, 42%, say their dashboard displays useful metrics, and only 10 users, 53%, trust the data. Ease of use is low. Only 7 users, 39%, find the dashboard quick and intuitive to navigate, and only 9 users, 50%, find it quick and easy to access within their workflow. But most people agreed that the visualization of data allowed them to understand the data with minimal effort. We asked spinal cord injury clinicians what metrics they would like in a future dashboard. The top 5 metrics on the wish list were patient types, patient numbers, patient journey, patient demographics, and staff activity. We received some great qualitative feedback, which we categorised into 3 themes. Spinal cord injury clinicians and clinical managers are interested in engaging with data. They see the value and opportunities with transparent, meaningful data. 2, they identified many uses for dashboards: monitoring trends or change, managing workload or resourcing, benchmarking quality activities, efficiency, and situational awareness. Thirdly, they believe they would use dashboards if they were spinal cord injury specific, clinically meaningful, intuitive, accurate, up-to-date, relying on automatically collected data, used for good intentions, available to all, and accompanied with staff time, training, admin, and tech support. I have been asked to share a little bit about my journey undertaking a Hopkins Centre Clinical Fellowship, given I am currently at the halfway point. And I have to say that this image resonated with me. I'm very grateful to the Hopkins Centre, Griffith University and Metro South Health for the opportunity to learn and be challenged, a zone that I'm really enjoying being in and highly recommend to clinicians wanting to test the waters with research. I have moved from don't know what I don't know about research processes to knowing what I don't know and to knowing some very important things, a long list of which is here, which I won't read out, but includes things like writing a scoping review protocol, writing a research protocol, using EndNote, using Covenants, and applying to ethics. I would like to acknowledge the fantastic team supporting me on this fellowship journey. Tamara Owensworth, Tim Garrity, Delina Amsters, Sarita Shores, Camilla Schroeder, Jessie Mitchell, Chow Doe, Susie Stoikoff, Diane John Dranego, and Kylie Persas. Thank you.
Thank you, Emily. That was excellent. And thank you for promoting our clinical fellowships as well. Do we have any questions for Emily on her fellowship or data dashboards? Or anything really? No? Oh, yes, we do. Oh, Kylie, wonderful. Trust it to be a colleague that asks you a question.
Really, it's more of a comment. I just wanted to say thank you because I'm immersed in looking at a whole lot of data at the moment for various things. And I wish it was taking the direction that this is taking in because that was just a joy to look at. So thank you.
And I've got the next question. When are you enrolling for your PhD?
Oh.
Question taken on notice.
Are you going to help me with that?
Nothing like a public decoration. Oh, Tim. Gosh, it just keeps giving.
Just to carry on that theme, when are you applying for your first funded grant?
My
First funded grant.
Oh, and when are you going to help me with that?
Tim, you're scaring me.
That's all right. Just take that as comment.
I'm going to apply. I'm going to compete in the $500 prize.
Oh, yeah. Any questions? So this is what we call clinician capacity building at its best. It's just remarkable. Thank you, Emily. Okay, so I'd now like to introduce the next clinical fellow, if you're brave enough to come to the stage, Kristen, after that. So Kristen Tynan is a senior clinical pharmacist in the Pain Rehabilitation Centre, and Kristen is one of our Bright Sparks recipients. And so it's a shorter clinical fellowship, and we're looking forward to hearing about your research related to monitored medicines during the waitlist period for the pain clinic. Thanks, Kristen.
Yeah, thanks, Tamara. So yes, so my project was looking at monitored medicines affected whilst waiting to access the our persistent pain clinic. So due to the increased awareness of opioid harms and the need for better pain management, we've seen a bit of a rise in referrals to our pain clinic. In addition to our patients, many of them are also taking multiple high risk or monitored medicines. So monitored medicines is a selected group of high risk medications that are required to be recorded in a real-time monitoring system when they're prescribed and dispensed. So each state and territory have their own system. Here in Queensland, we use what's called Q-script, and these medicines include our opioids, gabapentinoids, so things like pregabalin and gabapentin, and benzodiazepines. All of these have been associated with some significant harms, particularly when they're used together. So harms include respiratory depression and unintentional overdose. Both the America and Australia, so America's FDA, Federal Drug Administration, and here in Australia, our TGA, Therapeutics Goods Administration, have issued safety alerts for these combinations, advising all clinicians to judicious prescribing and evidence-based decisions to balance efficacy and harm, especially in our patients with any respiratory disorders. So our study aimed to investigate whether our patients' use of these high-risk medications
change whilst waiting to attend our clinic. So a retrospective chart audit was conducted on 682 randomly selected sample of patients who were referred to our pain clinic between January 22 and December 23. Demographic and medication data was extracted from 2 time points. The first being the GP referral letter and the second being EPOC questionnaire, which is completed close to or at their first clinic appointment. So EPOC means Electronic Persistent Pain Outcomes Collaboration, and it's a questionnaire that we use. It consists of standardized set of questions. It's designed to gather patients' self-reported information, and this data helps us guide treatment decisions, measures outcomes following treatments, and serves as a benchmarking tool for the pain management sector. So from our sample, 500 had complete data for analysis. We found the median wait list duration was 320 days. And of this, it was not found to predict opioid dose at their first appointment. 64 of our sample were category 3, meaning they needed to be seen within 365 days of their referral. 32% of our total sample were seen over this time. To the left, this figure shows the combinations of medications at GP in the black and at the EPOC time point in white. As you can see, though, reassuringly, there wasn't much change in overall medication use between each time point, whilst the patients were waiting to attend clinic. On the right, of the patients who were taking opioids, an oral morphine equivalent dose was calculated. So this tool enables one to convert all different types of opioids into a comparable value, which is useful in research, but it's also cautiously used in clinical practice when we're switching different opioids. You can see that at GP time point there, GP referral, the median morphine dose or oral opioid dose was 39 milligrams per day. And then at EPOC, it was just ever so slightly increased at 45 milligrams per day. Then we looked at patients who were considered on a high opioid dose of greater than 90 milligrams. And at GP referral, there was 14% of our sample, and at EPOC, 15.6%. Because there was minimal change or minimal to no change in the proportion of medications between the 2 time points, we wanted to see whether there were any individual patterns of change. So this scary looking figure is a Sankey diagram, which helps us see if patients start or stop taking certain medications whilst they wait to attend the clinic. The Sankey shows us not just the overall numbers, but also specific pathways of change. The width of each path represents the proportion of patients who followed that route. Now, I just wanted to draw your attention just to a few pathways, so don't get too frightened. Just the top group there, the aqua group, shows 197 patients taking opioids only at GP referral. Now, if you look at the yellow arrow, this shows a proportion that reassuringly changed at EPOC to no medications, which looks roughly half of that total 41. If you then look in the middle there, the sky blue group or the orange arrow, the number who were taking opioids and benzo combinations at GP dropped the benzos at EPOC, but most remained. Now, if you just look at the dark navy blue group and the red arrow, 40 patients taking high-risk combination of all 3. A small proportion changed to opioids only. Many stopped the benzo, but most remained on that combination. If we just look at that group of patients, 30 at EPOC who are on that all 3 combination, we found that 19 of those self-reported they had a respiratory problem. So these 19 patients would be considered more at risk of harm. So the audit found minimal to no increase in patients' use of high-risk medications whilst they're waiting, which is reassuring and suggests that perhaps there's been some prescribing practices, or prescribing practices have improved compared to some of the reports in the literature. And this data will then inform the triage process, helping us assess polypharmacy combinations of high-risk medications and patients with respiratory conditions more effectively. So I'd just like to extend a big thank you to everyone involved in this project, a big thank you to my team, the big thank you to the Bright Sparks grant, which has provided me with the time and support to conduct this detailed audit, something I wouldn't have been able to do alongside my clinical duties. And this experience has also been invaluable to my own research development and has provided clinically useful data that will support future service planning and improvement at our pain service.
Thank you, Kristen. I'll also just add thanks to Christy Hogan for helping us navigate the world of the Sankey diagram. We have some additional skills now in graphing data. Do we have any questions for Kristen? No? Wonderful. You're off the hook. Thank you so much, Kristen. Okay, we're now going to move on, and I'm really delighted to say that we have two clinicians from the Queensland Paediatric Rehabilitation Service. At least I hope we do. I haven't spotted you. Oh, just one. Okay, I think is that Janet Danielson? Wonderful. We're so pleased to have you here. It would be a nice shift, I think, in focus to hear about what you're doing at QPRS, but also in relation to mental health. So yeah, welcome, Janet. Really pleased to hear from you.
Thanks. Okay, so a huge thank you firstly to the children and adolescents with comorbidity of brain injury and mental health diagnoses and their families, because it's really their stories that helped motivate myself and our project team to consider better solutions. Okay, so today I'm going to be talking about an innovative model of care we developed and implemented at the Queensland Paediatric Rehabilitation Service, QPRS, at the Queensland Children's Hospital. At QPRS, children with moderate to severe acquired brain injury, aged 0 to 18, and their families are supported by a multidisciplinary rehabilitation service through their acute, subacute, and long-term outpatient rehabilitation care until they reach adulthood. Children are seen close to home using clinical approaches that focus on family and person-centred care over their development to adulthood. We're a statewide service providing outreach to regional centres as well throughout Queensland. Children with moderate to severe acquired brain injury have resultant chronic and lifelong disability. In childhood, the impact of an injury may be evident immediately, such as changes in a child's physical skills or sensory function. However, the majority of children grow into their difficulties over time as they fail to make expected developmental gains with their cognitive communication, social, emotional, and behavioural skill development. So in turn, these difficulties impact on both the child's longer-term functional outcomes as well as their family's long-term function. As such, the impact of a child's moderate to severe brain injury is complex, wide-reaching, and emerges over time, especially during the period of adolescence and young adulthood. So a key predictable and preventable outcome of childhood-acquired brain injury is poor mental health. And what you can see here is children with a chronic health condition are more likely to have mental health concerns as compared to the general population. But children with an acquired brain injury present with a much higher risk of developing mental health concerns. So 14% to around 33 to 63%. So that's a significant risk. So over the course of their lifetime, this cohort has a 50% chance of meeting diagnostic criteria for a mental health diagnosis, many of them presenting with more than one mental health concern. So in 2021, to understand these concerns better in our patient cohort, we completed a chart audit of our school-aged children with moderate to severe acquired brain injury seen in one of our outpatient long-term rehab clinics across both metropolitan and regional Queensland. We also surveyed our staff and rehab colleagues nationally to understand their experiences with accessing mental health care for children with brain injury. So consistent with clinician observations, the chart audit showed that of the 404 school-aged patients seen by our team that year, almost half presented with mental health concerns, and 21% of them had 2 or more presenting concerns. So we saw a range of some of concerns that were quite predictable for us, that we anticipated, like anxiety, behavioural regulation adjustment. But we also saw a high level of complexity, including psychiatric presentations, such as eating disorders, gender dysphoria, substance use, suicidal ideation, that an outpatient brain injury rehab service is not equipped to manage. So our young people presenting with these mental health concerns were also likely, as a result, to be presenting with other adverse outcomes, such as reduced school attendance or suspension, relationship breakdowns with friends, family, extended family, people in their community, and youth justice involvement. So at the same time, our clinicians reported having incredible difficulties accessing mental health care for their patients, and that was only exacerbated after COVID. So consistent with this and with prior research in the area, only 45% of our patients with mental health needs were able to access any form of mental health care in the community. Common barriers were limited services in the community who were willing and able to support a patient with a dual diagnosis of brain injury and mental health, complexity of post-injury cognitive communication difficulties, which impacted on the young person's ability to participate in traditional talking-based therapies, and difficulties engaging patient, family and community providers in mental health care as mental health concerns may be conceptualised from a more organic medical model or attributed solely to brain injury rather than other modifiable factors. So we gave it a whirl. We applied for a Working Wonders grant and we had enough funding to add 0.1 FTE psychiatric consultation to our ABI rehab outpatient service. So the solution by adding it to our service was that our service follows families through until they reach adulthood. So there are a known and trusted outpatient team, multidisciplinary team already around the patient. So, during the pilot period, 15 young people and their families attended the clinic. Each parent and, where possible, child were asked to complete questionnaires about their mental health, family function and clinic experience. And the follow-up at 3 and 6 months post-clinic saw early trends towards improvements in caregiver stress, parents' relationship with their partner, extended families and parent friendships, reduced impact of the child's mental health difficulties on the parent's ability to attend work and fulfil their work roles, the family's ability to access community outings, and parents also reported trends towards improvement in the child's ability to engage in school and family activities. The attendance and response of the families that participated was overwhelming. They spoke extremely highly of the program and the support and the ability to have a concentrated period of time to really focus on their mental health in the context of the acquired brain injury and problem solve with the physicians. So the other thing is staff wellbeing was considered. The complexity of patients and the fears, worries and concerns of families weighed heavily on the majority of our staff who were working with these incredibly complex families. So after establishing the clinic, clinicians consistently rated themselves as having higher levels of wellbeing than prior to the clinic. And there were several reasons for that, including feeling supported, being able to optimise patient care, to be able to come up with a comprehensive case formulation, to not have the patient siloed into pieces, and also to be able to consider medications with a mental health clinician as well as a rehab clinician in the one consult. So the initial success of our pilot continued on to trying to develop a business case and extend the FTE funding. We were successful in securing 0.1 FTE from the mental health branch, and the psychiatry position sits under the consultation liaison team in the Children's Hospital. We could absolutely reach more families with more FTE, but we're going to work with what we've got as part of a research project to long-term to really consider how we can best advocate for this group. The clinic runs fortnightly alongside existing rehabilitation clinics, both metropolitan Queensland and through telehealth to our regional families. The other thing is we chose to do a collaborative care model over the traditional consultation liaison model of care. And we opted against using consultation liaison model because for our clinic and families, the features of that model would likely exacerbate some of the barriers that patients with brain injuries already experience, such as siloed care, different systems for documentation, limited opportunity to shared education and care, and difficulties adapting to cognitive communication needs. So the collaborative shared care model offers unique advantages for our patients, including familiar and safe setting with a trusted team, improved sense of satisfaction with mental health care in light of acquired brain injury, with everybody discussing in the one room with the family as a key partner in developing a plan, opportunities for acquired brain injury and mental health education across team, co-location of resources, medical records and staff, and which enabled continuity of care between mental health and rehab. Okay, where to from here? Embedding, at this time, the clinic is well established, largely self-sufficient, and managing and growing a huge flow of referrals. The clinic and opportunities for peer consultation and professional development continue to provide support for our staff, enhance learnings and trainings for new and junior staff, and support a more collaborative relationship with our mental health colleagues. And in addition, what my neuropsychologist helped me locate was a health economist to commence the formal evaluation of our clinic to understand the value and impact our clinic has on young people, families, and health outcomes. Thank you.
Thank you so much, Janet. I think you would agree that there's quite a few parallels there with adults with mental health, but you have that additional challenge of the neurodevelopmental pathway for your clients. And congratulations on getting that continued FTE with the psychiatrist. That's no mean feat. Thank you very much, Louise. Sorry, you wanting to say something? Oh, okay. Yeah, sure. Absolutely. Yes, let's do that. 5-minute movement break. Yeah, that's okay. The only thing is we didn't get a question.
No, that's okay. That's all right. And Owen with the big card. Yeah, well, she was on hand down, so she's running for the but Owen was heavily involved. With one of the key people, you know.
Okay, everyone, if I could ask you to take a seat. I'm sorry, that was just a quick movement break. We have 4 more speakers and then we have afternoon tea. Thanks, everyone. Tremendous, thank you. We now have a series of presentations that are from the teams of people who were successful in last year's Hopkins Sea Grant round. So starting off, I have not seen this lady all day, but I think she's hiding in the audience somewhere. Karen, there she is. Wonderful. So starting off, we're going to hear from Karen Water, who's going to share some of the outcomes on the sustained employment following ABI and spinal cord injury sea grant. Welcome, Karen.
Thank you. And it's working. How exciting. Lovely to see you all here this afternoon. I'm presenting on behalf of our team and particularly Dr. Jessie Mitchell, who is the brains behind all of this. And she's put this presentation together. So we'd like to thank our team and also thank the people who've given their time as part of our project and shared their employment experiences. So employment is vital for economic security and quality of life for most people in Australia. But for people who experience a life-disrupting injury, such as brain or spinal cord injury, they can face many challenges in returning to, finding and sustaining employment. And we know that research shows us these populations often have low employment rates, and for those who do return to work, they can have difficulty sustaining that, and job withdrawal is really common. And many people are leaving the workforce well before retirement age. So we wanted to understand the experiences of people who've sustained their job for at least 12 months with the same employer following a brain injury or a spinal cord injury, and understand not only the experiences of the person with injury, but also the experiences of someone who's helped them in that return to work journey. So an employer, a rehab clinician, a service provider. From this, we can understand employment journeys, identify strategies to support sustained employment, and hopefully help employers to create inclusive workplaces. So the wonderful Jessie used a qualitative case study methodology to develop a range of employment journey studies. We recruited our participants with brain injury and spinal cord injury and their sort of work other, and conducted semi-structured interviews to employ those journeys and identify enablers of sustained employment. This data was then thematically analysed. And at the same time, Jessie also helped develop these individual employment journey maps, or a graphic visualisation of everyone's journey back to employment and then sustainability of employment. The second part of participation involved a co-creation session where participants finalised their journey maps and generated a written or video account of their employment. It's such a Jessie graphic, isn't it? It's beautiful. So this is our preliminary thematic analysis finding. We had this big overarching theme of personalised pathways to sustained employment. So these individual pathways were underpinned by 2 things: support, access through resources and relationships, and flexibility and change in how people thought about and participated in work. And they're quite interrelated, and I think we'll hear that as we go along. So resources and relationships, personal resources included things like drive, motivation, self-advocacy skills, friends and family. We had rehab and employment services, and the third was workplace supports, such as knowledge and understanding from colleagues, organisational resources, and workplace culture. Within flexibility and change, this included those injury-related changes and how they impacted work lives post-injury, career choices, such as adaptation and adjustment to injury, role and professional changes, education, training and career progression, and those reasonable accommodations.
such as strategies and supports to support people to participate in work. That might be transport, aids and modifications, cognitive strategies, different role requirements, flexible work. This is what I've got two really brief journey maps, and then I'm going to hand over to one of our lived experience co-researchers. So this is Dave's map, and Dave, you can't quite see down the bottom, but we've got our 1 to 4. He's got a 4-year return to work journey that he talked with us about. And you can see along the journey map, we've got those different time points or things Dave felt were important in that journey from back to work and then sustaining work. So those initial phases were around returning home and relearning how to do things, the initial planning and support to return to work, and then returning to work at 6 months. And the middle of Dave's journey is really interesting because he was back at work and realised that old team really wasn't working for him, and that was not the best fit. So he worked with known and trusted rehab providers. He really emphasised how important that was in his return to work journey. He was able to self-advocate with his employer to try some different employment options within the broader organisation. And it's not quite a loop-de-loop, but this is him trying out different career choices and options to find a good work fit and to find a fit that was better for skills, flexibility, and had a more positive team culture. And he's there now and sustaining that really nicely. And I have to say, in our bigger versions of these, every time point has an explanation and multiple quotes, but we need an hour for that, not 7 minutes. So we get what we get. It's really interesting to look at these different journeys for different people. So this is Matt's journey, and this is a 12-year return to work journey. So Matt had a spinal cord injury, and the first 8 years post-injury were really spent around engaging in rehab, regaining his independence, in integrating back home and into his community. Then he chose to explore return to work and undertook a new career path. And he entered the workforce as a disability support coordinator. Matt used his experience in managing his own health condition and rehab needs to get that job, and was really supported and valued by his managers for bringing that lived experience to that role. And Matt and his manager, Donna, have done the interviews about Matt's journey, and they've identified the value of having an employee with lived experience and can relate to their clients, and how Matt is supported within the workplace for accommodations and those sustainable strategies for work, whether that's accessibility within the office, working from home, and doing part-time work. So what we're finding across these journeys is they are unique and they are individual. And even though we have really similar components, and they're often repeated components over time, but the importance of them is quite different depending on people and their journeys. So they're really individualised experiences. And to finish up, I will hand over to our co-researcher, Mr. Knut Schneider.
My name is Knut Schneider, and I'm a German national living in Australia for 8 years by now. And my profession is that of a chemical researcher. So I'm a scientist. So I had my brain injury January 2022. I was on the way home from work at the time with my private e-scooter and was going from the train station to home. I must have missed a crack in the ground because, due to nobody's fault other than my own, I woke up a month later in hospital. With a brain injury, I think it is similar to any traumatic event happening to you, be that the loss of a loved pet, the loss of a loved one, or a breakup, or losing a friend due to growing apart, or all those kind of things. If you sit at home and do essentially nothing, you start ruminating on things that are better left alone. And so going to work gives you not necessarily an outlet, but it keeps your mind engaged in doing something. And so in that regard, I just want to, the reason why I am doing all these research projects, help all these research projects with brain injuries, is I was so lucky that I had a good outcome due to also the service providers that I had and their knowledge. So I want to be able to help other people to also have a good outcome. And for example, that they're not in one of the best places to have a brain injury, which is the PA hospital. Let's say they're out in Rockhampton or somewhere. I want the people there to also have the opportunity to have a good outcome because their service providers also know how to handle these cases. If you are in a bad situation, you can see other people made it out too. They also had a bad situation and they got out, and they also had obstacles that might be the same or similar to yours, and they were able to overcome them, and maybe they share how they overcame it. And it's always nice to see other people have it bad too and they got out of it, so I can do it too. My name is Knut Schneider.
Ooh, that's not meant to happen. Thank you. Thank you so much, Karen. Wonderful to see the outcomes of that seed grant. Do we have any questions for Karen about that seed grant? No, it should be popping up again soon for another presentation. Okay, so it's now my pleasure to introduce Dr. Susie Stoikov, who's a physiotherapist with Metro South Health. And I believe that Susie is presenting on behalf of the team for their seed grant on health literacy, a change champion co-design approach.
So thanks so much for having me. Like Tamara mentioned, we are looking at a project implementing health literacy principles into rehabilitation using a change champion and co-design approach. So throughout this presentation, I'm going to talk about what we've done, what we've learned, and what we've got left to do. So we did a pre-evaluation survey with the team, and this team is the spinal outreach team, and they are a team of expert clinicians working in community rehab for people with spinal cord injury to provide all-of-life care. And so this team did 2 surveys for us. The first one was looking at what they believe their own skills and knowledge were around health literacy, but they also talked about, well, what are the perceptions of the organisation they work in? Because we know that health literacy extends just beyond the individual, and we really need to look at it from an organisational perspective. So after we did that, we audited the team. And so when I mean audited the team, we looked at their workflows for each of the professions. And so we got an understanding of where are the opportunities for health literacy, where do they interact with their clients or consumers or other allied health professional or health professionals, and what are these high touch points that happen around health literacy. And so we looked at those and we compiled them, and then we spoke to a group of experts around health literacy and got their opinions around what we identified, and then strategies that might support improving the skills and knowledge of these clinicians around health literacy to support consumers. And so they probably gave us some ideas around what tools might be useful, but really highlighted the fact that we need to teach people around the basic principles of health literacy. We did 2 things concurrently while these other things were happening. There's sort of multi-sections to this project, but the first one was really providing these little health literacy education nuggets. And these are really practical sessions, 5 to 10 minutes around parts of health literacy. So things like, well, how do you construct an email that's really valuable? Or how do you format a patient handout? So no capitals, no justified text, really simple things that they could apply immediately to their practice. We also used the change champion. So this was one of the SPOT staff members, and they really kept health literacy at the forefront of the team meeting. So they asked about what went well, what didn't go well, what's happened, and what came from this was like, oh, I got a poor email, it wasn't that great, and it was hard to read. And so by using a change champion, it was really valuable in them understanding what health literacy was, but also continuing to keep people engaged. From there, we had a co-design workshop, and that's a co-design workshop with the SPOT team. And so we recognised really on that in order to implement and then sustain change around health literacy principles and having those skills and knowledge applied to consumers, that they really needed to be at the forefront of deciding what was done. And so in that co-design, we identified 3 key areas which were consistent with what we found in the audit and what we got from the health literacy experts that they wanted to work on. And that was emails. It's a really high volume activity that SPOT participate in that support consumers' health literacy. the use of technology to support health literacy, and also this idea of these education nuggets. So we provided them about health literacy, but how can they use that ability to provide really short chunks of information to support consumer information or consumer health literacy? And so looking at how they can do that rather than just doing a brain dump about all the knowledge they know about a particular topic. And then we started the development of a toolkit. And so this toolkit will involve those three elements, specific tools that will help support the skills and knowledge of those clinicians to then support consumers with their health literacy. And so things are like an email checklist. So that is a card that lives next to the computers of all the SPOT team members. So when they're writing a really long email, they can look at it and go, well, actually, that might be too long. And is my subject line really appropriate? And is it dot point? Does that make me accountable? What will they do about this conversation? What will I do next? Other things like really practical templates. So they often have to provide information about how you get a referral into QSIS or into the spinal outreach team. And so that is written with health literacy principles. It can be modified, but it's a really clear starting point to support someone's health literacy or a consumer's health literacy, or being able to read it and digest it and understand it. And then really practical things like, how do you create a hyperlink in an email or in a Word document? Rather than just saying, oh, this is the link, and it's got this very long link, you can include it. And that's really just helps with readability of sentences, makes the email shorter, easily understood, more digestible. So what have we learned? We learned that the education nuggets were actually gold. They were really valuable to staff. They help staff, we have this idea of health literacy being about an individual problem, but how that they can interact with that and how they can change that. And they were really, really important to keep staff engaged. I talked about how valuable a change champion was in this. And so when we think about what it's like or what's needed to create behavior, we talk about capability, opportunity, and motivation. And so the nuggets speak to capability, and then the opportunity is around having a change champion and time to talk about that. And the motivation we talked about in our co-design workshop about, well, what is our motivation to actually sustain this change? And that is why the implementation of this is incredibly important for sustainability. And so we're using a Paris framework to help us do that. And we'll see the effect of that as we go. And I guess part of those strategies that change champion will slowly pull out. So they're going to do weekly sessions, and then as we progress, they'll do less, maybe fortnightly, maybe monthly. And so we can see, well, what is the change? And if it's not sustainable, well, why not? How do we change our implementation? Because we talk about this as a feasibility study. So where to next? So we've got ongoing toolkit development of those other two areas. So looking at tech and how sport clinicians can provide education nuggets to consumers about particular topics rather than just a brain dump of everything they know. Ongoing change champion check-ins, review and refine the toolkit. So as we get feedback based on those co-design sessions, we'll change things, adapt things. It's really important that this is for the SPOT team. It's bespoke to what they need in their workflow, not just what's worked for everybody. And then we'll evaluate it. And that's evaluation of things like skills and knowledge of those clinicians, but also a process evaluation. So how do we implement it? What went well? What didn't go well? Was it really hard work for the clinicians, or actually was it really smooth? Then the next thing to do is identify some new rehab teams that want to do the process again with us after we've refined it. And we've already had some interest from some rehab teams. So hopefully we'll be able to redo this, improve it, and be able to really increase the skills and knowledge of rehab clinicians across Queensland around how to support clinicians so that they understand their care. Thanks.
Thanks so much, Susie. I think we'd all like to see that toolkit, and there's a lot that we could learn. Does anyone have any questions for Susie? Health literacy toolkits? No, I think everyone's wanting afternoon tea soon, but we have two fabulous speakers before you get that opportunity. Thanks so much, Susie. So I'd now like to welcome to the stage Melissa Kendall. And Melissa's going to talk about something that I have to say is a real passion project for Melissa. It's been a long time in the making. So Melissa is leading a seed grant on friendships and social connection, and she's going to share the findings of phase 1 of her seed grant.
Thank you, everybody, and for your attention while you're flagging, waiting for afternoon tea. As Tamara said, this is a very, very dear project of mine, leading on from my PhD many years ago, looking at friendship and social connection for people with spinal cord injury and acquired brain injury across the rehabilitation continuum. So right from when they first have their injury right through to the rest of their life, basically. And the title is for my presentation today is actually based on a quote that came from one of my participants who said, "Keeping and maintaining friendships are pivotal. They are absolutely necessary to live in society. We're social beings. We are not islands." And that participant knows who they are. So the purpose of my project overall is to co-design a translational framework of feasible and sustainable strategies for change to support friendships. And the words feasible and sustainable are really key to what I'm talking about. So I'm talking about things that can be implemented in practice on a daily basis that don't cost a lot of money, don't use a lot of resources, but they're things that staff can do. So the bigger picture is this is a 3-phase project. We have phase 1, which is an exploratory phase involving focus groups and interviews. Phase 2 is an Delphi survey where it's a consensus phase where we're aiming to drill down on what the strategies could be to implement. And phase 3 will be an evaluative phase looking at piloting the framework. So today I'm reporting on phase 1 and the findings of that. So we did focus groups and interviews either in person, by telephone, or by video conference using Microsoft Teams with 50 people. So 6 people with ABI and 11 people with spinal cord injury, 3 family members and a friend of people with ABI, 15 staff from the brain injury rehab service continuum. So that was across the continuum. And 14 Queensland spinal cord injury staff. So that is a lot of interviews and focus groups. And what we found, the factors that were affecting friendships that were identified included things like who I am, so who the person is, was an aspect of people, who we are, who the friendship is, what we know, so our health literacy and understanding, where we are, so at the environment around us and the things that are affecting us, when they are affecting us, and who helps us. So things about our rehabilitation practice that affect the friendships. And I'm going to go into these in a little bit more depth. I'm not going to read all the quotes because I only have 7 minutes. So I'll let you look at them, and the presentation, I am assured, will be available later. So things about who I am. So people spoke about injury-related impairments, so how the injury had changed the person, whether that be physically or cognitively. Things about the person themselves, their demographics, so their age, their gender, the stage they were in their life, their geography, so whether they lived in a rural setting and were now in hospital in a metropolitan setting, and all their friends were still in that other setting, their priorities, so what people were prioritising in their life at the time. And as you can imagine, when you have an injury, your priorities centre around the injury and are not of a lot of other things, but also their identity, so who they were as a person now and how that had changed since their injury. So that's very important, but when we're talking about friendships, we're talking about 2 people, not just one. And so who we are was seen as very important. What was our friendship like prior to the injury? So were we close friends? Were we just acquaintances? What are our prior and present roles? So what did we used to do together before? Was it your mates that you went surfing with, or was it your girlfriend that you had coffee with? And what can you still do with that person now? What does that friendship involve? It was about the capacity of friends. Everybody has their own lives, so the capacity of the friend to be involved in the rehabilitation journey, whether they were motivated to do that, their motivation to be involved, and the different levels of separation that the friendship experienced, whether that was geographic because they were separated, or interaction, they couldn't interact in the same way that they did previously, or that they just didn't feel like they were the same person, and therefore their interests were different now. Also, what came about was what we know, and people spoke about health literacy and understanding, but they spoke about it in two contexts. They spoke about it in the context of the injury itself, but also in terms of understanding the importance of that friendship going forward, of friendships to their recovery journey. So that was for the person with the injury themselves. That was for family understanding the impact of injury and friendships, the friends themselves, but also rehabilitation staff and supports, so community supports as well, things like support workers. Where we are, and people spoke about the way the hospital environment is not conducive to friendships, the lack of privacy in rooms or private spaces to meet with friends, the confronting nature of that. But they also spoke about this in the community environment as well, things with transport not being available to increase access, or funding supports not being available in the community to focus on friendships. How support workers could support or hinder that friendship journey, or the attainment of new friendships. And equally, family as well could do that. In terms of the hospital, processes and policies in place, things like visiting hours, things like how staff focused on friendships, whether they even asked the question, their capacity to do so, so the staffing and the workload of staff to add one more thing to the list of things to consider in the rehab journey, and what priorities were in that. As you'll read from that quote, that says it perfectly. What we put first and what we don't. And when. So timing after injury was really important. It was not only about the time since the injury, but it was that individual's journey in their timing of their own adjustment to their injury, how ready they were to take things on, how their functional stability, their cognitive stability, and recognising that that was different for everybody, and people need to choose when they address something, when it was right for them. So our interviews and focus groups didn't just focus on what were the factors that were affecting friendships, they also focused on what strategies can we implement to improve this in our practice. I'm not going to go through all these strategies in detail, but this figure just sort of outlines where they focus. So education awareness raising on injury and friendship was really important, and that was focused on the people components. It was focused on who I am, who we are, what we know. And that was for all different parties, so staff, family, friends, the person with the injury, support workers, funding bodies, etc. And on the other side of the thing, when we look at the environmental factors, it was making the implicit explicit. When we talked about what strategies had been implemented, staff would say, oh yes, I did something this time and I did something that time, but there was nothing explicit in protocols to say this should be considered. So it was very ad hoc in how things had been done. So making those protocols, making the implicit explicit, and putting it into a handover, into discharge summaries, into documentation, creating a supportive milieu. So trying to make those spaces better for people, creating that private space for friends to have a conversation in a ward environment, etc. Building the helpers. So all the other people that can support that. For instance, creating champions amongst staff. So staff that were specialised in assisting friendships, or family facilitators that could be the conduit of information between the person and their friends. And then getting the timing right. So making sure that that was done when that was appropriate for the individual and the friend. So the way forward from this, and the reason why I didn't go into a lot of those strategies in detail is that that is part of phase 2 of the project, is that we are doing a eDelphi survey to develop and refine those strategies. That involves 2 rounds and it's currently underway. We are in round 1 at the moment and we're up to about 70 participants at the moment. So hoping to get to 100 and have had really, really good participation from people with brain injury and hoping to build our participation for people with spinal cord injury. Of course, I haven't done this on my own. I have a team that helps me with this right across the continuum of both BIRS and QSIS. So thank you to all of them. And thank you for your time.
Thank you so much, Melissa. It's such a lovely, important project. Do we have any questions for Melissa? No? Okay, well, thank you. And I'll now invite our final speaker up for this afternoon's session before afternoon tea. So if we can have Dr. Karen Washer return to the stage. And speaking of passion projects, I think this one is definitely the case for Karen. Karen's going to share an update on translating and implementing the early ABI VOC rehab framework in Queensland.
Thanks, Tamara. All right, this one then afternoon tea, everybody. It's a pleasure to be here today to present on this work we've been doing in the ABI Transitional Rehab Service and really progressing this work beyond our initial workshops to a statewide level. And this work has been funded through a NISQ research and education grant. I'd like to recognise this huge, amazing, brilliant team up there, our clinicians, our researchers, our clinicians who presented in our translation workshops, and also thank our expert advisory panel who were wonderful to work with. So some of this you might have heard us present on before. We have previously undertaken work to build capacity around delivering VOC rehab rehabilitation. And this grant let us develop this further and deliver this across Queensland. Our aims were to develop the capacity of rehab clinicians, so our NISQ providers, from metropolitan, regional and rural areas across Queensland, and build this capacity and the ability to deliver structured, evidence-based vocational rehab, particularly that which was developed around our VOC rehab framework. We did this through developing my words don't work. We did this through delivering a previously developed 2-part workshop series. Our first workshop is an education-based workshop where we provide education and training on our framework. We provide the tools we use to do that in practice at ABI TRS and discuss case studies and have really good clinical discussion. Our second workshop is a translation and implementation workshop where we use implementation science principles to support our clinicians to develop a personalised implementation plan for their workplace to take and put into clinical practice. The lovely hidden bits were our new elements that we added. So we added an online version of this workshop that we created and piloted, and we added some post-workshop supports to further aid that translation and implementation. These are our key outcomes we were aiming to deliver. So deliver our workshop series, develop and pilot the online version, and then evaluate these learnings and keep in mind, what does that look like compared to the first series we did back in 2022? So we've successfully delivered some workshops, a series in Townsville and a series in Brisbane late last year. And this cohort was provided with group-based post-workshop supports for 3 months. Earlier this year in April, we delivered our online workshop series successfully, which was great. And we tried a hybrid model of supports, which involved individualised and group-based supports. It was a really popular workshop. We had over 75 EOIs for the limited places we could offer. We trained 50 clinicians across the course of these 3 workshops, half from Brisbane and then a lovely mix of our regional colleagues and for people from metropolitan coastal areas. And around 30% of our attendees participated in those post-workshop supports. For our evaluation, and I'll just go through a few of our findings, we did some quantitative and qualitative investigations through pre and post surveys. Quantitatively, we used a 5-point Likert rating scale where people rated against our learning outcome questions. We're presenting that percentage who rated they agreed or strongly agreed with those statements, which let us know, are we meeting those outcomes? We also look at that individual change between pre and post. So are people's learning changing across those objectives? And for our open-ended survey questions, we did a basic content analysis. And we analysed our data separately, our in-person data and our online data, and found it was very comparable. So we've been able to combine that today for reporting. Okay, it's a terrible slide, I know, but what we can see on the left are our questions. These address our learning outcomes. Then we've got 3 columns of big numbers having our pre-workshop agreement and strongly agree, our post, and then that positive change at an individual level. Some key things to highlight would be that the people we were training and people who attended our workshops were clinicians who were experienced in ABI rehab and had knowledge confidence in this area. Even so, they made some really lovely individual gains across those areas. This cohort was less experienced and had less knowledge, understanding and confidence in delivering VOC rehab in this cohort and had really nice changes and improvements again post-workshop. And then this just shows that for the remainder of our learning objectives and workshop 1 aims, we were meeting those through our online and in-person workshops. Our participants reported they found workshop 1 was beneficial, it was relevant and useful, it enhanced their skills and confidence and had good resources, and they were happy with the instructors. Qualitatively, the most valuable and interesting components people reported to be from workshop 1, our implementation manual and the contents that gave them things they could use in practice, and information on the framework itself and its structure. And overall, our participants indicated their expectations were being met through these workshops. Other identified needs included having more time and then some very specific requests for slightly out of scope information. For our workshop 2, so our implementation workshop, again, we're having some really high levels of knowledge and confidence for most of our learning goals post-workshop and good change. Some key areas to highlight is that with our workshop 2, people could compare their practice with our VOC rehab framework and identify what was same, what was different. They could identify components that would translate to their clinical practice. And if we look down the bottom, we could see that they were confident to plan and apply that into the real world and had actually commenced a plan for that, an implementation plan. And that second line up just shows that pre-post confidence in delivering VOC rehab. So even that implementation session had some nice changes there. Again, our participants found this training would benefit themselves, it was relevant, it was useful, it enhanced some skills, and they quite liked the implementation science model. Qualitatively, those valuable and interesting components included the specific implementation science tools that we use to do our workshop with and their use and application to practice. The workshop activities themselves, where we get people to work through and plan out implementation. And people also reported, which I didn't expect, the structure and format of the workshop and the presentations. And the majority were feeling that their expectations were met by the workshop. Nothing particular was missing, but again, people wanted more time and just identified across both our workshops, there's this need for more basic clinical information and education on how to undertake vocational rehab, just as a general comment from our participants, which wasn't the aim of what we were targeting, unfortunately. Our other outcomes, we were successfully over time able to modify and develop our workshop for online delivery to a smaller cohort though than in-person workshops. Operationally, we finally made this work through much trial and error and use of multiple systems. And we delivered this successfully and used the technology available to deliver this. A positive experience was higher than I anticipated it would be with our workshops online. So the negative experiences for workshop 2 were mostly around the heaviness of that content in an online format and people wanting more time than a tech-based issue. So we've successfully trained a good range of clinicians across Queensland and increased their knowledge, skills and confidence. We've provided them with a range of resources, tools, research articles and helped foster clinical networks so people can continue to support each other in delivering this work. And I think most excitingly that we're able to bring the work we do in VOC Rehab and that ethos of a team-based approach beyond and out of ABITRS and into other workplaces across the state, which is really exciting. So I'd just like to acknowledge our funders and all the people who've supported this and been involved with the project along the way. Thank you.
Thank you very much to Karen and the team for that lovely implementation focused work and excellent training outcomes. Well, boy, I think everyone has earned this afternoon tea, but particularly our speakers. So if I could ask you all to join me in thanking all of the speakers from this session. We have afternoon tea for 20 minutes. So if you could please be back just before 4 o'clock. And then we have a short session to finish the day of stimulating 3-minute lightning talks. So that'll keep everyone awake. Thanks, everyone. Enjoy your afternoon tea.
Hello, is anyone able to hear me at all? Anyone from the tech team able to hear? Sorry, none of the participants, sorry. Thank you.
Welcome back, everyone. This is the hardest break to get people back in from, I think. So I hope you enjoyed it. We have a fairly brief final session for you, which I think your attention spans will appreciate. So we have our session on lightning talks, which we're calling Bold Ideas and Better Solutions starting now. So we're about to showcase 8 projects that are just on the cusp of starting, and they're new projects either related to our seed grant scheme, so people that were awarded seed grants in the Hopkins seed grant round earlier this year, as well as PhD research that's just emerging. So I would like to welcome to the stage Hannah Simmons as our first presenter, and Hannah's going to share an overview of her PhD research, which is on leisure and recreation in the built environment for people with disability. Welcome, Hannah.
Thank you. So yeah, my name's Hannah Simmons, and I'm just going to do a brief talk on my PhD, Social Inclusion Outcomes for People with a Disability in Leisure Environments. Also, I forgot to put my supervisors' names on the PowerPoint slide, so just know that I'm working with Professor Louise Gustafson, Associate Professor Paul Harris, and Dr. Kim Walder. I'm so sorry. I wanted to start this talk, next slide, please. I wanted to start this talk off by talking a little bit about my disability and my lived experience. So I was hit by a car when I was 3 years old and suffered a C7 spinal cord injury, which left me unable to walk, with limited hand function and incontinence issues. I was very lucky to have a family that was very supportive, who made sure that I went to a school that was not made for special needs, and that we were able to get out and about as much as possible in areas that were accessible, getting to be in all parts of life. However, as I grew up into a teenager and eventual young adult, it became apparent to me, as even though I was becoming more independent using public transport and going to university by myself, there were so many places and spaces that I would try to access with my friends that I could not get to. That were built for young adults. Next slide, please. So because of this, this is what has driven my PhD. So my project aims to look at people between the ages of 18 and 34, to look at what barriers and enablers there are in environments that are made for leisure. This includes going out to restaurants and cafes and things with friends and family, going to, festivals, shops, anything like that. So my 3 research questions are, in what environments are people with a disability engaging in leisure, and/or what environments do people with a disability want the choice and opportunity to access for leisure activities? What are the barriers and enablers for people with a disability engaging in a leisure setting? And how do these impact the individual's social inclusion? And how does inclusion impact personal identity and participation in leisure and socialization? So to answer these questions, next slide, please. I will be breaking up my PhD into 2 study phases. Phase 1, due to the lack of research within this area, we first need to do a national survey to begin to understand what kind of spaces people are already accessing and what barriers and enablers are currently there. So to do this, we've put together a couple of surveys that have already been used within research, so have been psychometrically tested, and that includes the Community Participations Indicator and the Craig Hospital Inventory of Environmental Factors. Both of these will ask people what barriers and enablers they have come across in the spaces they have used in the last 3 months of their life, and how they feel in those environments, whether they feel included or not. Next slide, please. Then from this data that we collect, the second phase will involve online focus groups of up to 36 people with a lived experience of disability. And the questions that will be asked in that will hopefully outline experiences of participating in leisure-built environments, perceived impact of barriers and enablers in leisure-built environments on social inclusion, self-identity and variability in enjoyment and pleasure, and perceived access to choice of leisure for social inclusion. Yeah, that's basically it.
so much, Hannah. We look forward to hearing about your PhD progress, and Hannah's supported by a Hopkins Centre scholarship as well. If I could now welcome, please, Dr. Evgenia Zakharova-Luneva to the stage to provide us with an overview of her recently awarded C grant. And accompanying Evgenia is Darren Myers, so they'll be co-presenting. Thanks, Evgenia.
Thanks everyone for having us. We'd like to introduce our research looking at post-flap complications in people with spinal cord injury who have complex pressure injuries. And I'd like to ask Darren to introduce the background to our topic for us.
Okay, traumatic spinal injury is a confronting and discombobulating experience. It obliterates what was your every aspiration for life and requires you to completely reimagine your future. It affects all aspects of your quality of life, from your relationships, your social mobility, your employment prospects, your housing requirements, community access. You also require lifelong personal care and has lifelong health implications. At higher levels of spinal injury, you have reduced lung capacity, your autonomic functions are compromised, your bone health is affected, and generally because of a lack of a feeling below the lesion of injury, your skin health is of critical importance. A lack of mobility and capacity for positional changes means you have increased risk of pressure injury. Pressure injuries are a common complication of spinal cord injury, require long periods of bed rest. This has mental health implications, financial implications, and requires increased care. In severe cases of pressure injury, you require hospital admission and surgery. There's a 40% complication rate in that form of procedure. Post-surgery is a minimum of 4 weeks complete bed rest and a 2 to 3 month transition to sitting. This can be really confining and mentally challenging. In my own case, I was a country boy from the Atherton Tablelands, brought up in the back blocks of the Northern Territory, the Gulf of Carpentaria. I was into horses and cattle and working on cattle stations and all sorts of things. I was going to be a tradesman. I left school in grade 16, studying at TAFE. I dived off a rope swing into the Barron River, hit a sandbar, hyperextended my neck forward, compressed the spinal cord, and was instantly paralysed, become a C4 quadriplegic. It's no barrier to a full and comprehensive life. I went back to high school, completed senior, went on to university, completed postgraduate study, worked as an academic in 30 years as a CPA qualified accountant. After 38 years of spinal injury, I incurred my first pressure injury as a result of a byproduct of osteomyelitis in my left heel, an allergic reaction to vancomycin, which induced a DRESS syndrome or red man syndrome, put on 11 kilos of fluid, required a number of blood transfusions. Once these issues were resolved, my skin was very fragile. I ended up with a 5 centimetre deep pressure wound near my sacrum. This required 2 years of bed rest. And when I eventually had surgery, my hospital admission stay ended up being 9 months, which is twice what would be the benchmark for this type of procedure.
So Darren's case really highlights the difficult journeys that these patients go through, and it's led us to doing this research project with the aims of improving the processes of people requiring this flap surgery through our spinal injuries unit, looking at delivering better care with fewer complications and reduced time in hospital. And so we want to do this by identifying the factors that contribute to complications following flap surgery and look at how our complication rates in SRU compare to those reported in the literature. We want to also gain insights into the lived experience of those people who have had flap complications and also the clinical experience of health professionals who manage them to develop a framework to strategy build and develop outcomes. And we want to do that by developing a clinical pathway for our unit to improve future practices. So what we'll be doing is conducting a scoping review of published and grey literature, and also a retrospective chart audit for the last 9 years of patients who have undergone flap surgery, looking at what our complication rates are and possible contributory factors of those. We'll also be doing focus groups or semi-structured interviews with recent inpatients who have had complications following their flap surgery, as well as with specialist clinicians who manage those patients, and looking at teasing out the causation of those complications and strategies for prevention and management. And we'll use all of that information to develop a clinical pathway in consultation with people with lived experience, as well as specialist MDT clinicians. So we're very lucky to have obtained a CGRUD through Hopkins team. We have a fabulous research team, including experienced clinicians from QSIS, experienced researchers through Hopkins, and we're very lucky to have Darren as our consumer researcher. So our project is just taking off, and look out for results mid next year.
Thank you so much, Evgenia and Darren. It's a really exciting project. I look forward to hearing how it progresses. Okay, if I could now welcome Matt McShane back to the stage. Very active participant today, Matt. We really appreciate it. You're now going to provide an overview of your seed grant entitled Design Cafe. Thanks so much, Matt. Of course. Oh, microphone.
Yep. Cool. I'm going to talk about my seed grant called the Design Cafe. I'll get through. Next. So the Design Cafe is about promoting co-design solutions to assist with everyday tasks and challenges for people with disability. We often see like there's a lot of effort put into high-tech assistive technology, and there's a subset of technology that often slips through the cracks for people with disability. Next. Cool. This type of technology that falls through the cracks is often like, it's kind of hard to explain it. It's small, low cost things that might enhance someone's life, but isn't off the shelf or isn't sort of readily known. So what we're doing is we're bringing people with a disability into an environment with clinicians, OTs, designers, anyone that can sort of help, and we're focusing on how we can enhance their lives or their challenges as collaborative as possibly. So it's no secret that people with a disability are the original life hackers, and this is just a perfect example of those Ozo thick grip things that are everywhere. Like, they were designed by ends up being the wife of the husband of the company, even though she did all the work. But and then next one, and then the classic zip tie, 4 zips, and these are the type of hacks that people with disability just do every day, and we're trying to figure out a way we can make them better and more accessible. So this is how it started. A friend of mine, Ryan, was losing every week at his poker night and thought he needed some help because he couldn't quite hold the cards, so he's blaming it on that. But we came up with a quick and easy solution that's no new technology or anything. It's something that's been done forever with creative OTs and parents and teachers and whoever else can hack these ideas. But what we did is we made it more personal with Ryan and made it to suit his grip and how he wanted to sort of position the card. So this was a super low cost and quick fix that we did for him. So we've run this through a course already at Griffith, and as well as just some weekend warrior little activities. So here's a few examples that we've come up with. A drone attachment for someone that needed a bit of a thicker grip, and it was it was the size and color and everything that he wanted, and it gave the user real ownership of his product and how he wanted to use it. The other ones are a paintbrush holder and a thumb loop for an iPhone cord. And then the protein shaker was the big one for me, where a friend of mine could do every stage of having a protein shake except for shaking it. So he could fill it up, close the lid, open it, drink it, but he couldn't shake it. So this was this one little step within the process that he needed a little bit more help with, and a personal solution achieved that for him. So main aims and objectives is to find out what co-design of this type of AT is going to look like. We want it to dictate every iteration of it. So we want to find out what it looks like and feels like from everyone involved. And then if we need to make changes because it's missing the mark somewhere, then we're gonna pivot and change it to make sure everyone's feeling as included and valued within the process. We're trying to promote inclusive design of these types of daily activities and occupations for the user. And the big one will be to complete a process evaluation of how a project or a program like this might look within a community setting, what pieces we need to be able to pull something like this off, and who needs to be involved and who doesn't need to be involved maybe. So yeah, as well as empowering people with a disability to collaborate with some of this AT. Yeah, that's it. That's a little table tennis racket for Emily. But yeah. And we've got a great team of people from Griffith University, Hopkins Centre, Spinal Life have been very good to jump on board, and we're excited to work with everyone. Cool.
Tremendous. Thank you. Thank you very much, Matt. Really appreciate that overview, and good luck to you and your team in progressing. If I could now invite Kelly Walsh to the stage. Oh, no, we have a very interesting take on Kelly Walsh. We have Michael Dean instead. Tremendous. So Michael's going to represent his team to share an overview of their seed grant on interdisciplinary pain management.
Thanks, Tamara. Indeed, I'm here representing Kelly, who's our lead researcher on this project. Our team's listed up there. So our fantastic physio team and superb psychology team are leading the project. Nick and I are also involved, as well as Tamara and Michelle and Karime from UQ. And Fifth Levin is our consumer on the project, who's also a previous patient of ours. Really excited to have her on board. So interdisciplinary pain management programs, as well as a mouthful, they happen in all pain clinics across the country. So usually they're a group format. So they're running groups, they're run on an outpatient basis. So people come in for the groups maybe 1 or 2 times a week. So that the intensity does vary, and it's usually a therapist-led program whereby the therapist leads the group of patients, varying therapists lead the group of patients through the process of understanding pain better and developing skills to help to manage that pain. And these programs are pretty much the gold standard for pain rehabilitation practice. What we know from the research is that these interdisciplinary pain management programs seem to work. So there's evidence of their efficacy and effectiveness. Patients seem to like them and they're satisfied with them. What we don't know is what people actually learn from them. So what do they take away from each session? What are the sticky bits that they take away that really sort of seem to help them to move forward? So here in our clinic in the Metro South Pain Rehab Centre, we run a group called the Engage Group. It's a low intensity group, 5 weekly sessions. We phone the patients at week 6 to look at a plan moving forward and try to find out where they want to head into the future. It's primarily a physio and psych led, with a little bit of me included in the group. And the focus is around helping people to understand what's going on, so that pain science education within an acceptance and commitment therapy framework, looking at grading their activity, managing flare-ups, and goal setting. So what we are really wanting to know is, if you come to our group, what do you learn and what do you do differently? And we want some specifics from the patients in terms of what's helping you to move forward in life. So the aims of our research are to explore the knowledge that people acquire during and what they retain after the Engage program, and to explore experiences and self-reported changes, their beliefs and their behaviours, both during and after the program. Our secondary aim is to use this information collected during this initial phase to develop a more person-centred interdisciplinary pain management program so that we can implement better practice in our clinic. So the design, as I mentioned, it's a two-phase process. So initially we'll run focus groups and do phone interviews. We're aiming for 20 participants and we're anticipating that'll be 4 to 5 groups of the Engage program. We'll get a phone call prior to just to sort of get an understanding of what their understanding of pain and pain management practice is prior to the group. And then after each of the sessions, after each of the five weeks of the program, they'll sort of stay behind and participate in those focus groups. And then we'll do a phone call 4 to 6 weeks after that. Those groups will be audio recorded and transcribed, and we'll use reflexive thematic analysis as per Braun and Clark in their 6-phase process. Phase 2 will be the co-design workshop. So that's whereby we'll have 5 or 6 consumers who have participated in the Engage program and 5 or 6 staff from Metro South. And it's a single workshop, and we'll sort of use the information we've gathered through those focus groups and the phone interviews to look at how can we do stuff better? How can we really make some of these points stickier? And how do we help people to move forward? In terms of the participants, so there'll be patients who are coming to the Engage group, so willing to attend the clinic once a week for 5 weeks to attend a group-based program, and then they'll stay back for the focus group after that. They'll also be willing to participate in the telephone interviews prior and post, and if they don't want to do that, they can't. Cheers, mate. So our progress so far is that we have ethics through, yay. And we're not too far off, fingers crossed, getting the SSA and all the contracts signed. We are hopeful for a November kickoff for our first programs. So fingers crossed this goes well and we can get it started. So when we're thinking about this, in developing a project, we looked at that Lao Tzu quote from many, many years ago, obviously 700 BC. Go to the people, work with them, learn from them, respect them, start with what they know, build with what they have, and when the work is done, the task is accomplished, the people say we've done this ourselves. So really wanting to sort of focus on our patients who are attending and really that ownership sort of perspective and really get them to sort of be involved in developing our new programs. And we thank Hopkins for our seed grant.
Thanks very much, Michael and the team. What a great quote to finish with. I'd now like to welcome Caitlin Spalding, who is leading another seed grant at the Hopkins Centre with a focus on how and why patients modify their rooms in inpatient rehabilitation. Oh, co-presenting. Oh, tremendous. And we also have Hannah co-presenting. Yeah, perfect. Thanks, ladies.
All right. Hi everyone, I'm Caitlin and this is my colleague Hannah. We're part of a wonderful team who were very privileged to get a seed grant, exploring if, how and why patients modify and personalise their rooms in inpatient neuro rehabilitation environments. So recovering from neurotrauma can involve weeks and months in specialised hospital settings, most of which patients spend in their rooms. So healthcare environments largely prioritise safety and efficiency, often neglecting user needs and experiences. In rich environments, which is the development of settings that may facilitate environment engagement, can positively affect mood, anxiety and depression after neurotrauma.
Yeah, so from a lived experience perspective, current adult hospital environments do not offer much enrichment. The use of personalisation within a room is one way to provide this need, encouraging some positive feeling to an otherwise difficult situation. The lack of enriching spaces within adult hospitals is especially apparent for those with a lived experience who have transitioned from the children's hospital setting. As you can see, this is my room when I was in hospital for a few months, and I had everything there. But yeah, colorful spaces are inviting and are encouraged to reduce anxiety and depression for children.
So the aims of our project is to explore if, how, and why inpatients in neuro rehab environments personalise or modify their environments, and also to understand the effect that this personalisation and modification on the inpatient environment has on the patient experience.
This research will partner with Griffith University and the Hopkins Centre with clinician researchers from the Gold Coast University Hospital and Logan Hospital, building upon and extending existing relations while also building clinician research capacity. This project will be mixed methods in design using a one-time interview and observation methodologies with up to 40 inpatients. We intend to gain a representative snapshot of inpatient experiences across 2 neurorehabilitation sites, the GCUH Neurosciences Rehabilitation Unit and Logan Hospital Ward 2Q. The framework method for qualitative analysis will be used to support multidisciplinary collaboration.
So here's a little outline of our project. As you can see, we're sitting in that first stage. We have our ethics and we're finalising all of our governance and documents. Huge shout out to Chelsea Marsh, who has really spearheaded that component. It's we all know, a complex process. So well done, Chelsea, thank you. And so hopefully we should be getting onto that next stage very soon, fingers crossed. So outcomes and impact, we are hoping that the knowledge generated from this project will contribute to valuable insights into the relationship between inpatient neuro environments, neuro rehab environments, and the patient experience to foster those supportive healthcare spaces. We're hoping there's opportunity for immediate translation into practice through the development of end user guidelines for clinicians and patients and their families, which we're hoping can be scalable across multiple sites, and as well as informing future co-design interventions using personalised, enriched environments in the rehab space. Thanks very much.
Thank you very much, Caitlin and Hannah. Tremendous to see you doing that research across 2 sites and you're tracking well time-wise, so that's fantastic. Okay, so we're now moving on and I would like to welcome Tennille Hodson, who's going to talk to us about the Robin smart device application and her seed grant that she's leading.
Okay, hello everyone. So I am presenting this project on behalf of a group of researchers, and it's very much representing a partnership between Griffith University and also members from the Metro South Health. And also we have a person with lived experience of an acquired brain injury on our team as well. So a bit of background, this is the second phase of a program of research. So I thought I'd go back to where it all started. So this research came about because we know that people with acquired brain injury experience difficulties when they return home after hospital rehabilitation, even though they may have made a large amount of progress whilst in hospital. This is because the hospital environment is built to be quite safe and we can't always predict the things that are going to occur at home. We thought that technology might help in addressing some of the issues or preparing people. And we were initially interested or thought this might go down the route of augmented or virtual reality. So we then ran a series of co-design workshops last year. These involved people with acquired brain injury as well as health professionals with experience with working with people with acquired brain injury and also technology developers. And so there was a few things that we wanted to achieve in these co-design workshops. We really wanted to see what were the needs, what were the challenges that people experienced as they returned home from inpatient rehabilitation. Then we wanted to look at some solutions for that and how technology could possibly help. What came out of that was some priorities, which can be seen on the slide, but people want to access education resources. They wanted to know who their support team was. They wanted to share a bit about themselves before ABI. They wanted to use the technology to set goals and to help them develop their plans. Notably, when it came to what kind of technology would you like to use with this, it wasn't augmented or virtual reality. It was actually, they wanted to use it in a smart device application. So that's part of the fun of co-design, is it shows us things that we wouldn't predict, which is great. So we were able to have some prototypes developed. Now, these are wireframes, which means that you can kind of see what an app would look like, but it's not very usable, so you can't really play with it. So there was 2 different prototypes that were developed from that phase. So that was the outcome. So what this seed grant is looking to achieve is we want to take one of the prototypes that were developed from the previous phase and actually make it into something that's workable. So we have engaged some app developers with experience in developing health apps. And they're going to help us develop some prototypes based on the findings of the previous phase. We're then going to have a co-design workshop where the initial prototypes by these app developers are presented. We get some feedback before they then develop the app and finalize it. After that, it will be to a stage where we can trial it clinically and look at the feasibility and usability of the app. I'm going to do a shameless plug and say that we are going to be doing a workshop, a co-design workshop soon. And if you are interested, please reach out. I'll be advertising it everywhere. I'll be here afterwards. So there are all my information. Thank you so much.
Thanks very much, Janelle and team. We all like a shameless plug. Okay, moving on, we now have Jake Bennett, who is going to represent the team led by Emily Bray, and this seed grant is on sleep disturbance after spinal cord injury.
Beautiful, thank you everyone. So I'll get my jets on. Beautiful, so my name is Jake Bennett and I'm one of the senior research assistants currently working on a project looking at sleep disturbances following spinal cord injury, understanding help-seeking behaviour and co-designing a sleep management resource. The principal investigators on the project are Dr. Emily Bray, Dr. Jessie Mitchell, Associate Professor Melissa Kendall, and Mr. Ross Duncan from Spinal Life Australia, alongside a team of associate investigators. So sleep disturbances are one of the top 5 secondary health problems of a spinal cord injury. Some of the types include trouble falling asleep and sleep-disordered breathing, such as obstructive sleep apnea. Some causes may include muscle spasms, pain, and temperature dysregulation, and impacts can be reduced emotional, physical, and cognitive well-being as well. So sleep issues following spinal cord injury are common. In a community survey of 82 people, we found that 86% indicated that they experienced sleep disturbance, and 47% haven't sought treatment for their sleep disturbance, while 25% have sought treatment but reported that it did not seem to help. In a subsequent survey, we then found that 35% of people did not know that their sleep disturbances could be related to their spinal cord injury, while 16% did not know where to seek help for their sleep disturbance. So knowing the emotional well-being and quality of life impact of a sleep disturbance, but little research which has investigated on the prevalence and characteristics, we wanted to get a better understanding of some sleep interventions tailored to the needs and preferences of people with a spinal cord injury, and some of the help-seeking behaviours of people, so the reasons why they do or do not seek help or treatment. So we have 2 primary research questions. What are the help-seeking behaviours? And 2, what resources would best support people with SCI to manage the sleep disturbances? So to do this, we're starting with a needs identification interview, which will be semi-structured with 12 people living with a spinal cord injury. And the purpose of this is to explore the lived experience of sleep disturbance following a spinal cord injury and also get an understanding of their help-seeking behaviours to identify the unmet needs and review some of the existing solutions. The first 6 people who take part in the needs identification interview will then participate in a solution ideation workshop alongside 6 clinicians who work primarily with people with spinal cord injury to brainstorm solutions to unmet sleep support needs to develop an initial sleep management resource. A follow-up solution refinement workshop will then be conducted with the last 6 people from the needs identification interview alongside 6 new clinicians to refine the novel sleep management resource further. So our expected outcomes include an increased understanding of sleep management needs and preferences, getting some of the insights into the help-seeking behaviours of people with a spinal cord injury, and also get an improved understanding of what enables people with a spinal cord injury to seek support for their sleep management needs. We're currently finalising the ethics and governance process. We have our literature review and finding available sleep resources ongoing, and we've currently got a draft completed of our workshop presentation and resources, whilst also being in the early recruitment stages of our interviews, and we're looking forward to the remainder of the project. Thank you very much.
Thanks so much, Jake. We're very lucky to have you on the project. Okay, so now I understand there's been a slight change. So if I could please ask Isaac Hollins to come to the stage. You might remember that we have someone at home looking after sick children. So Stacey James can't be here, but we're delighted that Isaac can to provide an overview of the C grant on navigating rail transport after acquired brain injury.
That was very impressive how much information you could have. So this research is primarily about rail transport, making rail transport more neuro-inclusive and accessible for populace with impaired cognitive functioning. And when I tell like colleagues and friends about this research, they always kind of have the same facial expression. They scrunch it up and like, how do you research something like that? And that just because there's so many uncontrollable parameters in a train station, and would it not be more relevant to research homes or rehabilitation facilities? And there are many parameters to consider in a train station. There is light, sound, other people, access, and there's also so many variables in people. Every cognitive impairment is different and every trip is different for each type of outing. For instance, for me personally, each outing success depends significantly on whether I've had enough to eat or not. I am curious about this area of study because my background as an architect and lived experience with an acquired brain injury. This study on train accessibility is very relevant to recovering from an ABI, as it is an important step in establishing your independence. Often patients return home from hospital and cannot drive for years. Public transport is their only option for independence. I personally found it intimidating and exhausting catching trains while I was recovering, and that limited my ability to engage in activities away from home. From an architectural perspective, train stations are a great preliminary study into neuro-inclusive architecture, as there is a very specific function to the building that requires it to be used in a particular way. This makes it easier to test if each process performed within the architecture can be used as intended. Rail accessibility for impaired cognitive function is a relatively new area of study and required a method of study that captures the full broad spectrum of variables. This study will include walk-along interviews with current clients of acquired brain injury transitional rehabilitation service whilst undertaking a journey from one station to another. During the trip, we will be paying attention to the challenges encountered and how the design of the train station's environments influences the experience. In the project team, we have people from a variety of disciplines. With the group from the Hopkins Centre, we have Louise Bathingwhite running the study and doing all the heavy lifting with Louise Gaddisford. and Kelsey Chapman and Carol Gillett. We have clinicians from TRS, Mandy Nielsen, Karen Water as part of the advisory board, and Stacey James running the walk-along interviews. We also have Tanya Koloshenko, an architect from Hassel, who has previously and is currently designing train stations in Queensland. She will be joining us after the preliminary data analysis to assist in translating the study to implement in future stations. And so an update with where we are at now. We have our ethics and SSA approvals from Metro South Health and Griffith University. We have also completed our phase 1 focus group. This was a discussion with experienced clinicians who work with patients recovering from ABIs and have first-hand knowledge of some of the enablers and barriers that patients may encounter when using trains. In addition to the focus group, we have conducted a preliminary practice walk-along interview to identify points of interest for specific conditions in each train station. We are now just about ready to commence data collection in the interviews with a few details to be finalised. So thank you to our sponsors and everyone here.
Thank you so much, Isaac. Well, that team, I tell you what, they've hit the ground running. They're going at a cracking pace. Look forward to the next update. Well, we've reached that moment, guys. We are up to the final speaker, but we did not leave. We're not going to leave on a down note because we have Kelly Clancy coming to the stage now, who always brings the energy of the room right up. So wonderful to bring us home, Kelly, providing an overview of the final C grant on co-producing resources for clinicians in the spinal cord injury.
Okay. Hello, everyone. I am going to use the last couple of minutes of this conference to talk about co-producing resources for clinicians and people with spinal cord injury in Queensland. I'm presenting on behalf of our research team, but specifically Dr. Kelsey Chapman, who is currently in South Africa accepting an Inclusive Health Research Award for her fantastic work for the Dignity Project. So we're very proud of her. For those of you who know me, know why I've been put in the last time slot. I may not be a particularly good public speaker, but I am a fast one. So we will go. So ensuring access to information about health systems and service delivery is pivotal for people with newly acquired spinal cord injuries and their support networks, particularly when this information is presented in a personally relevant and accessible format. Data from a series of studies conducted by researchers in our team with rehab patients and clinical staff highlighted the need for improved access to information, increased family engagement, and greater options for self-advocacy, choice, and control. This research identified a scarcity of contemporary, fully accessible, co-designed resources for patients. Specifically, there are very few orientation resources co-designed by patients, supporters, and clinicians, not only within the Spinal Cord Injury Service, which is our primary collaborator on this project, but across various healthcare settings and different patient populations. From the presentations that we've heard here today, we can readily acknowledge the potential of co-design to enhance collaborative decision-making and improve service design and delivery. Consequently, our project has 3 key objectives. We will identify essential patient and family information needs and preferences. Secondly, we will collaboratively co-design an orientation resource with patients, clinicians, and support networks. And finally, we will develop a comprehensive how-to kit, ensuring that our co-design processes can be replicated. We have a 3-phase research design. Our pre-design builds on our preliminary pilot data and includes semi-structured interviews where participants will be asked to identify the types of information that should be included in the orientation resource, the timing of the resource delivery, and also the preferred delivery method. Our co-design phase is divided into 2 workshops. Workshop 1 will aim to achieve a consensus regarding the resource content and its requirements. In the second workshop, we'll evaluate the assembled content and also validate our design process. Our post-design phase includes a 2-level evaluation. Firstly, we'll use validated measures and interviews to evaluate the acceptability and the utility of our resources. And then finally, we'll document the steps, the barriers, and enablers of the co-design process.
We would like to achieve two key outcomes in this project. Firstly, we would like to provide accessible and relevant information to enhance the dignity and autonomy of patients during their rehabilitation journey. Secondly, we would like to develop a how-to toolkit to increase capacity for the development of similar resources, but also to contribute to the wider co-design field. As Tamara mentioned, our research is supported by a recent seed grant, so we would like to acknowledge the funding body, the Motor Accident Insurance Commission, for this grant. If there are any questions regarding this research project, I'm more than happy to write them down, and I will ask Kelsey when she returns. Thank you for your time.
Tremendous. Thank you so much, Kelly. I knew you wouldn't let me down with your energy levels. Well, we have now reached the end of the formal part of the program in terms of presentations, but it's not over yet. We have a very exciting session next, and I would like to ask Tim Geraghty to come back to close the conference, but also to announce some very special awards. Thank you, Tim.
Thanks, Tamara. Is this microphone working? Yes. Okay, thanks everyone for making it to this point. I did warn you at the beginning that it was a jam-packed program, but it's been a wonderful day. You can probably officially turn your thinking brains off now. Just keep your clapping hands engaged. And we have some important awards to announce as we do every year. I'd also like to invite Matthew Ames, who many of you will know, who's a member of the Metro South Board, who's going to help me present the awards today. Thanks, Matthew, and thanks for coming along. Actually, coincidentally, Elizabeth Kendall and I presented an update on Hopkins Centre yesterday to the Metro South Board. So Matthew was chairing that meeting, so it was a great opportunity to update the board on how Hopkins has been going. And we will have you out of the room in under 15 minutes, I hope. Okay, let's get straight to it. So there are a number of awards that we'd like to give out today. And the first one is the Early Career Researcher Award. So this award is for outstanding achievement for an early career researcher in contributions to advancing the Hopkins Centre research programs and reputation as a leading disability and rehabilitation research centre. So our award winner today is Sam Borg. Sam exemplifies the centre values, working tirelessly in contributing to advancing Hopkins research, particularly in the areas of Trace 1 and Trace 2 and the Osinski research program. And most recently, she's been doing that while completing her PhD. And she's had to put up with working for me for most of the time she's been in Hopkins. Congratulations, Sam.
Thank you.
Matthew's got your... Great. Thanks, Sam. Okay, moving right along, the Citizen Research Award. This award recognises, sorry, the awardee is Hannah Simmons. This award recognises Hannah's outstanding contributions to citizen research, including her own PhD and research engagement with Hopkins. It acknowledges her hard work, research and advocacy for citizen research, working collaboratively to ensure research is meaningful, inclusive, relevant and informed. Congratulations, Hannah. You want me to take that? I'll hold it up in the middle. Great, thanks, Anna. Okay, next is the Emerging Researcher Award, and this award goes to Louise Bathingthwaite. So this award recognises Louise's excellent progress and outcomes of her PhD, as well as new initiatives she's leading with the Hopkins Centre related to driving and community access. Louise can't be with us today, but we will make sure that she gets the award. Okay, next award category is Research Champion. And we have 2 awardees in this category. The first is Dr. Kylie Ferguson, who's staff specialist in BIRU. So this award recognises Kylie's incredible efforts and enthusiasm, which has been crucial in supporting participant screening and recruitment from BIRU as part of the TRACE3 research program in 2023 and 2024. And I don't think Kylie's here as either at the moment, so we'll pass that on to her. And the second research champion is Kelly Clancy. Recognising Kelly's incredible mentorship and support of other researchers within the Hopkins Centre for many years. Congratulations, Kelly. Thanks, Kelly. Okay. So last 2 awards. So the next award is, I think this is the first year I think we've had this award. So the Research Team Award. And the Research Team Award this year. Sorry. Right. Okay, take 2. Sustained Contribution Award. We've definitely had this award before. This award recognises the recipient's long-standing leadership and contribution to research focused on improving access to rehabilitation, peer support, long-term community outcomes for people with acquired brain injury. And it goes to Dr. Ben Turner. Most people probably know that we recently lost Ben. I probably shouldn't say it like that. Ben moved on from his long role with ABIOS and is working as a lecturer at Sunshine Coast University Hospital, Sunshine Coast University. And but we have maintained connections with Ben by making him accept an adjunct position, and he's continuing to work with us on research already, and I'm sure that will continue. But thank you, Ben, for your long contribution to Hopkins and to brain injury research, even before Hopkins. Great, thank you. Okay, going back then to the final award, the Research Team Award. And the Research Team Award this year goes to the team from the Pain Rehabilitation Centre at Metro South. So I've got a list of names here that I'll read out, but I suspect that there are other people as well. So Nick Aitchison, Michael Dean, Kristen Tyne and Kelly Walsh, Liam Jensen and others. And The team award recognises the Pain Rehab Centre's outstanding contribution and commitment to capacity building of clinicians and great progress in advancing a research agenda focused on improving consumer experiences and outcomes of pain rehabilitation services. I think those of you who've been coming to BIBS for a while will have seen that this year there's been an increasing involvement and content from the pain team, and they have been working really hard to get the research in the centre going, which is fantastic. Well-deserved award. Thanks, guys. Okay, we really are in the final stretch now. Thank you all for coming today. I'd particularly like to thank Michaela Kerr and all of her team who have done an amazing job, again, organising these events. It takes a huge amount of time and effort, and as we know, often you have professional conference organisers who do this kind of work, and Michaela and the team do it in-house and do it just as well, if not better, than professional people, but it is a huge time commitment. So thanks, Michaela, and thanks everyone. And particular thanks also to the Auslan team. I think it's the first year that we've had them, and that's been a fantastic addition, I think, to the symposium as well. So thank you guys very much. I'd like to thank my Hopkins executive team, Elizabeth Kendall, Tamara Owensworth, Louise Gustafsson, who've been an incredible help to me as I've settled into my role as director over the last 6 months, and to all the research fellows and research assistants at Hopkins who have also assisted greatly. So thank you all, and thank you for your great contributions to today, either as chairs or speakers. Again, thank you to Motor Accident Insurance Commission as our major funder, Metro South Health, Griffith University, NISQ, and our other partners. I'd like to thank all of the presenters today. They've done a great job at presenting fantastic information and also keeping to time, which is always helpful. And finally, to everyone in the room, particularly people who've stuck it out till the end and also online, we continue to think that having the symposium as a in-person and virtual event is important. Again, adds another layer of logistics, but I think it really adds value to the symposium. So, thank you all for making it another great day, and we look forward to seeing you in 2025.